We are live. So we are live.
Welcome to the 5th Global Neuro-Ophthalmology Case Festival 2025. It is an absolute pleasure to greet each of you as we come together once again for this inspiring celebration of knowledge, collaboration, and clinical curiosity. Over the next 2 days, on the 6th and 7th of December, we embark on yet another enlightening journey through the fascinating world of neuro-ophthalmology. As we gather amid the festive season, a time filled with weddings, celebrations, and the anticipation of the approaching new year, this festival offers its own kind of joy, the joy of shared learning and professional camaraderie. Much like the season around us, it's a time for reflection, renewal, and looking forward with a spirit of optimism and creativity. In this fifth edition, we also stand at a remarkable junction in medicine. Artificial intelligence has quietly yet profoundly woven itself into our daily clinical practice, whether in pattern recognition on imaging, diagnostic predictions, or clinical decision support. Yet, as we embrace these technological companions, we remain the final masters, the discerning minds who interpret, contextualize, and transform data into meaningful care for our patients. It is precisely this human insight, the art beyond the algorithm, that brings us together today to discuss some of the most extraordinary neuro-ophthalmology cases from across the globe. Over these 2 days, 6 distinguished moderators and presenters will lead us through engaging discussions that challenge our thinking and deepen our clinical perspectives. We encourage you to participate actively, share your thoughts in the chat, and make this festival as lively and interactive as possible. As we immerse ourselves in 2 evenings of science, dialogue, and friendship, may this gathering continue to embody the essence of what makes neuro-ophthalmology such a unique, stimulating field, a perfect blend of logic, observation, and wonder. Here's to the 5th Global Neuro-Ophthalmology Case Festival, to learning, laughter, and lasting connections. Let the festival begin. And I would like to start by introducing to you my co-host, Dr. Shikha Basi, who is the director of the Neuro-Ophthalmology Department at Shankar Nethralaya, Chennai, India. She is on the editorial board of the Indian Journal of Neuro-Ophthalmology. Her topics of interest are optical coherence tomography in neuro-ophthalmology, optic neuritis, and idiopathic intracranial hypertension. Next, I'd like to introduce Dr. Ambika Selvakumar, who is a senior consultant in the same department at Shankar Nethralaya, Chennai, India. Her areas of interest are optic neuritis, seromarkers, demyelination, ocular myasthenia gravis, mitochondrial optic neuropathies, LHON, and neuroimaging. She is also the Vice President of the Indian Neuro-Ophthalmology Society. She has authored the Atlas of Neuro-Ophthalmology and the Atlas of Neuroimaging in Ophthalmology. She's been an invited speaker in many national and international ophthalmology, neurology, and neurosurgical conferences. She's on the editorial board of IJO, JNO, and Frontiers of Neurology and Ophthalmology. She is going to moderate the first session in today's program. The panelists in the first session are Dr. Astha Kapila, who is an additional professor in the Department of Neurology in PGIMR, Chandigarh, India. She has been convener Neuro-Ophthalmology subsection, Indian Academy of Neurology, an assistant editor in the Annals of Indian Academy of Neurology, Her fields of interest are neuro-ophthalmology, neuroimmunology, and neuro-oncology. She has more than 120 publications in peer-reviewed national and international journals and 11 book chapters. Next, we have Dr. Veena Norona. She's a consultant radiologist in VRR Scan, Chennai, India, and also visiting Shankar Nethralaya, Chennai, India. She is a speaker at state and national ophthalmology conferences and state-level radiology conferences. She is a co-author of the book Atlas of Imaging and Ophthalmology, which I mentioned earlier, and she has chapters in ophthalmology, radiology, and neurosurgery books. Next, we have Dr. Padmavati Maharajan, who is a chief of the Neuro-Ophthalmic Services and a regional HR director at Arvind Eye Hospital, Tirunelveli, Tamil Nadu, India. Her areas of interest are disc edema, supranuclear palsies, and OCT and neuro-ophthalmology. I would like to now hand over to Ambika to start the session.
Thank you, Satya, for this wonderful introduction of this 2 days wonderful program on neuro-ophthalmology cases. I think our session 1 speakers, let me introduce in one go. We are having 6 wonderful speakers across the globe. And to begin with, let me also introduce the person, the sheet anchor of this 2 days program. Bye. So to begin with, Dr. Satyakarna, the main person behind this wonderful collaboration of Neuro-Ophthalmic Case Festival. He's a director of ophthalmology, neuro-ophthalmology, and cataract refractive surgeon practicing in Delhi at Karna Eye Clinic, as well as Max Hospital, Noida. And his areas of interest are teaching basics of neuro-ophthalmology and neuroimaging. And he has authored Shankar Nethralaya Atlas of Neuro-Ophthalmology, both the editions, and he was the Joint Secretary of INOS in 2018 to 23, and he's also a specialty reviewer of IJO. And the next speaker is Dr. Helen Danish-Meyer. She's the first female professor of ophthalmology in New Zealand, who has the Sir William Lady Stevenson's Chair in Ophthalmology and Head of Academic Neuro-Ophthalmology and Glaucoma. She's the youngest professor of the University of Auckland Faculty of Medical Sciences. She's the international representative on the American Board of Basic and Clinical Science course for the neuro-ophthalmology, and she has also served as an examiner of the RANSCO examinations. She's on the Executive Advisory Committee for the World Glaucoma Association. She's also presently the chair of Women in Ophthalmology for RANSCO. She's published more than 200 papers in glaucoma and neuro-ophthalmology and authored several textbooks. She's the only New Zealand ophthalmologist who have been awarded the Paul Harris Award by Rotary for her service to the community. Her clinical expertise includes imaging modalities in neuro-ophthalmology, giant cell arteritis, ischemic optic neuropathies, role of astrocytes in optic neuropathies, and glaucomatous optic neuropathy. Thank you, Helen, for joining. And we next have Dr. Umapati Thirugnanam, who is a senior professor and a wonderful teacher from Singapore. He's a professor in Duke's NUS and NUS YLL School of Medicine. He's the chief medical officer visiting Al-Hadi Neuromuscular Center, Iraq. And I think he's zooming right now from Iraq to us. And he's a visiting consultant in most of the senior institutions in India. And he has special interest in neuromuscular diseases, neuro-ophthalmology, otology, and practices medicine in resource-limited services. So Dr. Hazel Lind, she's a senior consultant at Eye and Retina Surgeons, visiting senior consultant at NUH Singapore. And she's completed her residency fellowship training at NUH Singapore, and she practices neuro-ophthalmology in Singapore. Thank you, Hazel, for joining. And we have a wonderful clinician from Hong Kong, Dr. Carmen Chen, who is the Chief of Service Consultant Ophthalmologist of Hong Kong Eye Hospital. She's a clinical professor and in the Department of Ophthalmology, Visual Sciences, and the Chinese University of Hong Kong. She's also the honorary clinical professor of Hong Kong University. Dr. Chan did her medicine at the University of Cambridge as a Prince Philip Scholar and trained in ophthalmology in UK and Hong Kong. followed by the Neuro-Ophthalmology Fellowship with Dr. Neil Miller at Wilmer Eye Institute, USA. She's published over 80 peer-reviewed papers and served as a journal editorial board in many prestigious journals, including the JNO Neuro-Ophthalmology and the BJO. She's the founding convener of the Hong Kong Neuro-Ophthalmology Interest Group, and she has received multiple APAO awards, including the Senior Achievement Award in 2024, and was named among the top 100 ophthalmologists in Asia-Pacific region. And we have with us Dr. Luciano. She's a senior consultant neuro-ophthalmologist from Buenos Aires, Argentina. She's currently into private practice, and she has done international observership in neurology and neuro-ophthalmology at Moorfield Eye Hospital and St. Thomas Hospital, London, UK. And she's the reviewer of neuro-ophthalmology papers of Argentinian Council of Ophthalmology, and she's an international fellow of NANOS. And the last speaker is Dr. Almela. Dr. Almela is a senior consultant ophthalmologist at the Department of Ophthalmology, Baskent University, Faculty of Medicine, Ankara, Turkey. She has completed her fellowship in ocular oncology at the University of Michigan, Kellogg Eye Center. Her clinical research interest includes neuro-ophthalmology, uveitis, and ocular oncology, with a particular interest on inflammatory and neoplastic eye diseases. It's indeed a pleasure to introduce all the 6 wonderful international speakers in session 1. And with this, I stop sharing and I would hand over to the first speaker, Dr. Helen, who is joining to us from Australia. Dr. Helen, over to you.
Thank you, Dr. Ambika and Dr. Satya, for the kind invitation to be with you. I would like to start with a case, the blotch that launched 1,000 questions. So this was an 82-year-old gentleman who was actually referred to me by my medical retina colleague who operates down the road. He presented with a sudden onset of a central scotoma in his right eye. He had noticed a dark spot in the middle of his vision. This was 2 days before he presented. His past medical history was of hypertension and elevated cholesterol. He had no review of histories, no family history, and his review of systems was unremarkable except for a few night sweats that he had started to experience. Other than that, it was a negative for the usual questions for giant cell. On examination, his vision was 618 on the right, 66 on the left. Color plate was 4 out of 14 on the right and 14 out of 14 on the left. And there was no relative afferent pupillary defect reported. With my retinal colleague, when she saw him, when I saw him, he was dilated. Pressures were fine, and the slit lamp examination was unremarkable. So these are his optic nerve appearance in the 2 eyes. There is no evidence of any swelling. And otherwise, the nerves were relatively unremarkable at this view. If we look at a broader picture, stepping out a bit, you can see that the retinal vasculature looks okay. There was a little bit of haziness in the right, over the right macula, but very difficult on the photos to identify anything particular that was going on. This is the autofluorescence in the 2 eyes, and equally it was nothing too dramatic noticed on the autofluorescence. This was the visual field that was done because he complained of a central scotoma. 10-2 visual field test was done in the right eye, and you can see there was a general decrease sensitivity in the central scotoma, and there were some mild fixation losses that were present. This is the right OCT scan of the optic nerve. And the left, and you can see it's generally relatively symmetrical with no particular abnormality of the optic nerve that stands out. And this was the ganglion cell layer in the 2 eyes with the Zeiss test. The OCT of the macula, however, was a bit more interesting. The top one is of the right and the bottom one is of the left. And you can see this inner layer of middle hyperreflectivity in the middle layer of the retina. This was identified by my medical retinal colleague, and she was quite concerned because this was not, the patient was not the normal phenotype that you would normally see for this condition. Right there. So at this question, the question was, what investigations should we do? So he had some blood tests, and his ESR was 58 and his CRP was 18. His platelets were elevated, and other than that, the test results were within, his blood tests were within normal limits. He had a recent carotid artery ultrasound not too long ago, and an echo that was done within the last month as part of his normal cardiovascular workup. And these were unremarkable at that time. We, at this stage, were concerned that this may be giant cell arteritis. What concerned us about this was his high CRP and ESR. Systemically, he had some night sweats. And when we did review his retina, the findings that we see in his retina has been reported with his with giant cell arteritis, which I will come on to in a moment. The TAB was positive. Of course, we did not know that for 4 or 5 days after we had done that. So he had biopsy confirmed giant cell arteritis. Our management of patients who have visual loss with giant cell arteritis is to admit them for 3 days of high dose 1,000 milligrams of intravenous methylprednisolone, and then followed by a prednisone at 60 milligrams and a taper following. So when he was reviewed 3 weeks later, his vision had improved to 6/7.5 in that eye. And this was his follow-up OCT. So again, you can see the inflammation in the middle areas of the retina. And this had not completely resolved, but had largely resolved 3 weeks following his scan. So what diagnosis did he have? He had a diagnosis of paracentral acute middle maculopathy, or referred to as PAM. The retina people like to use abbreviations for their diseases, and his was known as PAM. So what concerned my medical retina colleague was, she says, I normally see this, but I normally see it in 50 to 60-year-olds. It's very rare in an 80-year-old, and that's why she came down the corridor and to see me. I had never seen a case of PAM associated with temporal arteritis, although I had read about others who had reported the case reports of this. So PAM typically presents as an acute paracentral scotoma. The diagnosis is made on OCT. It's a hyperreflectivity in the internuclear layer, which reflects ischemia of the intermediate and deep retinal capillary plexuses. The case reports that mention it with giant cell often have it in association with ischemic optic neuropathy, or anterior arteritic ischemic optic neuropathy, but isolated cases have also been reported. So most have had permanent visual loss when they present, and it's really the OCT that gives us the diagnosis. But it was interesting that if you just do the ganglion cell layer and the retinal nerve fiber layer, you may miss it. You actually have to look at the OCT in detail, and I look forward to the panel's comments about that. So basically, PAM reflects hypoperfusion at the level of the deep retinal capillary plexuses, and in giant cell may be associated with more extensive retinal infarction and worse outcomes. Ours was caught relatively early, and I think the short interval between symptoms and diagnosis and immediately starting the treatment before we waited for the temporal artery biopsy were the keys to getting the diagnosis in this case. In giant cell, again, it may be associated with CRAO, but it's also been associated with other retinal vasculitides as well, and other vascular diseases of the retina. So with that, I would like to hear the panel's questions and comments. Thank you.
Thank you, Helen.
So thank you.
Yes, Satya.
Yes, thanks. So Helen, this patient did not have RAPD, so we are reasonably sure that Helen, am I
I think
heard?
there is, yeah, now you are.
No, we missed you before.
Yes.
Now
Yes.
you
Am I
are.
audible? Okay. Okay. So Helen,
Yes,
can you
now
hear
I
me that
can.
this patient did not, this patient did
No.
not have RAPD. So which means that we rule out optic neuropathy.
Yes, that's correct. I mean, the patient did not have an RAPD. I have to say it was not an RAPD seen by the medical retina specialist. So whether there was a small RAPD or not, it's hard to know. But certainly did not have a decent size RAPD, and that would be consistent with a macular problem. That if the RAPD was there, it would have been very, very small and negligible. The optic nerve function was fine. The color vision was down, which was the only unusual atypical case. Some of the other cases of PAM have reported decreased color vision, but often they have an associated optic nerve involvement as well. So that was a little bit unusual, but macular diseases can cause decreased color vision, but I wouldn't have expected to be so far down. So that's why I wonder whether there was the beginning of an optic nerve problem or not. We don't know, but that is the interesting things. What are your thoughts, Dr. Sataya, on whether the color vision suggests an occult optic nerve problem?
So I think that since the patient had no symptoms except blurring of vision, and the clinical examination was normal except for the findings on OCT,
Yes.
it would have been very difficult to even think of this entity. So how did you arrive at this entity? What made you think of this?
Well, the patient actually was seen by my medical retina colleague. So because they had a blurring of vision, they actually, we're in a big group practice. So the patient came into one of the general ophthalmologists and explained of a central scotoma, a certain blind spot. So the general ophthalmologist took the patient down the corridor to the medical retina specialist. The medical retina specialist examined, and of course, they do an OCT on everyone. So it was fortuitous that they did the high 21 raster OCT through the macula. Having said that, the patient complained of a very discrete central scotoma. And I think that if a patient complains of a discrete central scotoma, an OCT 21 raster is an appropriate investigation, along with the 10-2. So I think that was the appropriate investigation to do, to see if there was a central serous retinopathy or any other cause of macular abnormality when it was such a central scotoma the patient was complaining of. So this is a condition commonly seen by the medical retina specialist, so they're aware of it. But I think what made my medical retina specialist very sharp is that she said it's unusual in this age group. So it's unusual in an 80-year-old. She said we normally see it in 50 to 60-year-olds. So then she was thinking, what else could it be? And of course, neuro-ophthalmologists, we always get the mysteries. So then she walked it further down to the corridor to me and said, Helen, can you come see what you think it could be if it's not a classic isolated PAM without any other causes?
I just have one question
Right.
to you, Dr. Helen.
Yes.
So do we have features like AMN, which is being confused because an acute macular neuroretinopathy, what they say in the 50s, that also has this type of ischemic central zone involvement. Only thing is your patient age group is slightly elderly, so you had a tag of giant cell arteritis suspicion. Probably the same patient in 50s, we would not even have thought of a GCA in that.
Probably not even the 50s, maybe not even 10 years ago. You know, don't have to go back to the 50s to do that. It is, you know, most of the case reports are in the last 3 to 4 years that have been associated with this. I think this is a very discrete inner middle macular lesion. Now, if we had an OCTA, that would have helped differentiate these conditions because it would have shown a lack of flow to the middle and deep plexus. Very discreetly, the superficial plexus would have been fine. The choroid and deeper layers would have been fine. So an OCTA would have been very helpful in this case.
Yeah, so when the patient can't see and the doctor can't see anything on the fundus, usually the next investigation we resort to is the fluorescein angiography. So was that thought about?
Well, we didn't think it was necessary because the OCT was so classic. So the retina specialist said this is a very classic OCT diagnosis. The fluorescein does not change the diagnosis one way or the other. It wasn't going to help or differentiate for us. We were going to do the temporal artery biopsy anyway, and we were going to treat them with steroids until the biopsy came back anyway. So because it wasn't going to change our management, we didn't do a fluorescein.
Okay, so and then coming to the understanding that it was a case of giant cell arteritis,
Yes.
would it be justified to start the high dose prednisolone immediately, even before doing any other tests?
Yes, I always do. If I think of giant cell arteritis, I start the steroids and then take the appropriate tests that were done because I think that you really do need to protect the risk of visual loss, you know, which could proceed not just in the one eye, but in the second eye. And everyone in this panel would have seen vision loss from delayed diagnosis in giant cells. So not something that I want to happen on my watch. Yeah.
Yeah, so as we can see, subsequently, the investigations did not add anything to the diagnosis except the biopsy, which
Yes.
cannot be done quickly. So it took some time to get the
A
biopsy done.
week.
In the meanwhile,
That's right.
you started steroids. Yeah. So I
That's
think
right.
your management was excellent and you got good results, I believe.
Yes, it's the one time, you know, it's sometimes we make a diagnosis, and I was wondering sometimes when I make a diagnosis of PION or choroidal ischemia, have I missed PAM? You know, with my giant cell patients. And sometimes we
Yes.
make a diagnosis of choroidal ischemia and then you treat them and they actually improve. And you think, actually, maybe they had PAM because the PAM they improved in this case. While we rarely see improvement with arteritic cause and even with PION, rarely with giant cells. So I wonder whether I've missed a few in the past because I haven't been aware of the diagnosis.
Yes, you're right there. We might have missed such conditions in the
Yeah.
past. Only with
Yeah.
the help of advanced OCTs, we are able to detect these new entities.
That's right.
Even in the present, is there any timeline where the OCT changes will resolve before the patient comes to you? The hyperreflective band, what you're saying? Because if the patient comes 3 weeks or 4 weeks later, we may miss it.
Yes, we may miss it. We definitely could miss it. I think if it was giant cell, I suspect they would have gone on to have other symptoms if they were not treated. So they may start with a blurred patch and then end up with an arteritic anterior ischemic optic neuropathy or CRAO or something else subsequently. I would be surprised if giant cell stopped at PAM, but
Yes.
but I think if it was an isolated PAM, we may miss it. That's right.
Yes. Thank you. That was a wonderful case.
Thank you.
Thank you.
Thank you, Dr. Helen and Dr. Satya. I think we will move on to the next speaker, Professor Umapati Tirunyanam. He's going to talk on the where and what we see. Over to you, Dr. Uma. So you're muted.
So, I just wanted to start off by thanking Dr. Satya and his team for inviting me. Just a quick disclosure that the Wi-Fi, although I'm only about 50 kilometers away from, as I was joking just now, the seat of civilization, a city called Babylon, but things have degenerated since the beginning of Sumeria. So now the Wi-Fi is not so good, and my resident, Dr. Ahmed here, is kindly standing next to me with his data on his phone. So if I look a bit Parkinsonian, please wave so that I can reset the computer and try to get the videos to play. Okay, so whenever a patient comes to me and with visual blurring, and when I teach my residents, I ask them to ask these basic questions, whether it's a monocular, binocular problem. And if it's if it's binocular, then the next question is the vision improving with the closure of one eye? Now, if the vision problem appears to remain with closure of either eye, then we know it's a visual field problem. And one of the important visual fields that as neurologists we need to be aware of is the homonymous visual field. And whenever we see a homonymous visual field, there's only two possibilities that we need to think about. Isolated occipital lobe lesion or something more anteriorly in the temporoparietal lesion. And to differentiate between the two, you just need to go on to do a full neurological exam, specifically things like weakness, numbness, dysphagia, and neglect, because the presence of these findings would suggest that the lesion is not in the occipital lobe, where the pathology is often isolated to the visual fields, but in the temporoparietal lesion. So with that, let me introduce you to this patient that some of you may have seen before. So his problem is an acute onset of left upper quadrant tonopia. So as I mentioned before, because it's homonymous, the deficits could be a right occipital lobe lesion or right temporal lobe lesion, because it's upper, so it's more likely to be temporal. To differentiate between the two, we did a full neurological exam. He had no weakness, no numbness, no dysarthria, no dysphagia. But when I give him this white stick, which is of course the tendon hammer, and ask him to find the central point of this stick, let's see what he does. You can see that he is cutting of this line, the so-called blind bisection, is clearly biased towards the right. That tells us that his whirl is now truncated to the right side of the fields. So even though he's got a left quadrant deficit, if it is a lesion is in the occipital lobe, the patient will be able to readjust and find the center of the stick. The fact that he's so biased to the right suggests that in addition to the visual field, he has left-sided neglect. So this told us that the pathology must be in the temporal lobe, and as you can see, there is a hemorrhagic infarct in the temporal lobe in this patient. But then I was then called to see the patient again because the physiotherapist and the occupational therapist were upset at the amount of deficit this patient seems to have. They were aware that he had a mild neglect. They were aware that he had a quadrant deficit only, but he had a lot of difficulties with activities of daily living and also other tasks, because as a construction worker, he had to get back to manual work. So we were trying to do some work hardening, that's a form of rehab to improve his employability. And the occupational therapist was having a lot of problems. So she wanted me to reassess this patient. So I came to him and I showed him this very classic neuropsychiatric diagram that everyone is familiar with. But I think with the modern age, to be politically correct, I think there's a lot of sex gender bias in this picture. So the modern version of this picture, as advocated by the academic organizations, is that a picture like this on the left-hand side, where the man is doing all the washing and the woman is doing more manual work. But I think I would like to contend that there is also a problem with this picture. It's very culturally out of context. So we in the global south wouldn't understand what is lawn mowing and many of the things that are seen in this picture, which seems to be monochrome in color. All the characters are of the same color. So I would like to propose that we use the picture more relevant to us, where the man is drinking whiskey and watching cricket. The woman is, of course, slaving over the fire. And of course, the neglected children are in the danger of falling into the well. So we hope to validate this soon and then use this because this is culturally more contextual. for the rest of the world. But unfortunately, until we get that, we have to use this picture. So for those of you who are enlightened enough to know Tamil in the audience, will be able to appreciate what this gentleman is saying. But for the rest of you, unfortunate souls, I have to translate into the more common imperialist language, which is English. Okay, so he looks at the picture and he says there are lines. These lines, this is lines. I asked him, what is
போட்டிருக்க லைன் என்ன
I said, what is those lines make up? He says, those are just lines. What am I supposed to say about that?
வேற
And he says,
கீழ
a
வந்து
round thing
ரவுண்ட் போட்டு வச்சிருக்கீங்க
on the table.
This is a round object, but doesn't recognize it.
I said, what object it is? He says it's a round thing that you put on the table, on top. But he doesn't know what it is.
தட்டு சாப்பிடுற தட்டு
அதான் ஏதோ வைக்கிற ஜாமான்
Because he neglects everything on the left. We already knew that. And then when you ask him to look at further parts of the picture, he describes geometrical figures, but he's not able to figure out what these objects are.
இது வந்து முக்கோணம் போட்டு இருக்குது
This is square there.
Another square.
கீழ வந்து இது வந்து
But he doesn't say that's a cabinet. He doesn't say water that's overflowing.
Looks like a
No,
building. He says.
essentially, he seems to have a problem with object recognition. To validate this, we often use diagrams like this, where all of you in the audience should be able to recognize the picture in spite of the clutter. But let's see what he does. These the geometric figures again, the lines,
இங்க கூட
the semicircular arcs, but he's not able to figure out the umbrella.
நடுக்கோட்டு ஒரு கம்பி வச்சிருக்கோம்
தெரியும் கூட எங்க இருக்கு
இந்த
காட்டுங்க
தான் இருக்கு இந்த
ஆ?
Even when I tell him it's an umbrella, he's not able to
ஒரு கம்பி
recognize
ரெண்டு கம்பி மூணு
the
கம்பி
umbrella.
கொடையை தவிர வேற என்ன இருக்கு
Then he looks at the
கீழ
top
வந்து இது
doesn't-
ஏறு தான் நமக்கு
not able
புடிச்சு
to
வருது
say
இல்ல
it's
அந்த
top.
கீழ வந்து இப்ப அந்த
and
நம்ம டேபிள் மாதிரி உட்கார்ந்திருப்போம்
likewise, he's struggling with it. So it's quite clear to everyone in the audience
வேற என்ன
that
தெரியும்
he sees the shapes.
வேற வந்து
He's able to
இந்த- இந்த-
recognize the
கம்பியினுடைய
geometrical
ஒயர்
figures,
கீழ வருது பாருங்க.
but is not able to understand that the object is what the object is. So basically, it's a classic disconnection syndrome. So we are able to capture the image in the occipital lobe, but the captured image must travel down the ventral stream to the seed of knowledge. The seed of knowledge is your semantic knowledge, which is stored in your temporal lobe. And if the information doesn't get to the temporal lobe, he's able to see the things, he's able to figure out the shape, but he cannot see it as an object. He can't recognize it as an object. Okay. Likewise, this lady, okay, she's quite astounding. Every time I play this video, I get goose pimples because here I'm showing her a spoon. Now, this is again another non-imperialist language. So this will be a Mandarin. So I'll again translate it for the rest of the audience. So she looks at a fork.
这是什么东西？这个是吃东西。
She says it's a spoon, sorry, not a fork. She says the spoon is meant for eating, but she just cannot figure out what it is. Remember, she's got otherwise normal comprehension. I don't know what it is, but I know it's used for
这个叫什么？
eating. And then she looks at this phone, and very interestingly, she says all these objects are the same. And in fact, the alphabet on top are the same.
好像说
In
是什
fact,
么
the
一样。
third object looks the same because the same
这个
alphabet
也
are
是，我
there.
看也是
But
一
I
样
really
一
don't
样
know
的
what
名
this
字，
object
我不会
is.
读，我懂它的。
I really don't know what this object is. And then this is the part that most of you will be bowled over because I give her an apple. She feels the apple and she doesn't know what it is.
Is it okay? No, she can
And
just
then the next
看
moment,
这是什么东
she
西？
puts the apple at her nose and shouts
苹果
out,
吃。
apple. So in other words, when she smells the apple, she's able to figure out the apple, but she couldn't figure out the apple from the shape. So in other words, her knowledge of apple is intact, but the information does not get to the visual information does not get to the semantic cortex for her to be able to appreciate the fact that it's an apple. While the sense of smell comes from the olfactory lobe to the frontal lobe to the semantic lobe, and she gets the information. Now, this is object recognition is actually a higher order recognition of objects. But if you want to go to a more primal modality, a more primal deficits, then you realize that the person, usually if it's a bilateral ventral stream problem, the patients may have something called an aperceptive agnosia. In aperceptive agnosia, they can't even appreciate the shapes. So you saw just now the two patients, right? They could appreciate the apple shape. They could appreciate the umbrella shape. They knew what the curtain had lines. They knew it's a circular thing, but they couldn't figure out it's a plate. They could figure out the geometry, but they couldn't figure out the object. That is what we call associative visual agnosia. But a more primal, a lower order agnosia is when they can't even recognize the object shapes itself. So if you give something like this, all of us will be able to figure out the triangles, the Pac-Man shapes, the inverted and the other triangles, even if they are not there. But a person with aperceptive visual agnosia will have difficulty. Now, so if aperceptive is the lowest part of agnosia, what is the highest form? Highest form is when it comes to very specific functions like facial function. Now, all of you in the audience are able to appreciate that these two pictures represents a famous personality. I don't want to risk exposing my age, so I pretend that this is way before I was born. So she is a famous personality, and you can see that a face looks about the same, right? Both the pictures look about the same. They don't look very different. But if I were to just invert the same picture, you realize that actually one of the pictures was grossly distorted. So this is the marvelous part of the whole thing. Now you are using the object recognition, the second order visual agnosia function. Now you are using the highest order facial recognition part of the brain. And therefore, immediately he knows there's something wrong with the face. So the highest form of agnosia is when it comes to recognizing faces. And that's not just for human evolution. It's also for other functions. Like, for example, farmers are able to recognize their cows. For us, they all look the same, but farmers are able to recognize. But if you want to know more about this exciting area of visual recognition and facial recognition, you have to come back for the next episode in 2026. And of course, this is a shameless pitch to Dr. Satya to make sure that he invites me next year. So please, so I'm sure the audience will be clamoring to know more about facial recognition. Okay, now that we have talked about the ventral stream, which is the what pathway, what about the dorsal stream? Dorsal stream is also very exciting because, many of you would have realized that, when we look at an object in front of us or look at the scenery in front of us, we don't have grid references, right? We don't have grid references to tell us where objects are positioned. But nevertheless, we are able to find things in space. So how do we do that? Now, if you have biomedical or mechanical engineers in your family, if you talk to them, they will say that's very difficult because this is efference control, because you don't know where to go. So how will you know where to go? So that's where the where pathway comes in. So let's listen to somebody who has a problem with the where pathway.
I cannot see things where I expect them to be.
Sorry, I think I accidentally muted him. I need to unmute him quickly because his testimony is brilliant. So sorry.
You see, I'm a touch typist. So to me, a keyboard is instinctive, and I know exactly where I'm supposed to look to find something.
Can you see it, sir?
And I'm not noticing these things there.
Are you able to see it?
We are seeing both the presentations.
Oh, I'm sorry. I'll just go back and try it again.
Yes.
See, I'm a touch typist. So to me, a keyboard is instinctive, and I know exactly where I'm supposed to look to find something. And I'm not noticing these things there.
See, these words are very precise because, he's a touch typist. He instinctively knows where to...
You see, I'm a touch typist.
Where to direct his fingers to, but he's not able to do it. And the next patient will demonstrate clearly. He's got normal visual function, but look at how he's trying to find an object in space. He looks like a blind man groping for things.
You see, I'm a touch.
You see how the patient is trying to find the thing? Now, he's got normal visual function, but he's not able to find an object in space. So you would think that he's blind. And look at him groping for it. See, it takes a while, and then finally he realizes that the object is on the other side. So there's a clumsy term, optic ataxia, but it's not really optic, it's not really ataxia, but that's the term that's used for this inability to find an object in space using your vision to direct your. So this is a classic dorsal stream function. Now, just like you direct, after you find the object, you direct your hand towards it, but you also need to find the object first. So you need to move your eye to find the object. So the ability to find the object in space is ocular praxis. When that is abnormal, we call it ocular apraxia. So in these patients, they look like they are stuck, psychic paralysis of gaze, sometimes people call it. They look like they're stuck on one object and they cannot move away from that object. So here in this video, I will tell the patient to look at the window on the left, but instead of moving and looking to the left, he will be stuck and looking at the box of biscuits in front of him.
We are telling him again to look towards the window. Instruction.
看那个窗口可以吗？看窗口。
Window is that side, sir.
看窗口，窗口在哪里？
Can't move his eyes.
在
It
哪
looks
里？
like his eyes are stuck in space. Now, so if your eyes are stuck in space, when you give them a figure like this, what's going to happen is that they're going to see the trees for the woods. In other words, they will fix on one point and they will just be stuck there. They cannot scan the image. So when they can't scan the image, they will not be able to see anything else. So for him, that this shape is only a T. You will not be able to take a step back and see the Z behind it. This image will only be a H. You will not be able to take a step behind and see the F. So this condition is called simultagnosia, the inability to see things in entirety. Okay. So when you have all these three things, classic dorsal stream pathology in the parietal lobe, usually bilateral parietal lobe problem, then we have this syndrome, classic syndrome called Bellin syndrome. So this patient has it, and he's got bilateral parietal lobe dysfunction because he's got a pathology that is relatively common nowadays called posterior cortical atrophy. Now, for the non-neurologists in the audience, now, when you have a dementing disorder, it can either start in the temporal lobe, like in Alzheimer's. It can start in the frontal lobe in the case of frontotemporal dementia. But occasionally, the cognitive failure starts in the back of the brain. When the cognitive failure fails in the back of the brain, then which type of cognition fails first? Visual cognition. So their memory remains intact, their behavior remains intact, they can do a lot of things, but their visual, the intelligence that comes from us seeing, the visual intelligence goes down. So they end up seeing neurologists or ophthalmologists because their problem seems to be starting at the back of the brain. So if the pathology is Lewy body, the pathology can be either Lewy body disease, or I'll talk to you later, sir. I'll talk to you later. Yeah. Yeah. So the pathology can be either Lewy body disease or amyloid tangles. But if it starts at the back of the brain, then the general function in terms of memory and behavior will be intact, but the visual intelligence, visual cognition fails. So visual cognition like visual agnosia, Bellin syndrome, and things of that sort. Another classic syndrome that starts at the back of the brain is the Heidenheim variant of Creutzfeldt-Jakob disease. Heidenheim variant of Creutzfeldt-Jakob disease, which unfortunately is a terrible disease that starts from the back of the brain and progresses to the rest of the brain. Okay, so today we have talked about the seeing brain, but more importantly, how the seeing brain knows what it's seeing. Okay, and using two pathologies, the ventral stream pathology, which is the agnosias, the visual agnosias, and the dorsal stream pathology like Bellin syndrome, we have illustrated how the seeing brain becomes the knowing brain. With that, I would like to thank you and make an appeal, because many of these patients' face identity was very clear. So I think none of you have facial recognition problems, and none of the audience in YouTube also have facial recognition problems. So therefore, please be aware that these patients we need to protect the privacy of these patients, because I'm sure they can be recognized. But they have been very kind enough to give us permission for their videos to be used. With that, thank you very much. Dr.
Thank you,
Satya,
sir.
and I
Dr.
need to make
Asta,
sure
your
that
comments,
name
please.
is not.
Wonderful cases, sir. I think it's a pleasure hearing to you every time we hear you. You make things so interesting that anyways, they sound extremely intriguing. Sir, I have one small input to whatever you have said. Of course, I don't have any questions because I guess you have made things so clear. However, it's often asked by the residents and specifically the ophthal ones that we don't have visual field effects when we are dealing with higher visual pathways. So when we see that the problem is in temporal lobe, we see that the problem is in parietal lobe, but still we do not get quadrant anopias like we would expect with a lesion of temporal and parietal lobe. Maybe there's a good forum to clear this out for our younger colleagues, that why these patients won't have any field effects when they are anyways having temporal parietal disorders.
Maybe I can just add one more point to what you're saying. So I always tell my residents that I always have that that picture, the cookie jar picture, and then of course in the near future we'll have the Indian man drinking whiskey and watching cricket picture. Because if you give a picture like that to ask a patient who comes to you for what looks like a visual field deficit but doesn't seem to be having any clear-cut deficit, it's good to test the intelligence, the visual intelligence. How does he use his vision? Actually, that's the best way to put it, because the brain, the easiest way to understand brain function is the brain is an intelligent organ. Okay, there's intelligence that's seated in the frontal lobe, which allows us to make right decisions. Like on a Saturday afternoon, instead of going to a party, we are sitting and watching Dr. Satya's show. Okay, that's the frontal lobe working. The temporal lobe will tell you is intelligence or knowledge. Like, for example, knowing the cranial nerve 12, which foramina do they come up from? The memory is all stored in the temporal lobe, right? But there's also a visual intelligence. So to test the visual intelligence, you just put a picture, a beautiful picture like the one that I just showed you, where there are many things going wrong, like the water is overflowing, the boy is going to drop, the cookie is going to, there's a theft of the cookie. So there's a lot of things that the person must infer from visual images. So from the way they infer, whether they see the problem, they see the criminology, they see that the boy is being a criminal and stealing the cookie, and because of that he's being punished by falling. If they come up with complex moral argument just by looking at that picture, you know that the intelligence must be intact. The visual intelligence is intact. So my suggestion is everybody should have a copy of the cookie jar thing, or the Indian man drinking whiskey and watching cricket diagram in your clinic. Whenever you see a patient that looks a bit functional, where the deficits seem out of proportion to what they are reporting, and then you test the visual intelligence.
True thing, sir. So basically, until unless we have a normal visual functions, it's very difficult to comment upon these higher visual pathways.
Yes, indeed.
So for all the younger colleagues, if there's not a problem in the Mayer's loop or the specific visual pathway which we are talking about, if there's a problem there, we don't comment upon higher visual pathways. And secondly, sir, what about, so the second case which you showed, like the balance syndrome. So do we expect a balance syndrome in a unilateral parietal stroke? Because that's the other thing. And why do we not?
It's a bit tricky. Yeah, actually, I was hoping you wouldn't ask this question, because I've got a problem. The first patient, I don't know whether you noticed, the first patient has got a severe associative visual agnosia, but his lesion is on the right temporal lobe. Yes. Okay, so my theory is that this man is a left hemisphere dominant. That's my theory. Because just to make it simple, most of these deficits are seen when the pathology is in bilateral pathology, especially the severe ones like the perceptive visual agnosias, the severe Berlin syndrome. But you need to get bilateral pathology. But you can get it in unilateral pathology in certain strategic locations. For example, visual agnosia that occurs in the left hemisphere, if it affects as the pathway, the ventral stream is going towards the temporal lobe, close to the Wernicke's area, so the semantic cortex, then there is going to be some pathology that kind of overlaps with language dysfunction. So therefore, these patients are more likely to get a visual agnosia, even with a unilateral lesion. So as a general rule, a unilateral lesion shouldn't cause it, but there are many exceptions. Even facial recognition issues, prospagnosia, which is the inability to recognize face, is classically seen in bilateral ventral stream problems, especially in the fusiform area. But we have case reports of right-sided fusiform area lesions causing significant prospagnosia. Because there's one other element that I would like to bring in, just to make sure Satya invites me next year. Another element of facial recognition is your emotion, because every time you see a face, there's an emotional quotient that is associated with that face. So if that doesn't get activated, you're not going to recognize the face. So, so therefore, facial recognition is really a higher order function, because you need to bring in connectivity to other areas like the amygdala, the hypothalamus, and and even the hippocampus for emotion. So if you see a picture of a woman as opposed to a picture of your mother, even if they look alike, your mother will evoke a different emotion, and therefore your recognition of your mother's face will be much stronger than that of a woman that looks like your mother, you know?
Absolutely, sir. I think we can listen to you for hours together, but for the moment, I think I'll shift over the mic to Dr. Ambika and Dr. Satyakarna, sir.
Thank you, Dr. Asta and Dr. Uma, for the wonderful lecture. And we will move on to the next speaker, Dr. Hazel. She's going to talk on when all the drains are blocked. Over to you, Dr. Hazel.
Thank you very much. So I'm always and firstly, I want to thank Dr. Satya and the team for inviting me back again. And just to say that it's always been very stressful going after Prof. Uma, even in Singapore. Okay, so just going to share my slides first. Okay, so today I'll be sharing a case on a young patient. And my titles are When All the Drains Are Blocked. So our patient is actually a 16-year-old Indian female, much more on the lean side, BMI under 18. And she has no known past medical history of or any medications or supplements. And actually, she first presented to the ENT team earlier this year in February with a right-sided hearing loss and pulsatile tinnitus for approximately 2 months duration. This was increasing in severity and it was really bothering her a lot. And while waiting for further investigation, she was actually started on steroids and beta-histine, but that did not improve her symptoms. What she and her parents didn't actually share with the team was that actually they had consulted a different doctor 2 months ago and had an MRI scan done elsewhere. We only received these scans fairly recently. At that point in time, the scans were done to exclude any space-occupying lesion within the IEM or anywhere near the 7 and 8 nerves in view of her symptoms. And it was reported as no mass lesion within the IEM and the CP angle, and the 7 and 8 nerve were close to the ICA on both sides. Now, this is with the benefit of hindsight, and we look more closely at the images. If you notice this number 7 figure over here on the right, as well as on the left, you can see that the one on the left is slightly smaller. Okay, so we know that the left sigmoid sinus is probably a little bit more hypoplastic. And also looking at the other cards, there were no evidence of intracranial hypertension. We'll circle back to this image later on. So a CT scan was done for her by the ENT surgeons and was found to have a right-sided sigmoid sinus diverticulum, which was it was eating into the squamous temporal bone at the retroauricular region. In addition to that, and this is a little bit more of a subtle finding, which is something I probably wouldn't be able to pick up, but thanks to our neuroradiologists who were very sharp about this. If you look at the occipital bone on the right-hand side here compared to the left-hand side, it's actually slightly thinner, which gives us now a clue that the sigmoid sinus on the left, again, is probably more hypoplastic. So in view of the findings and her symptoms, which were not resolving with any conservative treatment, she actually underwent a right sigmoid sinus obliteration surgery with bone wax in March this year, 11th of March. Surgery went well, uneventful. She was discharged home. But unfortunately, on post-op day 5, she presented to the emergency department with worsening headaches, nausea, and vomiting. The team at that point in time treated her presumably for raised intracranial pressure, and they diagnosed it as IIH, and started her on oral acetazolamide 250 milligrams twice a day, and planned for an outpatient MRI. This was the MRI done a few days later on post-op day 7. As you can see on the image on the left, it shows slight posterior flattening of both globes with protrusion of the optic nerve heads, and the optic nerve was also slightly tortuous. The figure of 7 image again on the right side now is much larger, and you can see there's a flow void with a hypodense material lodged right in the middle over here. Also, it was reported there was a mild herniation of the cerebellar tonsil, just about 0.3 millimeters below the foramen magnum, all consistent with raised intracranial pressure. So just to recap the previous scan, looking at the number 7 on the right, compared to how it is now, much larger. And now there's a large flow void hypointensity over here. Okay, and the left side still remain quite small. So the question now was, what is this? Is this a clot? Is this surgical material? And can she just be managed conservatively, or will surgical procedure be required? So at that point in time, the family were offered a lumbar puncture to firstly determine the intracranial pressure. However, the parents were not keen for any invasive procedures and opted for medical treatment first. Keeping in view a lumbar puncture is still not better. She was advised by the managing team to proceed with a CT venogram to exclude the presence of a venous sinus thrombosis. So this was done subsequently, another few days later. And as you can see, hypodense area both here, where the original sigmoid sinus diverticulum was, and where the place of the surgical site, and this extended down towards the jugular bulb as well. So this was quite consistent with actually surgical material. As if it was an acute thrombus, we would have expected this to be a bit more hyper dense in the scans in an fairly acute phase. However, so she was then referred to us finally for a review. She had no ophthalmic symptoms of any blurring, visual loss, or any diplopia. However, she still had persistent headaches, nausea, and vomiting at that point in time. Optic nerve function was good. She had normal vision, color vision, confrontational fields, pupil exam, as well as no presence of any sixth nerve palsy on clinical examination. Her anterior segment examination was normal, and in fundus examination, she had presence of bilateral disc swelling consistent with the raised intracranial pressure. These were her visual fields, and this was done in March. Slightly enlarged blind spot on the right-hand side, and probably a bit on the left with some other non-specific defects. And gross disc swelling as also documented on the OCTs. The plan for her was to be treated conservatively with oral acetazolamide, antiemetics, as well as analgesia in the meantime, to allow for further discussion on further plans for her. An interval scan was also done in the meantime to plan any timing of intervention if the family had decided on it. So this took place with a multidisciplinary team, and both conservative and surgical options were thoroughly thought through. This comprised the ENT surgeons, neurosurgeons, neurointerventionists, as well as the pediatric neurologists, and of course the ophthalmologists. The parents actually opted to hold off anticoagulation as they were more inclined to try a lumbar puncture first to determine the intracranial pressure, although all signs actually already pointed to a raised ICP. Surgically, what was considered was a reversal surgery via the same retroauricular approach, a diagnostic angiogram during the surgery itself, and keep in view a endovascular thrombectomy if there was evidence of any clot. The parents also sought another opinion externally, and another neurosurgeon suggested a more conservative approach with a serial lumbar punctures or optic nerve sheath fenestration or even shunting procedures. So while I think the parents at this point in time were more inclined for something more conservative as they were quite afraid of a repeated surgery. However, as we all know, CSF actually reaccumulates quite fast, and even a serial lumbar puncture is probably not the best case scenario for her. A repeated MRI scan, this was 2 weeks after the initial surgery, showed consistent findings of a raised intracranial pressure, and there was still a flow void on the right side. So the parents eventually opted for a lumbar puncture. Lumbar puncture was done towards the end of March, and the opening pressure was 44 cm water. The OCT RNFL prior to that was about 280 and 267 on both sides, and this reduced about 2 weeks later. However, of note, she actually had a CSF leak. And although her pressures, the ICP was getting slightly lower, she subsequently had a mild low pressure headache, and a blood patch for CSF leak was subsequently discussed. However, as they were still not keen on anything, and they said, okay, if things are getting better, she could manage with a low pressure headache. Let's just wait and see what happens. A repeat CT venogram was done in the meantime. And as you can see, there were still 2 areas of hypodensities seen all the way from the sigmoid sinus to the jugular bulb. This is comparing the previous CT that was done. And at this point, I think we're more convinced that this was definitely just surgical material because we would have expected a change in the radiographic characteristics if it was a clot. The worry was whether it was both the surgical material also causing a secondary clot on top of it, seeing that it will cause disturbances in flow in the sinuses. So the headaches actually continued to improve after her initial lumbar puncture for approximately a month. There was possibilities of a natural evolution of the right sigmoid sinus occlusion. They were hoping for spontaneous recanalization, or maybe the fallow site could spontaneously enlarge. Otherwise, there could also be retrograde flow with chronic venous hypertension. The benefits and risks for repeated surgery to reverse the initial procedure was discussed intensely with the surgical team as well as the parents, and in view of the fact that there was the best chance for long-term outcomes for this young patient. However, this was at risk of the recurrence of the initial tinnitus, which was the main reason why she had the surgery in the first place. They were not so keen on it, so they opted for conservative management. And this patient, Diamox, was subsequently taken off as well, as it was not really helping her symptoms. And also she was developing acidosis and vomiting. The peds neurologist actually recommended serial LPs to buy time for potential collaterals to form. And however, although she was maintaining quite well for about a month, early in May, she started to have recurrence of symptoms again. And we likely felt that at this point in time, the dura leak probably self-sealed. And that's what caused the pressure to raise again. So in addition, the patient also was kept on various combinations of analgesia and muscle relaxants as she was having very stiff neck at the same time. So this is a timeline of her OCTs as well as the pressures. So in March, this was approximately 10 days after her initial surgery, and it was the first of neuro-ophthalmic review. You can see that the OCT readings was about 280 and 267. LP was done, raised pressures, and this was complicated by a CSF leak. The OCTs showed a reduction in the thickness of the optic nerve head, and this was also seen clinically, and actually continued to improve over the next 4 to 6 weeks. However, over the course of about 2 to 3 days, after her review on the 2nd of May, she actually noted worsening headaches and vomiting again, and you can see that the nerve thickness again proceeded to get much thicker just a couple of days after. So this was a repeat. She was admitted then for a repeat MRI 2 days after presentation. And you can see over here, the material is still there. There's still an hypo intensity seen on the MRI scan. Repeat LPs were again done in May. So every time she repeats the LP, it gets a little bit better for a short while. And of course, as expected, her symptoms recurred. This was repeated again towards the end of May. And even with a repeat LP, as you notice, her optic nerve head thickness kept increasing. So finally, after a lot of discussion and persuasion on the medical team's part, the parents finally agreed to for her to undergo a surgical procedure in form of a lumbar peritoneal shunt. In fact, they initially wanted to still have serial LPs and asked, since it worked the first time, could we kind of leave it such that the CSF continues to leak? And of course, the team said no. So the LP shunt with adjustable strata valve was inserted in June this year. And symptoms improved pretty well over the next 6 weeks after. But in September, she actually experienced headaches again. And there's another big worry. What's happening now? She finally has a shunt in place. It was working well. What could have been the case? We were concerned about an over drainage and whether there was possibility, like in the initial presentation, of a mild herniation, or could have been an over drainage with collapse of the cerebral veins, leading to a paradoxical rise in the pressure. Parents unfortunately declined repeat imaging, so we were unable to tell what was the likely cause. However, when she went to see the neurosurgeons, they found that the valve spontaneously set to 0.5 when her initial settings was 2. And with this valve, the lower the settings, the higher the flow. So the diswelling, after being reset back to 2, had reduced and optic nerve function remained good. And every time she has a recurrence of a headache, somehow they found that the valve settings had dropped to a lower setting, which means a higher flow. So the patient eventually requested to keep it at 2.5, as this gives her the least amount of symptoms. And fortunately, at the last review of just about 2 weeks ago, nerve thickness is back to normal. She was much more comfortable with no more headaches, and her optic nerve function remains well. So in summary, my patient is a 16-year-old Indian female with a pulsatile tinnitus secondary to a right sigmoid sinus diverticulum. She underwent obliteration surgery with a bone wax via a retroauricular approach on the 21st of March this year, and unfortunately was complicated post-operatively with raised intracranial pressure, likely from surgical material within the sigmoid sinus, which was migrating down to the jugular bulb. This was also considered whether there was a sinus thrombosis at the same time, or whether it was a sinus thrombosis which should have been anticoagulated. She was initially treated with conservative management with repeated lumbar punctures and medications. However, this was not sufficient to treat her, and she eventually required a shunt procedure, which unfortunately again was complicated by spontaneous change of valve settings at least twice so far in the last 3 months. So following 2 readjustments, her optic nerve swelling has evolved, and she finally has a resolution of headaches. So for discussion, I think the few questions was in the background of sigmoid sinus hypoplasia. And of course, this is with the benefit of hindsight. Should an alternative procedure have been considered? Or will it have been reasonable to concurrently stent the left sigmoid sinus during the same procedure if they're doing it via this approach of external packing of reduction of the surgical approach with using the bone wax versus an alternative procedure such as an endovascular procedure? And apart from the LP shunt, would the VP shunt have been better at this stage? Or should she have pushed harder to have, again, to do a reversal surgery? And lastly, with worsening symptoms while the shunt is on high flow, could this be paradoxically due to a mild herniation or venous collapse and hence obstruction of outflow rather than a low pressure headache? So just to end off, actually found this paper comparing endovascular treatment versus surgical treatment in patients. And actually, interestingly, more patients underwent surgical treatment, but EVT or the endovascular treatment actually had much better results in terms of complete and partial resolution of symptoms in all their patients as compared to surgical treatment, which only had complete resolution in 77.6% compared to 85.2% in the other group. And they also had a proportion of patients, about 11.2%, with no resolution of initial symptoms at all. Significant complications only occurred in 1 patient in the EVT group, and that was a cerebellar stroke, which patient recovered from within 2 months, as compared to the surgical group, which almost 10% of complications ranging from venous thrombosis, a worsening of symptoms, or even hemorrhage and intracranial hypertension. So this is likely because during surgical exposure of the diverticulum, there's a higher risk of dural as well as vascular injury, which can lead to hemodynamic problems, bleeding, or thrombosis. And the delicate vascular wall surrounding the diverticulum, coupled with a smooth or absent bony shell, possesses a risk of bleeding during the surgical exploration. And the main reason for lack of benefit with surgical treatment of SSD sometimes is related to the inability to address the commonly associated transverse sinus stenosis. So we didn't touch upon that in this particular patient, but I think it's maybe in retrospect, it might have been better to do a CT venogram to properly assess all the venous sinuses on both sides as well. Thank you.
Excellent case, Dr. Hazel. I'm very thankful that you've shared it. It's an iatrogenic raised ICP after the surgery for closure or obliteration of the SST. I would like to know pulsatile tinnitus. It's a problem with those who suffer. It's a big problem, and they would go to any extent to get it cured, and hence this invasive surgery. Is it a common problem? Or maybe in this particular case, because the other sinus was the contralateral sinus was hypoplastic, the patient landed up with this trouble, or how common is it, this complication?
So to be honest, the patients I've seen with pulsatile tinnitus tend to be the group with truly has idiopathic intracranial hypertension, rather than in the ENT setting, whereby it's a sigmoid sinus diverticulum. So for my patients, most of the time, even the demographics, their BMIs, their risk factors are all different. And compared to this young lady who comes in, she's very tall and slim, doesn't match no risk factors at all, doesn't match the IH picture as well. I was actually speaking to my ENT colleagues about it. They see it once in a while, not that often due to a diverticulum also. And from their experience, there have been patients who, when they undergo surgery in the same way with packing material with like bone wax, some of them have actually had the fellow sides hypoplastic sinus stented during the same procedure. But this was a colleague of mine who did his fellowship overseas in the UK. So maybe they do see it more over there, and hence, they have more experience in dealing with this.
I've had a patient who's, since you're mentioning that this patient did not, to begin with, have an IIH, which was the reason for the pulsatile tinnitus. Here, probably the bone thinning that you mentioned in the occipital area, that's the reason that the patient had the pulsatile tinnitus. And the patient I'm talking about, my patient, she underwent a stenting procedure to take care of this tinnitus. And that stenting was done after measuring the pressure gradient. In your questions for the discussion, you've mentioned whether we should have, at the same time, done the stenting for the other sinus. So probably obliteration for the, I'm not an expert at this, but any stenting has to be done with the measurement of pressure gradient if it is more. At the same time, doing both, I don't know if it would have been a little more aggressive, but this complication is now being reported when the other sinus is a little, when it's hypoplastic or there is only one, sinus. Then this complication has been reported. The other thing is that was the post-operative imaging, what kind of imaging immediately before the patient presented with the symptom of papilledema? Any imaging was done since the question is basically, was the doctor, the operating surgeon, expecting this complication since the other sinus was hypoplastic?
So I actually think,
CTV.
Okay, so thanks for that. I think as we discussed, probably what should have been done pre-op might have been better assessed with a venogram and measuring a pressure gradient as well. I think as we saw from the CT scan pre-operatively, maybe the sigmoid sinus hypoplasia wasn't really a big point that they noticed prior to the surgery. So it might have been the case because they didn't actually know about the MRI that was done, which actually showed the sinuses a bit better. So after the surgery, immediately after, there was no scan done. I think it was planned for it in about a week's time. However, she presented to the emergency before that scan could have been done.
And doing, since you very clearly mentioned that it was a surgical material, not the clot there per se, I mean, like, what is the role of anticoagulation in these cases? As a protocol for doing this procedure, since some surgical material is being for stenting also, we know that the patients usually kept on, blood thinners for at least lifelong, I think. In these procedures, is there any role of anticoagulants or blood thinners? Was it considered? It's an invasive. I'm like, there is something in the in the vessels, blood vessels that is being placed. So is there any role of putting the patient on anticoagulate?
Well, I'm not so experienced with this, so I'm not too sure whether it's routinely done. I think in this particular case, she was not actually started on anticoagulants immediately after the surgery. And I'm not actually sure whether it's routine for this is done at this center.
The other thing is why, I mean, like, what could have caused the reduction in spontaneously the pressure was reduced? Like, what could have caused usually high magnetic fields? Once the shunt was done, LP shunt, programmable shunt was placed, you mentioned that the pressure changed. And
Yes.
yeah, so I mean, like any particular, this is just for a general knowledge, you know.
Yeah, so we were very curious about that as well, and we were asking her where she went and all, and she said, no, I was largely at home. In fact, if anything, she was trying to get started on going back to class. She's a very bright girl and intends to be a lawyer. And yeah, so she was trying to go back to school for a few more hours each day. So nothing that was in particular concerning in terms of her exposure. No repeated scans were done during that time as well. So we can't figure out why the shunt had reset on its own.
Yeah. So now this patient who's gone for a management of pulsatile tinnitus has landed up with a LP shunt. So what's the long term? What are we seeing? The patient's going to be on the shunt's going to be there, or are we going to wean it off, or what is
So the plan for now, I think, is just going to keep it at least for the next 6 months first and see how her symptoms go, and to ensure that her pressure doesn't rise again first. The long-term plan, parents are still not so keen about talking about it because, as you can tell, they were very against going in to remove the surgical material for her, which actually I can fully understand. It can be a very big procedure, and they were very, very concerned about the risk of an intraoperative large hemorrhage, which could be actually life-threatening for her.
Exactly. Thanks for sharing this interesting case.
Yeah, thank you very much.
Thank you, Dr. Hessel. And we move on to the next speaker, Dr. Carmen Chan. She's going to talk on when optic neuritis refused to respond to treatment. Well, that's a very nice topic, which we see day in and day out. Over to you, Carmen.
So thank you, Dr. Ambika. And first, I'd like to start off with, can you hear me okay? Okay, great. Okay, first, I'd like to start off by thanking Dr. Satya and his team, who has been preparing this for months. And thank you for sending me constant reminders, because I did need that. Okay, so this is a case of recalcitrant optic neuritis. So this is a 62-year-old Chinese lady who presents with us with a 4-week history of progressive blurring of vision, painless in both eyes, and increase in headaches. There's nothing specific in the history, no trauma, no nausea, vomiting. She's a low myope. She's generally well. She only has hypertension and some chronic headaches. So when we first saw her, her aided visual acuity in the right eye was 636, left eye 660, impaired color vision in both eyes, especially the left, and there was an RAPD on the left side. So fundal examination showed right side, the disc was pink. There could be a little bit of mild diswelling, nasal diswelling, but in the left eye, there was diffuse diswelling with an inferior disc hemorrhage. The extraocular movements were full, there were no orbital signs, and no pain on extraocular movements. The blood pressure and random blood glucose was normal. So, of course, we confirmed and documented, quantified this swelling with an OCT, which showed, in fact, the right eye was not really swollen at all. The left side, the average RNFL was 173. So at this point, the top differential diagnosis was bilateral optic neuritis, possibly a bit old for the typical demyelinating type of optic neuritis, but certainly in the right age group for NMO, but there was no pain. Less likely is papilledema, because with very little swelling in the right eye, you would not expect visual loss. So NAION, yeah, but it was progressive over 4 weeks, quite unlikely, and GCA, she's a bit young for that, and quite uncommon in the Chinese population. So she was actually, because of her quite severe visual loss, she was admitted for further workup, and also because we could do everything more quickly. So basic blood tests were normal, syphilis, hepatitis serology was negative, autoimmune markers were negative, and specifically, the anti-NMO and MOG antibody tests were negative. So she went on and had an MRI brain in orbit with contrast, which showed the abnormalities was best shown on the flare sequences. So there are some abnormal flare hyperintensity in the left cerebral white matter, especially in the temporal and temporal periventricular regions. and there was extension along the left cortical spinal tract at the left cerebral peduncle and the pons. And there was also some mild hyperintense signal noted at the body of the corpus callosum, which is not shown here. So as ophthalmologists, we're of course most interested in the optic nerves. So this is the top is the T2 weighted fat suppressed images. The bottom is T1 weighted fat suppressed images with contrast. It showed abnormal signal along the left optic tract, optic chiasm, and optic nerve. And also there was mild increase in flare hyperintensity noted along the right temporal region and along the right optic nerve as well. So it does demonstrate a bilateral optic nerve abnormalities, which could account for the bilateral visual loss. So the MRI differential diagnosis was inflammation or demyelination, and specifically it mentioned NMOSD and also multiple sclerosis. So she had a lumbar puncture, which showed normal opening pressure. The Gram stain was negative, and the white blood cell, there was only one, so no pleocytosis, and CSF sent for cultures and AFB cultures were all negative. So at this point, the images were reviewed with a neurologist and neuroradiologist, and it was thought that although she was seronegative, overall the picture was compatible with NMOSD, and by now her vision has decreased to finger counting in both eyes. So on day 9, from the first day of presentation to us, she was started on IV methylprednisolone, 1 gram, and she was given it for 5 days. And however, after 5 days, there was a little, in fact, minimal improvement. So she went on to have 7 sessions of plasmapheresis. Unfortunately, at the end of plasmapheresis, in fact, if anything, the vision has decreased further, especially in the left eye. And she was also started on rituximab. She was given 2 doses of 1 gram at 4 weeks and at 6 weeks. But the visual acuity, when we reviewed her 6 weeks after first presentation, was no different. So at this point, she had repeat neuroimaging. She had MRI brain and orbit, as well as MRI spine. The spine was normal. So the MRI brain showed, if anything, there was increase in the patchy T2 weighted and flare hyperintense signal in bilateral cerebral white matter, and also in the periventricular regions as well. Also involving the basal ganglia, cortical spinal tract, at the level of cerebral peduncle, pons, and there was also some mass effect. And there was the right cerebral hemisphere was less affected, involving the right parietal and temporal lobes. So this was the baseline for comparison, done on different machines, but as you can tell that it has progressed. And in terms of the eyes, now both optic nerves were swollen with abnormal T2 weighted and stir images extending from the intra-orbital segments of both optic nerves to the optic chiasm and also to left optic tract, similar in extent. And there was no definite corresponding contrast enhancement. So at this point, we thought the MRI, the findings were still suggestive of demyelinating disease, likely NMOSD, and there was overall increase in active demyelination. Well, we've given this patient steroid, plasmapheresis, and now rituximab, and we did not actually give her IVIG because the value of IVIG in this situation is limited, and also we do have the newer NMO medication like revolucimab. However, it's a self-financed item and is prohibitively expensive. Plus, it is also for to reduce recurrences, and really the primary indication is not at the acute phase. So we opted for observation after rituximab. So unfortunately, a few weeks later, this was 10 weeks after the first presentation to us, she was admitted through the accident and emergency department. This time, she came in with vomiting and right hemiplegia, she had dysarthria, and at this point, the CT brain showed midline shift towards the right side because there was an enlarging left periventricular lesion. So the eye examination, by then, she was bedbound, she was really not much verbal response, so we couldn't test her visual acuity. And this is what it looked like. On the right side, there was diffuse swelling with a combined CRVO and CRAO picture. So because you can see there is diffuse retinal infarction. So the cherry red spot is kind of obscured by the diffuse hemorrhages, but you can see the right eye much worse than before, of course, and with diffuse swelling. The left eye also with swelling and also some peripapillary hemorrhages as well. This was taken with a handheld camera. So she had a repeated MRI. So at this point, it was much worse. There was significant increase in the T2 hyper intense mass in the frontal lobe and in the periventricular region, with mass effect and infiltrating and extending to the posterior limb of the left internal capsule, cerebral peduncle, midbrains, and pons, with infiltration, well, basically everywhere. So across the splenum of the corpus callosum and anterior commissure as well. And there was infiltration along the left optic tract, or the optic chiasm, and bilateral optic nerves towards the canal. So I have some suggestions in the chat box from Dr. Uma, but I shall not reveal them at this point. So at this point, a diagnostic procedure was performed, as they say in the Walsh session. But since time is limited, well, in fact, well, this is actually the T2, but together with the MRI, an MR spectroscopy was also done, which showed, well, when they did it on the left frontal mass, it showed, well, to be honest, I don't know much about MR spectroscopy, so hopefully I think you have assigned Dr. Vina to be the expert in this case, which is very relevant because hopefully she can tell us more about it. But basically, the imaging features were suggestive of multifocal high-grade glioma. So in view of this, she went on to have a brain biopsy. And as expected from the imaging, it turned out to be a glioblastoma. And this was WHO grade 4. So at this point, the diagnosis was revised to glioblastoma. She was referred to oncology, and post-operatively, her GCS was poor. There was no verbal output. She was able to obey commands and with a dense right hemiplegia. So at 3 weeks later, and so we were still waiting for oncology. So at this point, she was admitted to she actually went to the convalescent hospital while I was waiting for oncology, but she was admitted with decrease in GCS again. And this time, the CT brain showed significant increase of the mass, well, of the lesions that we previously saw with great mass effect. So there was significant disease progression. And after discussion with the family, they opted for comfort care. And she passed away at week 15 after initial presentation to us. So in retrospect, I think the atypical MRI features were that there was extension across the corpus callosum and along the cortical spinal tract. There was mass effect, and there was rapid progression of disease, which were quite atypical for demyelinating disorders and for NMO. So at this point, so I'm sure Dr. Veena can give us more information on that in a minute, but I'll just give a very brief review on the mimics of NMOSD on MRI, which of course include multiple sclerosis and MOGAD. But apart from demyelinating diseases, there are also lots of other non-demyelinating disorders which can mimic and misdiagnose as NMOSD. And there's quite a nice paper in the European Journal of Neurology. So in this paper, so they had 68 patients from a literature review and also from their own cases. They had 68 patients which were misdiagnosed as NMOSD. So a whole range of disorders, including genetic, metabolic, infections, neoplasms, and also systemic autoimmune disorders. So basically anything can mimic NMOSD on neuroimaging. I think of note, in the published literature that they reviewed, there was only one case of high-grade glioma. So according to this paper, the common red flag signs associated with NMOSD were lack of CSF pleocytosis, which was present in our case, the lack of response to immunosuppressive therapy, which was also present, as well as progressive disease course over some months. In fact, in our case, it was over some weeks. So there was lack of gadolinium enhancement on the MRIs. So in our case, there were no gadolinium enhancements of the optic nerves. And also, there are other features which were not present in our case, which include oligoclonal bands and also fever. So in the take-home messages, the take-home messages from this case is that neuroimaging is very important in the diagnosis of NMOSD, especially in seronegative cases. Atypical cases require multidisciplinary input from neurologists and neuroradiologists as well. And we really need to consider to revise the diagnosis if the red flag signs are present, including lack of treatment response, progressive disease, lack of gadolinium enhancement, and lack of CSF pleocytosis. So I'd like to thank our neuroradiologists, as well as our neurology and neurosurgery, as well as our ophthalmology teams. So we have a few minutes of discussion, and then I'll hand the mic back to Dr. Mbika.
Thank you, Dr. Carmen. That was a wonderful case. Unfortunately, I think Dr. Veena is stuck with some other commitment, so probably she will join later and add her comments. I just have one question to you. When the patient came with a painless 4 weeks onset of a vision loss with a headache at 60s, so would you consider doing a biopsy on stage 2 after a reduced response to treatment with a spectroscopy as a repeat imaging?
I think here, in retrospect, I think at 6 weeks, I think we should have done it with the MR spectroscopy. I think at that point, if we did it at that point, I think we could have reached a diagnosis. So it is very important that we look for these red flag signs and then go for the diagnostic procedure earlier.
Because that is very frequent nowadays, what we see in our practice, when we have this sort of irregular thickening, which was very classical in your MRI orbit cuts, where you could see that optic nerve thickening of the left optic nerve. If you could share those images, you can see that irregular thickening, which was more pronounced in the left than the right. And did you have any fundus images in the acute stage in visit 1?
No, I don't have it, but I only have the OCT. So
yes, because the second
nowadays it's easier to get the OCT than the. But anyway, but you can kind of see. Yeah, but no fundus photo, I'm afraid, because it was seen in our general ophthalmology clinic. But yeah, so
this one. Yes.
Yeah.
So we can see that it's an irregular thickening along the optic nerve, and the sheath also is quite irregular thickening. And I mean, like, there are so many neurologists in the forum, so you can correct me if I'm wrong. The amount of enhancement and the brightness, what we see in a demyelination versus this is slightly less. Am I right? because if at all we think of a tumefactive demyelination, because that is what will look such big, and will it be more bright rather than a dull bright, what we see over here, which again is another imaging factor which will make us ask for a spectro and reconsider. Because if sitting in India, I would have think when there is a diffuse leptomeningeal thickening, I will start thinking of TB sarcoid as first things before even thinking of a biopsy. So that is the thing. And as you have rightly mentioned, there's been an adequate blood workups which have ruled out all those granulomatous changes. And then there was a very progressive decline of the vision and poor response to the therapy, which has guided us towards the diagnosis. And there's an interesting debate which is going on in the recent JNO about this biopsy, early biopsy versus late biopsy of the optic nerve. Also, the recent JNO has come up with that. So would you consider doing an optic nerve sheath biopsy if the vision is being profoundly down, rather getting into a more difficult brain biopsy, or would you advise directly a brain biopsy?
I think in this case, because the brain lesion was probably easier to biopsy than the optic nerve lesion. So I think brain biopsy in this case would be easier. However, if the brain lesions were in a different place, then of course we need to discuss with our neurosurgery colleagues to see which is easier. But optic nerve biopsy is never easy, especially when you're still in a seeing eye. So because it's quite easy to injure the optic nerve.
And because that has been recommended when the vision drop is profound. And
Yes.
if it is accessible, as you mentioned, here it is more of posterior to midsection optic nerve thickening. So thank you so much, Dr. Carmen. Are there any other comments from other panelists?
I think there was a comment in the chat box asking whether demyelination can also cause a mass effect, and that I was hoping to see whether we have any anyone else in the expert panel who can answer that question.
Can you hear me?
Yes, Dr. Plant!
Hello, Dr. Carmen.
Wow, so good to see you.
Yeah, sorry to be joining. Do you have the image of the tumefactive lesion? Sorry, I think
The initial or later ones?
Well, I've only just joined, but you say there's a tumefactive lesion in the brain somewhere.
So the brain somewhere. So this is the this is the one at 6 weeks from initial presentation. So
yeah, I wouldn't really call that tumefactive. It's interesting, if you look at the early CT literature of the really early CT scan literature of multiple sclerosis, the lesions that you can see on CT, particularly early CT, all of those patients had either hemianopia or hemiplegia. And they were all these really large, often space-occupying tumefactive lesions. And if you look, and then more recently, if you look at all of the histology of acute MS lesions, it's almost all tumefactive lesions, because people are still biopsying these because they think they might actually be neoplastic. So I mean, this is a very extensive lesion, but it's not space occupying in any way, and it's quite fragmented and so on. It's certainly a big lesion, though. If you're worried about diffuse glioma, then it's a really good idea to biopsy something that's accessible and less likely to cause problems. So where we've had cases of glioblastoma, malignant glioma of the optic nerve, if you look very carefully, you can often find bits of brain to biopsy rather than the optic nerve. And I think the successes I've seen with optic nerve biopsy have really been sheath biopsies, not biopsies of the optic nerve itself. And certainly lymphoma and other things have been successfully diagnosed following optic nerve sheath biopsy, which of course doesn't hold the potential morbidity of biopsying the optic nerve itself, which is basically curtains, isn't it? So it's a really interesting case. I wonder what you did. I wonder what you decided to do.
So you just joined in, so you didn't see the end?
No, I've literally only just joined, sorry.
Oh, sorry, brain biopsy, glioma. She passed away. The patient died.
Oh, it was a glioma.
Yeah, glioma. It was glioma.
Oh,
so
okay.
Well, at this point,
it certainly this is with malignant glioma of the optic nerve. Often also there's changes in the retina because they often get mistaken for actually a central vein occlusion early on because they have that sort of thing going on. So and of course the history is very short and invariably fatal.
Yes. So do you think by giving her by treating her as NMO with rituximab, do you think we have expedited her demise, or do you think she would have passed anyway?
No. This is a terrible prognosis.
Thank you, Dr. Carmen. And I think we'll move on to the next speaker.
Okay.
I invite Dr. Luciana to talk on All Signs Speak Aloud.
Yes. Thank you so much for letting me be part once again to the Global Neuro-Ophthalmology Case Festival 2025. Well, my presentation is entitled All Signs Speak Aloud. So this case is about a 74-year-old Caucasian female who was referred by a fellow ophthalmologist due to the worsening of the visual field. She had been diagnosed with glaucoma. Her past medical history included high blood pressure, and she was taken losartan and drops of timolol and dorzolamide. So here we can see the ancillary test that she had undergone before she was referred. The visual field shows on her left eye a decreased sensitivity, mainly at the superior arcuate level and inferiorly. And the left eye showed a more advanced visual field defect and a relative nasal sparing. To the left, we can see the OCT. The right eye showed a normal peripapillary nerve fibers layer, and on the left eye, they are a little bit thinner with a localized depression, mainly temporal and inferiorly. So the neuro-ophthalmic examination of the patient showed a best-corrected visual acuity of 20/20 in right eye and 20/60 in left eye. The color vision was preserved in both eyes, but she had a color desaturation on her left eye. At the slit pump examination, she had pseudoexfoliation only in her left eye. The intraocular pressure was normal, was 12-14 millimeters of mercury. There was an RAPD on left eye of 1 cross, and the extraocular movements were full. So here we can see both optic nerves of optic nerves of the patient with an increased area and a moderate cap to disc ratio. But the more interesting thing is that she had a notch in her left eye inferiorly, as pointed by the blue arrow. So another visual field was performed. If we compare the first one, this is the only visual field I had, and this is the new one. We can see that there is here we can see a localized visual field defect inferiorly and temporally, and the left eye showed extended inferior visual field defect. comparing with the first one. So what does her right eye show us? She had a borderline peripapillary nerve fiber layers in her right eye and a borderline ganglion cell complex. We had this localized visual field defect. She had no pseudoexfoliation in her left eye. The intraocular pressure was normal, was 12, and the optic disc in this condition. What about her left eye? Her left eye showed a decreased peripapillary nerve fiber layers, especially temporal and inferiorly, a decreased ganglion cell complex, this advanced visual field defect. She also had pseudoexfoliation in her left eye. The intraocular pressure was 14, was normal, and the notch in her left eye, the inferior notch. So I asked myself if the foregoing results were only due to glaucoma or due to the notch. Here we can see that there is a correlation between the superior visual field defect and inferior notch and the OCT. And so I asked myself if really it was only due to glaucoma or to the notch. But if we look at the inferior visual fields and inferior levels visual field, we can see that this is not, perhaps it's not due to glaucoma. So all signs sometimes speak aloud, and some signs at least speak aloud. Her best corrected visual acuity on left eye was 20/60. She also had a color desaturation in her left eye, and she also had an RIPD in the same eye. So I went back to the visual field, and I start to see this defect perhaps as an inferior incomplete quadrant tranopia. So I decided to perform an MRI, and the MRI showed the T1 coronal section on the MRI showed an occupant lesion in the cavernous sinus, mainly displacing the chiasm on the left side, pressing it upwards. And to the right, a sagittal section shows this lesion at the chiasm level with heterogeneous gadolinium enhancement. So I decided to perform an angiography. And finally, here we can see the dynamic angiography showing a wide neck carotid ophthalmic aneurysm that with the following dimensions, it was 13 millimeters high and 15 millimeters wide. So, well, what we have to consider about the ophthalmic artery, know the importance of the ophthalmic artery is the primary branch of the internal carotid artery, is responsible for supplying blood to the retina and ocular structures. So how we have to treat them? What about flow diverters? They provide a revolutionary method by alternating hemodynamics to promote aneurysm occlusion, and had achieved significant success in reducing the risk of carotid ophthalmic aneurysm rupture. So finally, she underwent endovascular treatment. Here we can see the angiography. So as a take-home message, I could say that when signs speak aloud, we should look beyond. And I would like to know your opinions about my questions. I ask myself if the aneurysm could be considered as a finding, if the notch can be caused by compression, if this visual field defect could be considered as a Guyson defect in this case, and if she really had glaucoma, or it's a kind of combination, or it's all because of the aneurysm. Thank you so much.
Thank you, Dr. Luciana. I just have one question before we go on to your list of questions. The first image of your right optic disc showing a OCT image itself showed some inferior and temporal RNFL defects. So when we see a disc which is not correlating with the OCT, and even even the left eye, which had the pseudo exfoliation, already had an advanced field loss. And yes, I agree, there was an asymmetrical cupping with a notch of the left eye. But to begin with, the right optic disc and the visual fields were not matching to each other. So when we have something like the disc not matching the OCT or the fields, we would step up an asymmetric glaucoma. As first line, we get imaging done.
Yes, pseudoexfoliative glaucoma tend to be a little bit asymmetric. So yes, it could be.
So I think the aneurysm is an add-on, more than one diagnosis for this patient. Can anyone comment that, Dr. Gordon, have you seen an isolated disc notch with chiasmal compression?
My rule of thumb with glaucoma is that the pathology is entirely at the optic disc. Entirely. There's no pathology at any other location in the visual pathway. So you have the advantage that you should be able to explain every defect of vision by looking at the optic disc. And glaucoma is common, and most of the problems arise, in fact, when people have glaucoma plus something else. And so various things. Most patients with glaucoma don't notice the loss of vision until it's very severe. And if a patient comes along with relatively mild glaucoma changes, and mainly because it's different in the two eyes and there are no overlapping defects, if they notice it and they seem to have quite mild glaucoma, always think there might be something else going on. And then the other thing, of course, is that the visual field defects in glaucoma always respect the horizontal meridian, and you have defects which are respecting the vertical meridian. So you did absolutely the right thing, but glaucoma is common, and this patient might have normal tension glaucoma as well.
Okay. So I want to know it was a finding, or I did the best thing for the patient, asking for the
There's an
MRI.
interesting thing, the ophthalmic artery, although it seems very important, you can ligate it and the eye doesn't suffer. Because the eye has, it just has a dual supply from the internal and from the external carotid artery. So back in the day, sometimes the ophthalmic artery was just ligated, and fortunately the eye doesn't suffer.
Okay, thank you so much.
And this ophthalmic artery aneurysms are not that common among the cerebral aneurysms. Is it quite rare to see such ophthalmic cranial aneurysms?
Well, I have a rather distorted practice experience towards the optic nerve, so I saw more than my fair share. But yeah, I think that's correct. But this question of the risk of ligating the ophthalmic artery is quite important for the neurosurgeons, provided the patient has a good external supply. So patients you see with ischemic orbit or ischemic globe, they always have disease of both the internal and external And giant cell arteritis is one of the causes of that, other than just regular vascular disease. But so you should always be thinking, even if the patient has some obvious evidence of glaucoma, if the color vision's down, that's not right for glaucoma. If there's anything respecting the vertical meridian, that's not right for glaucoma. They could have something else. It's a very nice case.
Okay, thank you so much.
Thank you. Thank you, Dr. Luciana. And I think we will move on to Dr. Almila. She's going to present Lost in the Dark, Found in the Angle. Over to you, Dr. Almila.
Thank you so much. So first of all, I would like to thank you for having me here, dear moderators, panelists, and colleagues. Good afternoon, everyone. So I'm Dr. Amilo from Turkey, and I'm going to present you our case, Lost in the Dark, Found in the Angle. Our case is a 49-year-old male patient, and he had a complaint of recurrent transient visual loss attacks in both eyes for the last 2 years. He had a past medical history of LASIK surgery almost 16 years ago when he was presented to us, and he had a family history of glaucoma in his mother and brother. Other than that, he didn't have any other diseases. So he first came to our clinic at 2025 April. So before that, 2 years ago, his first attacks started actually. In 2023 April, he had his first visual deprivation attack. He says that his complaint started in the left eye with a paracentral defect. And then the next day, he developed a lower field defect in the other eye, right eye. At that time, he was seen by an ophthalmologist externally, and he was treated as optic neuritis with IV pulse prednisolone treatment for 3 days, followed by oral steroid treatment. At that time, he had a systemic workup and a detailed evaluation for any causes of optic neuropathies. He also had a neurological evaluation. He had an MRI. All tests and imaging came out to be normal, except for a JAK2 gene mutation. And here you see the visual fields and OCTs from that time. While he was still on steroid treatment, 2 weeks after the first attack, he developed a second attack. First, in the right eye, he developed an upper field defect, and in the left eye, he developed a lower field defect. At that time, all tests were repeated for optic neuropathy etiology again, and also he was consulted to hematology, neurology, and rheumatology departments. None of the tests came out to be positive, and all the departments said there were no other pathologies. After that, he had transient recurrent blurry vision attacks for the past 2 years. In that time, he saw many different eye doctors, and he was started on azathioprine treatment. Also, he tried some alternative treatments, including bioenergy, leech therapy, glutathione, ozone therapy, and vitamin supplements. So when we come to our clinical examination, we first saw the patient on April 2025. At that time, his best corrected visual acuity was 20/25 in the right eye and 20/20 in the left eye. His pupils were reactive to light with no relative afferent pupillary defect. Intraocular pressures were 20 millimeter mercury in both eyes, which we can say high normal. So, and also color vision was normal in both eyes. We did an OCT scan and a visual field testing. And as you can see from the pictures, his retinal nerve fiber layer was thinned during the 2 years, and his visual fields worsened over time when we compare with the first OCTs and visual fields. On anterior segment examination, we noticed that the patient had a narrow angle. So we performed a gonioscopy, and we noted that he had grade 1 narrow angles. We did a Schönflug imaging and we noted that the angle was 9.5 in the right eye and 12.5 in the left eye. At that time, our differential diagnosis included ischemic optic neuropathies, toxic or nutritional neuropathies, mitochondrial neuropathies, or compressive optic neuropathies. But based on the patient's history and all the tests done and our examination, which showed obviously narrow angles, we concluded that the patient had intermittent angle closure attacks with bilateral chronic optic neuropathy, which caused a possible cumulative injury to his optic nerves. So we decided to perform a YAG peripheral iridotomy, and we did. After that, the patient didn't had any complaints of any other recurrent attacks. And we last saw the patients on September 2025. His best corrected visual acuities were 20/25 in the right eye and 20/20 in the left eye. His pupils were reactive to light. Again, no relative afferent pupillary defect was detected. Intraocular pressures were 16 mm mercury in both eyes, and color vision was still normal. Here you can see the posterior segment examination, OCT, and visual fields from the last examination. We noted some optic disc pallor in both eyes with diffuse retinal nerve fiber layer thinning, but compared to the previous visual fields and OCTs we performed, we didn't note a significant progression after the YAG iridotomy. So to conclude, we saw the patient, we couldn't have the chance to see the patient at the first attack. So we don't know if there were any other underlying etiologies. But when we examine, we should remember that when we examine a patient with acute visual loss, we must look carefully to the eye before ordering any imaging labs and consultations, and also prescribing any medical or alternative medical therapies. In every case of visual loss, our first investigation should be a detailed ophthalmologic examination. Also, gonioscopy must be performed in every case of unexplained recurrent optic neuropathy, and we should always remember to look at the eye first before we look anywhere else. Thank you for your attention.
Thank you, Dr. Almila. As you rightly pointed out, the ophthalmic eye examination goes before you think of any case of optic neuritis. I'd like to ask you, the patient had a visual phenomenon which was fleeting. This would fit into the diagnosis of Amarox pubens. Did the patient have any complaints of headache?
I'm sorry, did the patient have any complaints of? I couldn't
Headache.
catch. Headache?
Headache.
No, he didn't.
He didn't have headache. But
he didn't have a significant headache, but when he was experiencing blurry vision attacks, it lasted almost sometimes minutes, sometimes hours. So he sometimes experienced a mild headache, but he didn't have a significant headache complaint.
One more thing is, whenever a patient experiences attacks of angle closure, there must be some telltale evidence of any peripheral anterior synapse or any reduced cell density. But I think our patient didn't have any of these symptoms of acute attacks. So these are only a subacute attacks which cause a RNFL thinning with a GCC less. Am I right?
Yes, our patient didn't have any peripheral anterior synechia in our examination. So we are not sure if the patient had a history of acute angle closure. We think that maybe he had something else, and then those intermittent angle closure worsened the scenario. So he didn't have any acute angle closure attacks as far as we know, but we saw the patients only after 2 years, so we are not really sure.
And one more question is, what is the rationale of using all your ozone and leech therapy in all these conditions? Is it still used? Because
no. The patient had seen many other doctors before he came to our clinic, so those were the therapies he had before. We don't use those therapies for all of our patients.
No, is it used in the periphery? I'm just asking.
Treatments. Yeah, we don't use them, but the patient had them before he came to our clinic.
Okay, thank you.
Can I ask her?
Yeah, please.
I think the question of intermittent paroxysmal visual loss in glaucoma is a very interesting one, because it's not generally recognized. And I was just wondering, were these attacks provoked in any way in his case?
No.
Sometimes sometimes there are attacks provoked by exercise, climbing stairs or something like that. And that, of course, gets confused with demyelination, where that is much more common. But with, as has been said, with angle closure, we rather think this must be due to intermittent angle closure. But he had no provocation and no other symptoms, no pain, nothing else associated with these.
He says that he sometimes experienced a mild pain, but he didn't explain a significant pain like an acute angle closure attack.
No,
so
well, but they were so
pain, some blurry vision.
It's not going to be like acute angle closure because they're so brief, aren't they?
Yes,
they're not sustained, so he's not going to develop pressures of 40 and the whole picture.
Yes,
so
exactly.
I think it must be that there is an intermittent rise in the pressure enough to make a difference. And I think in many cases we think that's what happens with this narrow angle glaucoma, because the pressures at times may not be very high. So it may be that these intermittent rises in pressure are actually more of a problem for the optic nerve, because it doesn't have a long time to adapt and so on. And also I think the loss of vision can be more noticeable to the patient, because you can have a lot of the visual field affected all at once, and then it recovers to an extent. And that's very different what's happening in chronic glaucoma, where we have these localized field defects which don't overlap in the two eyes, and the patients are completely unaware of them. And I know very well, because I got glaucoma. I didn't notice my own defects until they were quite severe. So, but I think it's a very interesting lesson. But I agree with you. I don't think there was any justification for these other treatments. And the patient should have had a proper eye exam right at the start.
And most importantly, your patient had a family history of glaucoma. So when there is a family history of glaucoma, the first thing to go and look at is the angle. So the gonioscopy and the repeated attacks, he himself is giving the diagnosis to begin with, I guess. So your patient did not have any redness at all in any of the attacks? No red eye, headache, vomiting?
He
Nothing?
didn't have any vomiting, or he didn't have any significant pain, but he says that blurry vision and mild pain sometimes.
Yeah.
Thank you.
So I think this is intermittent closure, which is quite much. He would have, if somebody had dilated his pupil, they'd have done him a favor. Did he ever have his pupil dilated? If somebody had done that,
You would have made the diagnosis.
I've come across. I was, when I was at Wills, they were very anxious to say to the neurologist never to dilate the pupil. You might precipitate angle closure. You're doing the patient a favor if you do that. So I can only imagine this patient was never had his pupils dilated, let alone his looking at his angles.
Thank you. Thank you so much, Dr. Almela and Dr. Padmavati. And I think with this, we come to the end of this session 1. Do we have any wrap-up questions from any of the panelists? If no, we will move on to session 2. Over to you, Dr. Satya.
Dan, I have to share the screen before you start sharing the screen. I need to introduce you. Thank you.
Apologies.
Satya, may I start with the second session?
Yes, you're welcome.
So after this wonderful first session, I'm going to start the second session. Am I sharing my screen?
Yes, you're visible. But we have, yes,
Can you
that's
see?
right.
Yeah, you can see my slides?
Yes.
Okay. So to begin the second session, I'll invite the first panelist to discuss the first case. And our panelist is a very multifaceted person, Dr. Rashmin Gandhi. He is the director of Cygnus, Axon, MedTech, and Foresight Worldwide. And he is, for his clinical work, he is with the Center for Sight as the director of Neuro-Ophthalmology at Hyderabad. And he is the fellowship director and board member of World Headache Society. And he's been the founding member of Indian Neuro-Ophthalmology Society and country director for Davos Alzheimer's Collaborative. So welcome, Dr. Rashmin. And he'll be discussing the case presented by with a very famous ophthalmologist. I'll start with the last line first. He was recognized as among the 50 most influential ophthalmologists worldwide, Dr. Dan Millier. Professor Millier serves as the head of Neuro-Ophthalmology Department and director of Rothschild Brain Lab at Rothschild Foundation, Hospital, Paris, France. His distinguished career includes positions as adjunct senior clinician scientist at Singapore National Eye Institute and affiliate professorship at University of Copenhagen and Duke NUS Medical School. He has over 250 PubMed indexed publications and he's also authored several books. Professor Millier currently serves as the co-editor-in-chief of the journal Neuro-Ophthalmology. So over to you, Dr. Millier, to present your interesting case.
Thank you so much for this very nice introduction. Do you see my slides?
Yes, we do.
Okay. As full screen?
No, not yet.
I don't know why it's not moving into full screen. Yes, now I should be okay, right?
Yes.
Okay,
Yes.
lovely. All right. Thank you so much, Shika. It's such an honor and pleasure to be here. And Dr. Karna, Satya are doing such a great job. I'm seeing Ambika, Rashmi, so many other friends. It's such a pleasure to see you. You are doing an amazing job together, such a worldwide panel and great presentations. So in a few words, this is my disclosures. I'm the co-editor-in-chief. I'm succeeding Dr. Gordon Plan on this job. It's overwhelming. And this is my lab in Paris, my research lab. And I would like to thank Sami Zayer, who was my fellow who put this case together. So in brief, this is a patient age 45 with a not easy story. He's not a very good historian, had several strokes in the past 4 years, and he is referred for unexplained bilateral visual loss. And as I said, the history is not very clear. This is his past medical history. He was born in Turkey. These are his medication. He is basically a heavy vasculopath with obstructive sleep apnea. And this is the first stroke in 2021 at age 41. That's a bit young for a stroke. And he had a carotid occlusion, which was stented. And then that was followed by 2 other strokes, plus a transient ischemic attack in 2023. All this was before the ophthalmic history started, which is the following. In 2024, he had a rapidly progressive visual loss in his left eye, which was not really explained, not was really investigated. And subsequently, there was worsening in the same left eye with no explanation to counting fingers. And when he bilateralized his visual loss, also in the right eye, he came to us. He was referred to us. This is his clinical examination, poor vision bilaterally. And this is his fundus in his left eye. And this is the OCT. I don't know if anybody has any comments on this.
One side thinning is there.
Let me show you the other eye. You're absolutely right. So this is the OCT in his left eye, and this is the right eye. And you might think there must be a little bit of swelling in his right eye, optic disc, which seems to be confirmed by OCT. So let me go back. So this is the situation. He had an unexplained visual loss in his left eye, and then worsening in his left eye. This is his left eye again. And now he comes for optic disc swelling in his right eye, very mild optic disc swelling.
Dan, can I just stop you here and
sure, please.
Yeah, so what it appears is that a person who is heavily vasculopath has had strokes in the past and now is coming with a sequential loss of vision in both the eyes. So maybe we can stop and ask our expert as to what should be done next. It obviously it's tilting more towards ischemia, but I mean, if any suggestions.
Right. So he's age 41, so a little bit young for ischemia. So you're asking me, or are we asking others?
No, I thought if anybody else has any thoughts, since we discussed it. So
yes.
Yeah. Okay. Then maybe we can reveal the secret.
So what we thought is that probably in the left eye, as you say, this must be an arterial occlusion, looking at the OCT, looking at a cell loss, and there is obviously an infarct in the retina. But then how to put together worsening an ischemic event in the left eye and then optic disc swelling in the right eye, that was quite hard. And these are the visual fields which do not really match with this situation. So I think at this point, everybody would agree to have to go for imaging. And this is the neuroimaging at the acute stage. And you probably would notice an old infarct in the occipital lobe. And this is probably the most striking image, I think, that I would like to discuss with everyone. Basically, there is involvement. So this is a T2 flare image. And there is increased signal both in the chiasm and in both tracts. We suspect that the occipital damage is probably old, and anyhow, it would not explain this type of visual field. So the discussion is, I can show you images, but I can also tell you that there was no enhancement after contrast injection. So what would we think about? Any questions or any thoughts? Could this be coagulopathy? He had an extensive, so let me go just through the images. There's chiasmal involvement, and after contrast, there is no real enhancement, because we also thought, obviously, this could be an inflammatory optic neuropathy, and this was the workup, which was quite extensive. Everything came back negative.
So, Dan,
yes.
To give a clue to all the panelists,
right.
Just to sum it up, it's a little confusing. You said first the patient had carotid artery disease for which he underwent a surgery,
Correct.
right?
Correct.
He's a 41-year-old with every kind of risk factor for a vasculopathy. And he's had carotid artery disease, and he's also had an occlusion, vascular arterial occlusion on one side. Now Absolutely. He has presented, the carotid artery disease treatment was done after the occlusion, vascular occlusion. That's how it was diagnosed. And now he's presented with a disc edema in the other eye, which right. is, disc edema is caused what kind of field effect? It is, I missed that.
Yeah, so in the right eye, this is the right eye with the optic disc swelling, and look at the visual field in his right eye. I like the way you summarize the case. I think you're a better presenter than I am.
No, it's for now your case is being discussed by Dr. I'm the moderator, so I'm just trying to make it simple for everybody. So Dr. Rashmin is your panelist. So you're saying that there is at this point when there is a disc edema, you've done the MRI and you're seeing not only an old infarct, but also there is a signal which is non-enhancing signal in the tracts and the chiasm. So what are we dealing with? It's not enhancing, and there is a signal there. There is something that's happening on both the sides.
Correct. So I think the confusion here is that while a heavily vasculopath had vascular events in the past, has now arterial occlusion, vision loss, which is progressive, but everything has come back as normal.
So Dan also mentioned he's a smoker, right? Tobacco chewer. I saw tobacco somewhere. So Dr. Plant, you have to add anything? What can get aggravated by that? Are we looking at LHON toxicity?
I'm obviously there's vascular disease going on here. There's no doubt about that. This appearance of high T2 signal in the optic tracts, quite symmetrically like this, is very interesting, and it can just be edema.
No, it's not. I absolutely agree with you.
It can just be edema.
Can it be toxic? It's on both the sides. Can it be something to do with some toxic? We've seen these cases with ethambutol toxicity where bilaterally tracts are they show up some signal, and in patients with LHON. So maybe two totally not related things, Dr. Plant.
Yeah, well, I say I'm just thinking through the possible causes of this, and optic tract edema is particularly associated with craniopharyngioma, and it gets mistaken for infiltration, so people think it's glioma infiltrating the optic tracts. But if you don't think,
yes, please.
If you don't think it's edema, if you don't think it's edema in the optic tracts, what is the pathology? Is it infiltration?
I don't think it's infiltration. I think what you're mentioning is absolutely right. But with some infiltration, we would have had some enhancement, I think.
Not if it's just. Yes, I agree. But if it's just edema, you don't.
Yeah, true.
It's because basically the edema follows white matter tracks just through simple physics.
Absolutely right.
This can be edema.
Right. So from my title, I think the title gives away the diagnosis, and I think that this case is connecting well with the previous one when Gordon said that glaucoma is a common condition, so any other condition can be associated to glaucoma. So systemic vasculopathy is not that rare either. So when I'm in trouble with diagnosis, I just come back to dogmas. And the dogma in this case is a young man, 41, with sequential visual loss. And I would do, IV steroids did have not effect in that. So the next thing is we do a procedure, which is mitochondrial genome sequencing, and that was positive for LHON. And in fact, what I learned from this case is that I fully agree with you and with Shika, who said that in LHON or ethambutol, it's chiasmal involvement is not uncommon. But this type of bilateral tract involvement, I didn't know about this. And there was a paper last year by a French group. This is the paper, Extensive Optic Tract Involvement in the Acute Phase of LHON. And this opens the discussion. I'm sure you'll have an insight in this. How is the imaging really normal in the acute phase of LHON? Can you imagine or can you accept enhancement, or is it just T2 abnormal signal, which is something that we're all familiar with? So this is the end of my case. So basically, true, and unrelated, the poor gentleman was a vasculopath, had a retinal occlusion in one eye, and then developed LHON in a context of unknown family history. That's my story.
Yeah, that's very interesting. So, but what do you think is going to happen to this high signal? Is this just now atrophic gliotic change? This is quite acute, isn't it?
This is at the quite acute stage. Is within, yes, absolutely. It's in the first month or so. Yeah, I agree.
Dan, did you do IAD Bino for this gentleman?
Did we? I do not recall. Probably, but I do not have the answer.
Fine. How is it? I mean, like, how did this pathology, that is LHON, affect the other eye?
So basically, remember what happened is that he had an occlusion, a vascular occlusion in his left eye that got worse. And that worsening, I think it was not another vascular problem. I think it was the first attack due to LHON. And I think what already gave us a clue was the visual fields, because this is central scotoma, and right, and his right eye, I called it optic disc swelling. I don't think that was optic disc swelling. Look at his right eye and the OCT findings. I think this was just pseudo swelling of the optic disc. But obviously, if we did fluorescent angiography, I wouldn't have expected any leakage from this. So
no,
all
that's
the
right.
elements, the elements. I'm sorry. Yes.
Yeah, we're saying what we commonly see at the optic disc. This is presumably what's happening in the optic tract. So you get swelling, but it's because the axons are dying a metabolic death.
I guess so.
So there's no inflammation and no enhancement, no leakage on fluorescein. So,
right, I guess so.
But it's just incredible that it should be so localized to the optic tracts like that, isn't it?
I agree. We were puzzled by this image, and we just didn't know how to deal with it until the mitochondrial testing saved us.
Stefan has a comment. Stefan has written in the chat box that Stefan, can you comment on the OCT you've written in the on the hindsight that it looks like LHON? Would you like to?
Thank you. I think it very nice case, Dan. I think when you look at the fundus picture and the OCT, I actually think it looks pretty classical LHON with the fullness and redness of the disc, not really an edema, but however, when you look at the peripapillary NFL, you clearly see some increased thickness. And I agree, it's very difficult in an acute situation to place this diagnosis, but this is, in my opinion, how they look like, the LHON discs classically like this.
I agree. Just as of note, obviously don't look at the green circle, which all looks normal. Just look at the curve, which is more temporally elevated and inferiorly. So yeah, that would have been a clue as well, right?
Dr. Plant, do you think that tobacco can, it can bring about LHON? Or for that matter, ethambutol, the, hidden cases?
Yeah, well, it certainly increases the risk, doesn't it? I think, but the problem we had in London, there was a study made quite a few years ago now showing the increased risk from smoking, but it turned out to be mostly all in one particular family when you put them all together. And probably if we now knew a bit more about the various mutations, we could say something else. But it's certainly advisable to advise anybody who has a Labour mutation not to smoke. Ethambutol is an interesting one. again, because these mutations pop up in patients who have ethambutol optic neuropathy, and you can never be quite sure how significant they are and what would have happened without the ethambutol and so on. But these do seem to be risk factors.
And if I'm trying to extend Gordon's remarks, we also looked at patients with nutritional amblyopia and toxic optic neuropathy, and we looked at mitochondrial, but also DNA mutations in depth. And patients, because we see so many patients who are chronically intoxicated and do not have any problems. So what is the factor that facilitates development of optic neuropathy? So we looked at nuclear genes in patients who developed those optic neuropathy, and we published a study, I think 1 or 2 years ago, with my group from Angers in France, and we found a significant number of either DNA mutation in the nuclear gene, or at least VUS variants with unknown significance at that time, who were related. So I would still think that the dogma is right. The dogma is unexplained optic neuropathies, totally unexplained optic neuropathies. It's reasonable to look at genes. No, absolutely. In fact, we're when I was collecting cases in Tanzania and Cuba, and also in London, who were mostly poor nutrition associated with alcoholism rather than just poor nutrition. So they were different groups. We didn't really find the Leber mutations that were available at the time, but I've still got all the DNA samples. Oh, well, that's an interesting thing, because
so we're planning to look at them again.
Right. Look at nuclear genes. You might have surprises.
I mean, but the story at the time was important, because various people were trying to say that all of these cases in Cuba were related to mitochondrial disorders, and I don't think you have to have a mitochondrial genetic disorder to get this syndrome. I think that's not right. But clearly there will be risk factors, and some of those risk factors could be polymorphic mutations, that very rarely appear as typical clinical cases.
Absolutely.
Thank you, Dan. That was a really interesting case.
Very good.
Thank you very much.
We won't forget that. I called the edema sign, we called it the wishbone sign, because the Americans know about wishbones, because there's a formation in American football called the wishbone, when they get into a V shape. But what we were talking about was edema. This is atrophy.
May I make a comment? Hello, Dr. Dan. It was great, your case. And we have 2 cases here in the oven to be published in such things that you just mentioned. They are the 2 Leber's cases with gadolinium enhancement of both optic tracts as your case.
Wow, real enhancement?
But you didn't have enhancement.
No, I did not have enhancement. Enhancement is exceptionally rare. So hurry and publish.
Yeah. Actually, the first case was published in 2011, and the other ones, the 2 or 3, for instance, they were published in 2020. So cases are appearing, and they are just in the oven, in the way to be published. Maybe you have another case with you.
No, mine is not enhancing, as Gordon said. But let me ask the whole panel, because I'm very interested about who in the panel saw unquestionable enhancement of the optic nerves, even optic nerves in acute labors.
Not me.
Not here.
But I've seen cases presented.
Okay.
And then you begin to wonder about dual pathology again.
Exactly. Yes.
And those two cases are from different mutations, you know. So I think we must publish it so that you can see if there is any correlation. Yeah.
We have a good journal who could welcome those cases. I'm joking.
Even Veena is reported once in a while. It's rare, but it's a pity Veena is not here. But I think she's also mentioned that once in a while it can enhance. So with that, I think we'll move to the next case, and I'll be discussing the case. Why my slides are not moving?
Can unshare and share again.
Yeah. Are you able to see my screen, everybody?
Yes.
Yeah. So it's my honor to invite Dr. Stephen Hammond to present his case. Professor Hammond is a consultant neuro-ophthalmologist at Rigshospitalet, Denmark, and visiting professor at Rothschild Foundation Hospital, Paris. His pioneering research focuses on advancing retinal and optic nerve imaging modalities, particularly OCT, while incorporating AI algorithms to detect and predict neurological disease through ocular imaging. He has published more than 150 peer-reviewed papers, and he leads the Visual Pathway Research Center, VIPER. In 2015, he founded the International Optic Disc Drusen Studies Consortium, which unites dedicated optic nerve researchers from 15 countries across 4 continents. He also serves as a co-chair of the Neuro-Ophthalmology work group in the European Reference Network for Rare Eye Diseases. So over to you, Professor Hammond.
Thank you very much, Shika. I just can you see my screen now?
Yes, can see your screen, your slides too in full screen.
All right, that's perfect. I just remove this one and here. Okay, so thank you very much for this kind invitation. It's always a great pleasure and honor to participate, and I learn so much every time from all the fascinating cases. So when I was choosing the case here today, I was thinking either you can choose a case that is truly exceptional and very rare. Sometimes the problem with the very rare cases is that they are so rare that you never encounter them again, and the learning points are somehow hard to find. And in the other end, there are cases that are much more common, but where we don't really have a good explanation. And I think I have an explanation for this kind of case, so that's why I was bringing it today. And I also think it has some interesting discussion point that we hopefully can get to in the end. Okay, so let me just, okay. I have no conflicts of interest. And this is a story of a 25-year-old woman who comes to the on-call service, and she was sent from her own ophthalmologist with a diagnosis of left-sided optic disc edema. She is pretty healthy. She has some asthma and migraine, for which she gets medication, and it's well controlled, and otherwise she's healthy. For the past 2 weeks, she has had visual complaints while she has been seen by an optician. And the optician takes some photos and sends the patient acutely to be seen by an ophthalmologist. And upon questioning, she has some tired eyes for a couple of weeks, and she's also experiencing pain on eye movement, but it's actually on both eyes, she says. She has no other symptoms. Upon examination in the on-call service, she has a normal visual acuity, a normal color vision. Slit lamp exam is unremarkable. On a motility exam, she has free motility, but she experiences pain in outer positions, normal intraocular pressure, and the pupils have been dilated from the specialist in ophthalmology who sent her in, so she cannot get her pupils examined. So this is how her fundi looks like. And can you see my mouse here?
Yes, we can see.
Yes. So if you look at the right disc, it looks, well, what I would say pretty normal. Nothing special about that. But if you look at the left one, it clearly looks different, and it looks with a blurred margin. And perhaps there is some swelling. It's a little hard to see on this. Some true swelling is a little hard to see on this fundus image. But what happens here with this lady is that one suspects that she has a left optic neuritis, which is atypical because she doesn't have reduced visual acuity yet, and she has normal color vision, but she has pain on eye movements, and she's a young woman and might be on the safe side. So when they see her in the on-call service, they order a subacute MRI of the brain and orbits with contrast and refer the patient to neurology. And for the next 3 weeks or so, she has several exams been performed in the neurology department. Here, she no longer experiences pain on eye movements. She has blood workup for MS differential diagnostics, including NMOSD and MOGAD. She has a chest X-ray and electrophysiology, including visual evoked potential. All exams are negative. She has a neurological exam, which is also unremarkable. She even has a lumbar puncture and an examination of her CSF, which is also unremarkable. Her MRI of the brain and orbits are also normal. So she is seen in our neuro-ophthalmology service on day 28 compared to when she was seen in the on-call service. And now I see her in neuro-ophthalmology. And here again, the exam is completely normal, including she has no longer any pain on eye motility. This is her visual fields, nothing much to say about this, left and right eye. And this is how her discs look like. They look completely the same. Here, the whole picture on the left side is a little more blurred, but apart from that, it looks the same with a normal disc on the right side and a blurred disc margin on the left side. When we do the peripapillary RNFL, it's completely normal with a global value of 98 and 97. And when we do the OCT of the optic nerve head, here we clearly see the reason for the asymmetry. So looking on the right side, we see these hyperreflective lines, prelaminar hyperreflective lines, indicative of some axonal crowding. There are also some drusen when we scroll through the optic nerve head. These are not shown here. On the left side, however, it looks completely different. Here we see the whole disc is elevated. And on the infrared image, you can see that there is a contour that goes like 270 degrees surrounding the optic disc. And this is seen also here on the side. This is the forms. And here you also see the hyporeflective structure within the disc. It's optic disc drusen. Here are the vessels. So the reason for this big asymmetry between the two eyes is clearly the forms. So she has a unilateral pseudopapilledema due to drusen-associated forms. We can go through the disc and see it together. Here you see the vessels, and here you see the forms appearing, and you can see how it lifts up the entire optic disc. So this is truly the explanation for the disc elevation. You can see it here nicely on the 3D reconstruction. So the forms appears to be the explanation for the unilateral pseudopapilledema in optic disc drusen. So the question is this the only case? No, as I mentioned to start with, this is actually a kind of a common thing. Here you see a 14-year-old girl. She was referred from her own ophthalmologist. She has had headache for 2 weeks and a suspicion of right-sided optic disc edema. Here again, you see complete asymmetry between the two eyes. You should almost think that these are taken from two different individuals. They are not. On the right side, you have clearly blurred margins and normal margins on the left side. And if you do the OCT of the optic nerve head, here again on the right side, you see the forms that is elevating the optic disc margins, and there are no forms on the left side. Again, unilateral pseudopapilledema due to ODD-associated forms. This is a 21-year-old asymptomatic woman. She was referred from her own ophthalmologist with suspicion of right-sided disc edema. Again, completely different optic discs on the two sides. And you do the OCT, you see the forms on the right side and no forms on the left side. And if you scroll through, you see all the optic disc drusen. They're just located differently, different size, causing forms on one side and not on the other. So again, unilateral pseudopapilledema due to ODD-associated forms. And the final case is a 17-year-old asymptomatic girl referred from her own ophthalmologist, again with a suspicion of right-sided optic disc edema. Same picture, unilateral blurred disc margins. And you do the OCT and you see nicely the forms on the right side, but not on the left side. Here you clearly see the drusen more pronounced in these sections. So on or off, that was the title of my talk. It actually gave away. On, it was optic neuritis, and ODD is optic disc drusen. There are some learning points, I think, that are interesting. Here we have seen 4 examples of unilateral pseudopapilledema due to ODD-associated forms, and one of them was misread as optic neuritis. First of all, in optic disc drusen, optic nerve head symmetry is not always the case. And if you have a patient that comes in with unilateral optic disc swelling or elevation or blurred margins with few or no symptoms, think of optic disc drusen and maybe wait a little bit with starting doing all the additional exams. Just do the OCT of the optic nerve head to find the drusen and slow down. So what are the perspectives here? There are at least 2 things that I would like to also discuss a little bit with the panel if we have time for it. I think what we know is that in younger patients, but also apparently in the older patients, optic disc drusen can be associated with NION. And especially in the ones that are younger than 50 years, we see more than 50% of NION patients that actually have drusen. So I think it's very interesting in bilateral drusen with unilateral pseudopapilledema, such as these cases we've just seen. Where is the risk of NION greatest? Is it on the pseudopapilledema eye or is it on the other eye? In other words, does forms provide a risk factor for NION, or does it protect against NION, or is it equal? I think that will be a very interesting thing to study in order to learn more about forms. And the second thing I would like to discuss, if we got some time for it, this is the dogma of interocular optic nerve head symmetry. Could this be challenged in general, not only in terms of optic disc drusen? And here, for example, I'll mention if you have a patient with NION, you always look at the fellow eye and you say whether there's a disc at risk on the fellow eye. You cannot really say whether the eye in question, whether there's a disc at risk there, because there's disc edema. So it's only if you happen to be so lucky that you have photos of the patient before the NION event, you can say whether they actually had a disc at risk. But perhaps they had also a high degree of symmetry. So the fellow eye, is it always a proxy of the current eye? I don't know. I think I was a little not shocked, but surprised to see so many cases of asymmetry among our drusen patients. And that's why I wanted to bring it here today. Thank you very much.
As usual, excellent cases. The entire series was very beautifully documented. Just one question, Stephen. Did you also kind of count the number of drusens in the eyes? Maybe one eye had not only forms, had forms because there were more drusens in that eye. So you showed a beautiful video. I would like you to show to the audience. The drusens could be seen very nicely in that video when you went through the cut sections of the disc. Could you just show the drusens in the cut section? When you can stop it when the drusens here.
Here, for example, you have one here.
Yeah.
And you have one here.
One on the top. Yeah.
And here, come again, that one here. Here are the hyperreflexive lines. And,
yeah, the entire drusen could be seen there. So, have you had any study where you've literally counted the number of drusens in the eyes?
Yeah, well, it's easier to, no, we haven't really done, the answer to your question is no. We don't have a study where we counted all the drusen, because the drusen are easy to count if there are only like one large one or a few small ones. But such as this case, it's really, really hard.
So
and
in the right eye, it was only, it wasn't even a formed drusen. You said they were only hyperreflective horizontal lines.
No, they also had drusen.
They also had drusen.
In all 4 cases, there were drusen in both eyes. It was just not seen in the particular section that I showed you.
Yeah. So forms is basically, it's the lack of space at the disc, and because of that, the axons are kind of, going out of where they should be. So maybe there are more drusens in that eye. That's why there is forms. And the other side, the drusens, there's still space. The number of drusens are less, hence there is no forms. We'll also have Dr. Plant's comments on that.
Yeah, I'm not sure, Shika, that it's so simple, because I've seen so many cases with very, very tiny drusen, and perhaps only one very small, but with large forms. I have some beautiful cases with children with very large forms and just one tiny little drusen, and other cases with very large forms, very large drusen and no forms. So I think it's more or less arbitrary, but yeah, it has to be done, the study.
Dr. Plant.
Yeah, I just wanted to say that there are, to me, there are some minimal signs of crowded disc, which is often what we're looking at in the fellow eye in NION and so on. For example, that the vessels emerge centrally from the disc is one. I think there are some minimal signs. And I think it was the case with yours that the other eye did show that feature. And then early branching of the vessels is another feature. So even in discs that are quite flat, there are these signs which can be helpful if you think there might be either NION or drusen in the other eye, depending on how old the patient is. When it comes to, I think it's likely, we know that in NION it's very unusual to get recurrent attacks in the same eye. Mm-hmm. And when we see those cases, we often think there's something else going on. And the accepted wisdom for that is that you've lost a load of nerve fibers. So you don't have a crowded disc anymore. Yeah. And I think what happens with drusen is the same thing, but happening slowly over a period of time. Eventually, you lose so many nerve fibers, you just don't have the disc at risk anymore.
Exactly, yeah. I agree.
As you know, I prefer to call these PADs, peripapillary axonal distension, because that's what they are.
Yeah, that's the true, the farms, it's a OCT specific term.
Yeah, yes. I mean, this was all described in the 19th century. I mean, the first pathological studies of papilledema all showed this. That they're not of drusen, but with papilledema,
Exactly,
it was
all the
shown
old pattern studies.
the swelling is due to axonal swelling due to hold up of axonal transport.
Yeah, I
So
agree.
you have some preliminary study that shows that it has a protective effect. You know, that's a very novel thing that I heard today, that you feel that, you know, NaION is more, it forms, I mean, like, it's more in the eyes where there's no forms, right? That's what you were trying to say.
I don't know. No. I was just,
No,
putting it up as a question. I think it's a very interesting discussion whether you can have a similar kind of asymmetry in NAION cases that you have with the drusen cases, because what I was saying, that when we have NAION, we don't know whether there's asymmetry because you already have the disc edema.
So one of the very important questions there is that drusen optic disc drusen neuropathy, you know, which is not actually an ischemic optic neuropathy. It's just that, you know, there is a patient presents with a field effect, not with ischemic optic neuropathy. It's like because of the drusen, and what's the treatment that can be, you know, offered. I think we've discussed it in previous NOSIG meetings also, but anything new, anyone's doing alphagen, this brimonidine eye drops or anything to prevent the progressive vision loss in patients with large drusens?
I would love to say yes, but unfortunately we don't have anything available at the moment. Sorry about
So
that.
nobody's trying also anything. Dr. Plant, what do you offer your patients who's like desperately, you know, on the lookout for some treatment because of the progressive field loss because of optic nerve head drusen?
Yeah, well, throughout most of my career, there was nothing to offer. But I don't know if your experience is the same, Stefan, but I found some of the most severe cases of visual loss from drusen were in young patients, often starting in the teens. Because, you know, later on in life, the whole thing tends to become quite inactive. But, you know, as with glaucoma, the visual loss was usually asymmetric in the two eyes, and asymmetric nerve fiber bundle defects in the two eyes. So it was very unusual for patients, for example, not to be able to drive. And then the whole thing tended to settle down as they got into adult life, and they didn't progress anymore. But obviously, experience is much more extensive now. But to see somebody who was severely visually impaired from optic disc drusen and no other pathology is, I would say, quite unusual.
Thank you, Stefan. Thank you, Dr. Plant, for your comments. I will move on to the next case. And can you see my screen? Can you see my screen?
I can.
Yeah.
Yes, sure. Go ahead.
Yeah. So to discuss Dr. Luciano's case, I invite the next panelist, Dr. Revati Ramesh. Dr. Ramesh is head of Neuro-Ophthalmology department at Dr. Tony Fernandez Eye Hospital. She completed her MBBS in DO in Chennai and has dedicated her career to private sector ophthalmology. And after completing her neuro-ophthalmology observership at Shankar Nethralaya, Chennai, she spent the next 13 years at Dr. Tony Fernandez Eye Hospital, Aduva in Kochi, where she leads the department. And she specializes in optic neuritis diagnosis and management, idiopathic intracranial hypertension management, and especially third cranial nerve palsies. Welcome, Dr. Revati. And now I invite Dr. Luciano Simao. Dr. Simao is Associate Professor of Ophthalmology and also the Head of Neuro-Ophthalmology Services at Minas Gerais, Brazil. And he completed his fellowship training in neuro-ophthalmology at Federal University of Minas Gerais and an observer fellowship at Wills Eye Hospital, Philadelphia, United States. He has published several peer-reviewed articles and he's co-authored books on ophthalmology. He has given numerous lectures at national meeting, and he also serves as an editorial board member of Neuro-Ophthalmology and a specialty reviewer of ABO, RBO, and the Journal of Neuro-Ophthalmology. He is a co-founder of BRANOS, that is Brazilian Neuro-Ophthalmology Society. So welcome, Dr. Luciano, over to you.
Okay. You're seeing my screen?
About to, yes. We can see your screen, full screen. Yeah.
Okay. Oh, thank you. I would like to start thanking for this outstanding opportunity to participate in this great meeting once again. Here we have the X of the question, and I'm going to start with a 33-year-old woman, non-obese, healthy, that underwent an eventful tight and gluteus liposuction due to fat deposits in the lower limbs. She was discharged on the second postoperative day. However, on the fourth PO day, she had fatigue, one episode of syncope, followed by severe headaches, tinnitus, nausea, and vomiting. And she also experienced simultaneous visual loss bilaterally. Then she was taken to an emergency room, and there it was diagnosed a severe anemia. The hemoglobin titers are 4, and also the red blood cells and hematocrit were also low. Then she received 3 units of PEC RBC, and he achieved the level of 9 in her hemoglobin. She had a normal brain and orbit CT, and an inpatient ophthalmologic examination revealed papilledema bilaterally. And she had her first diagnostic impression of a bilateral and simultaneous NAION. And here you can see both these optic discs are swollen with hemorrhage more on the right, and then she was discharged. However, her systemic symptoms and visual loss progressed, and then she was taken to an ER again. Now, the brain MRI and MRV revealed a partial empty cella, reduced caliber of the right transverse sinus, no cerebral venous thrombosis, and a striking T2 X-shaped enlargement of the perineural spaces of the optic nerves with the chiasm. Those are findings are very suggestive of intracranial hypertension. So she underwent a lumbar puncture with the opening pressure of 36 centimeters of water with normal fluid analysis. She took acetazolamide 1 gram per day, and then she was discharged and referred to a neuro-ophthalmic evaluation. Her first neuro-ophthalmic evaluation on the 14th PO day revealed visual acuities of 20 bilaterally, but slow on the right. Then she had a test is full, but is low on the right. Her pupils revealed the right RAPT, and the contrast test was also full, but slow on the right. And by confrontation, Amberless grid test was seen dense nasal scotoma on the right. Her motility was full, biomicroscopy and tonometry were revealing, and the fundus revealed papilledema with flake-shaped peripapillary hemorrhage bilaterally more on the right. Her blood pressure was 90/60 at that time. The computerized visual fields confirmed the dense nasal scotoma on the right, and some scattered unspecific visual field defects on the left that were confirmed by the Goldman's visual field. Her OCT at that time revealed raised peripapillary retinal nerve fiber layer and normal ganglion cell layer bilaterally. And you have a question: does she have a bilateral anterior ischemic optic neuropathy or a fulminant idiopathic intracranial hypertension after the liposuction? And we have a paper that showed a patient that was diagnosed by bilateral NAION after high volume liposuction, and she had the same case of severe anemia, hypotension, and they are all conditions of hypercoagulability. And she also had a pulmonary embolism due to fat or maybe thrombus embolization. And they also found dural venous sinus thrombosis in that case. And the conclusions of the authors was that the patient had a bilateral NAION and signs of intracranial hypertension simultaneously. Here we have another case of bilateral visual loss complicating with bilateral NAION with swollen disc with hemorrhage, constricted visual fields, and the patient had also previous and undiagnosed IIH scenario as she had a history of long-standing bilateral transient visual obscurations. And here you have a question: was it investigated a relationship between anemia and IIH? And this very interesting paper revealed that the anemia was more prevalent in IIH group. The severity of anemia was mild in both groups, and the severe anemia was only found in the IIH group. And also the platelets count was higher only in IIH group. And the authors concluded that there is, in fact, a potential causal relationship between anemia and IIH, and the complete blood count should be evaluated routinely in those situations. But you have a question here: what's the pathophysiologic mechanism between anemia and IIH? It's known that iron deficiency anemia, IDA, is a hypercoagulable state, and iron inhibits thrombopoiesis. The IDA is associated to thrombocytosis, and the microcytic RB cells show reduced deformability, and there are conditions of hyperviscosity. And we know that anemia is a low oxygen delivery status, and that makes as a compensatory mechanism, makes the brain dilates vessels to maintain oxygenation, and this increases the intracranial volume, and it may be associated with obstruction or sluggish flow in the venous sinus, with or without of cerebral venous thrombosis. And those are all conditions that may contribute to elevated intracranial pressure. It's worth mentioning that the platelets in this study were elevated in IIH subjects. We have another elegant paper that showed 5 new onset severe anemia and fulminant IIH, and all patients had resolution of the papilledema after treating anemia alone. There was no recent weight gain in 2 non-obese patients. They also referred a previous systematic review of 74 IIH cases linked to anemia, and only 21% of the patients were obese. 60% of the patients improved without intracranial pressure lowering therapy, And it's believed that there is an anemia threshold linked to IIH, and it's believed that the hemoglobin titers must be around below 8 to 10. And regarding our case, the acetoacetamide was tapered as she progressed with the remission of the symptoms and as she used the iron supplements. Hematologic, neurovascular, and cardiologic evaluations were also ordered, and other to investigate our other risk factors, and they are all ruled out. In her hospital medical report, there was no precise liquid loss during the procedure. She had a prolonged intervention for about 3 hours. She had arterial hypotension, and also that was her pressure during the procedure too. There's no mentioning about fluid shifts with epinephrine that may contribute to the ischemic situation. But strikingly, she had 15 episodes of vomiting in the first 8 hours PO, and she wore pneumatic compression boots on the first PO day. Her last follow-up was revealed 2020 bilaterally. The fundus showed flat optic discs, and the visual fields maintained with the dense nasal visual field effect on the right. And now we have the OCT with decreased peripapillary RN, FL, and GCL bilaterally. And now I have a question answered, as now we may conclude that she had a bilateral ANION and fulminant idiopathic intracranial hypertension after liposuction. And I would like to end this talk with a slide of Aikara Med's lecture here in Brazil last Saturday. And thank Satya, all the scientific committee, for being out of their comfort zones and make this magical and superb meeting happen again for the 5th year. Warmest thanks.
Dr. Luciano, what do you think are the main symptoms and signs that were overlooked during the first hospitalization, which prevented a correct diagnosis in the first instance itself?
Oh, Revat, it's a very good question, because as she had a severe anemia, and she had that 15 episodes post-operatively, and also hypotension. They were all situations associated to NAION. But as she had simultaneously tinnitus, nausea, vomiting, severe headaches, and those symptoms were undervalued, and she was discharged without the other the other diagnosis.
And one thing about other specialties, do you think there are any lessons to be learned by the plastic or bariatric surgeons from your case?
Oh, absolutely. It's very important to highlight that all patients that undergo such kind of surgeries with significant fluid loss to have the CBC repeated on the first day PO, especially cardiac or orthopedic or plastic surgeries like that. And this probably will preclude catastrophic outcomes like this situation. I remember a recent case that I saw a patient in the same scenario, and she had along the duration of the plastic surgery, she underwent a 9-hour multi-site liposuction, and she developed severe anemia. And besides the transfusion, she got blind on the 4th day PO. So it's something that we should advise the people regarding that situation. I think this is something that we are more concerned about.
So it was the NAION that caused blindness, not the IIH. Luciano, what do you think?
No, a good question. This second case, unfortunately, she had the classic signs of NAION, and her MRI and MRV were normal. That excluded the IIH, but the MR of the brain MRI and the orbits showed ischemic signs of that were related to NAION. So unfortunately, the patient got blind, and in a situation that we can't postponed is the transfusion but that's the only way that oxygen may be delivered to the body. It's like a situation as we are in a flight, and the pilot just announces that the fuel is running out before impact, so we should be very worried about this. Yeah.
Thank you. Great case. Again, Dr. Plant has a comment. Yes.
Yes, it just there are two things that are very rare and unusual and happen usually because something else is going on. One is bilateral simultaneous NAION. I mean, the garden variety of that, it's not provoked by anything specific that's happened, and therefore it's not going to happen in both eyes at the same time. And when you do see it, it's usually perioperative or related to, and even posterior ischemic optic neuropathy as well. We see in this situation, often associated with posture during the surgery, blood loss, and so on. So this is the other thing that can happen, but rarely, is optic disc infarction due to papilledema, due to raised intracranial pressure. It's a very unusual thing to see, but I saw it once or twice, and the hallmark is that you see a sectoral defect in the swollen disc and so on. But again, this is an unusual thing. So to get either of these, you have to have some sort of collision of things happening. I was wondering if these surgeons are checking the blood count before the surgery. I mean, perhaps the patient was already anemic, because there's no doubt at all that anemia is now well recognized as a risk factor for IIH, although most of the patients we saw were also had a high BMI, but not every single one. So all of these things are unusual, and we need to be wary of them. So it's very, very helpful cases to show.
Like I mentioned, Dr. Plant, thank you for your priceless comments. And her hemoglobin levels before surgery were 13, and they just go down to 4.
Shall we move to the next case? Or Luciano, you were sharing something. Yeah, please.
We lost you in between.
I'm still sharing.
Yeah, we couldn't hear you in between.
Okay.
Because there's some audio issue. You can proceed.
Okay.
Luciano, I'm proceeding to the next case. Maybe by that time, if it's sorted, you can share it.
Okay.
Okay. So with that, we'll move to the next case presentation. And I invite the panelists for the next case presentation, Dr. Sovita Rath. Everybody can see my screen, right? Satya, my screen is seen?
Yes,
Am I
ma'am, we can see.
Yeah.
Yeah.
So welcome, Dr. Sovita Rath. Dr. Rath is she serves as a faculty in leads the neuro-ophthalmology services at Shroff Eye Hospital, Delhi. And she has received her postgraduate training and long-term fellowship in pediatric ophthalmology, strabismus, and neuro-ophthalmology from the prestigious L.V. Prasad Eye Institute, Hyderabad, and is a fellow of the International College of Ophthalmology. She is an expert in pediatric and adult optic neuropathies, toxic optic neuropathies, ocular electrophysiology, and she is also an excellent pediatric cataract and complex strabismus surgery expert. She has over 35 publications and numerous awards to her credit, and she is actively engaged in teaching and research. So welcome, Dr. Sovita. So the next case will be presented by Dr. Gordon Plant. He doesn't need any introduction. Everybody practicing neuro-ophthalmology world over knows him. He is a global educator and a mentor. He is an international authority in neuro-ophthalmology. He is trained in neurology at National Hospital Queen Square and Vision Science, supported by Wellcome Trust in Cambridge, and as a Medical Research Council traveling fellow at the Smith Kettlewell Institute in San Francisco, where he attended clinics with none other than Dr. Bill Hoyt. He was appointed consultant to the National St. Thomas and Moorfields in 1991. While in full-time NHS consultant, Dr. Plant has published over 300 articles with an H-index of over 70. He's a passionate believer in the need for physicians specializing in eye disorders, and as a training program director, initiated the first medical ophthalmology rotation in London. He has retired from clinical practice in 2020, but remains active in research and teaching. So thank you for giving us your time. And over to you, Dr. Plant. We are eagerly waiting for your case. Yeah.
Okay, can you see?
Yes, we can see the full screen.
Okay. Well, as you've been hearing, I haven't done in clinics for quite a while, so I'm reporting to you a case that was seen by one of our consultants, Dr. Burke, with the and the junior involved was Dr. Tari Bagel. I don't have the various things. I don't have OCT. I don't have, but anyway, we can make something of the case. So this was a 65-year-old woman who presented with a 2-week history of an aching pain behind her right eye and some frontal headache. A week into this, the vision in the right eye began to blur, and she noticed that she had this pain was worse when she moved the eye. And she also had some transient visual obscuration. So on standing, suddenly the vision would dim in the right eye just for a few seconds. She also complained of some scalp tenderness, but no other GCA type features. And she had a 1-year history of intermittent pulsatile tinnitus. She hadn't sought any advice about that. And she had some joint pains and and some generalized fatigue she was complaining of. She was known to have chronic lymphocytic leukemia, which had been diagnosed last year and was under hematology for that. She also had these other features you can see here. And negative was that she was not overweight. This was her treatment. She had treatment for asthma and was on acyclovir and amlodipine when she was first seen. And her visual acuity was and color vision were not too bad. The pressure was on the high side in the right eye, the intraocular pressure, and at that point there was no RAPD. The eye movement seemed quite normal, anterior segment normal, but she had bilateral optic disc swelling much more marked on the right, which also showed a peripapillary hemorrhage. At that stage, the vitreous appeared normal and the retina was normal. And so I don't have many images here. I do have these read free of the optic disc. So this is the more swollen right eye. Here's the hemorrhage. You can see my pointer. Yep.
Yes, we can see the pointer.
Yeah, okay. So there's the little hemorrhage there. And yes, a much less marked degree of swelling, but confirmed on the OCT of the left eye. Any thoughts? Or shall we go to the end and then have the thoughts? Let's press on. So basically, this is certainly not an IIH patient, but she's got bilateral asymmetric optic disc swelling and also some ocular hypertension, known CLL. So what was thought at the time? Did she have an intracranial space occupying lesion? Was this malignant hypertension? Well, she didn't have hypertension, so that was right. Had she had a venous sinus thrombosis? Did she have IIH? Well, she's a bit on the elderly side and not obese, some sort of meningeal process. Or was this an optic neuritis? Is this ischemic or compressive? So a pretty extensive initial potential list of diagnoses. Was it something to do with the hematological malignancy? That was really a major thought at the time. So she had imaging, and this showed no intracranial or orbital abnormality, and there was no evidence of any cause of raised intracranial pressure on the initial CT. She then went on to have an MRI of head and orbits, which again showed no definite abnormality. Certainly the retrobulbar optic nerves were normal. There was no evidence to confirm a diagnosis of optic neuritis. But it was noticed that she had lymph nodes associated with her CLL. So the conclusion from that, all of that, was that no definite cause for all of this has been found. Now, she did have moderately raised opening pressure on her lumbar puncture, and she did have more white blood cells than she should have in the CSF. But it was otherwise normal. There weren't enough cells to do very much with them in terms of what these white cells were. And there was no evidence, however, of meningitis. Now, by day 8, she's deteriorated considerably. In the right eye, her vision's now down to 260, and it's getting worse in the left eye. She's got she can't read any of the Ishihara plates now. And now the intraocular pressures are on the high side in both eyes, and she has a very definite right RAPD. eye movements were full, nothing in favor of giant cell arteritis. So she has perimetry on day 9, and this shows in the right eye there's a preserved central island of vision. So a rather typical picture of papilledema due to raised intracranial pressure, which is clearly advancing very rapidly. And in the left eye, she has an inferior peripheral field defect, which again is compatible. It's now noticed that she has some subretinal fluid on the right, and also some other abnormalities in the retina. Unfortunately, I don't have the OCTs to show you, but the main significant finding here is that she has some subretinal fluid, which is presumably extending out from the optic disc, or could indicate some involvement of the retina. And the ganglion cell layer is reassuringly preserved at this point. So the hematology team said there was no contraindication to starting on high-dose corticosteroids if this was thought to be some form of inflammatory condition. And they certainly didn't think it was likely to be related to the CLL. Now, my thought when this patient was discussed at the time was that this could be a prelaminar optic neuritis, and this is something that I'll talk about a little bit more at the end. The point being that the retrobulbar optic nerve is normal on imaging, but the pain on eye movement suggests some meningeal involvement with this, compatible with optic neuritis. But the optic nerve itself, as I say, is normal. So all of the pathology is at the optic disc. And then we also have some subretinal fluid, which could be coming from the optic disc. Anyway, she was put on corticosteroids. There was nothing abnormal in her bloods. And of course, she had aquaporin for an anti-MOG. And the top diagnosis here was anti-MOG, because this is known to do all sorts of strange things, including associated with raised intracranial pressure, including having more retinal involvement than we expect to see with either NMO or multiple sclerosis. But these were negative. So when she was seen, where are we now? It's been going for a couple of weeks now. Her vision has improved following the corticosteroids, but is still down. The pressures remain on the high side, and she's now on the right has a large central scotoma, and the left eye some more focal changes. But it's now noted that she has a vitreous haze and evidence of vitreitis, and also some sheathing of vessels at the posterior pole, suggesting some vascular involvement. Fortunately, she has still only mild attenuation of the ganglion cell layer on the OCT, but there is some thickening of the steroid. So we've got some evidence of improvement on the corticosteroids. So she's sent for a vitreous biopsy, which isn't particularly informative, and her vision got a bit worse after that. The lymphoma MDT suggests a bone marrow, but as I say, they don't think that her pre-existing condition is relevant here. She does have some hilar lymphadenopathy. We know she's got a lot of... and the oligoclonal bands are positive, suggesting that she's got antibody production within the CSF compartment. And she has a raised CSF protein with still quite a few lymphocytes knocking around. And then comes the most important result, which is that she is positive for CRIMP5, and she's now found to have a small cell lung cancer. So what happened, I say, after the vitrectomy, her vision went down, and she's developed an inferior retinal detachment. But actually, her vision is holding out reasonably well, and the optic disc swelling is remaining. Now, so we think here that she did have raised intracranial pressure, but the major pathology here is what I'm calling a prelaminar optic neuritis. Now, this is something that actually I introduced first of all in Vivek Lal's book, and then it came into our a couple of years ago. We have our 100 author, thanks to any of you who contributed, optic neuritis classification, and I also introduced it there. And this is the situation where we have a swollen optic disc, but with clear evidence of inflammation related to the pattern of visual loss and so on, but a normal retrobulbar optic nerve on imaging, apart from some evidence at times of a perineuritis picture. And this can also be associated with the generation of subretinal fluid. And when that's extensive, that then becomes a condition that has, so that condition has a difficult diagnosis of papillitis, because it's a term that's been used for a lot of different things. But also with the subretinal fluid, we then have a diagnosis of neuroretinitis, which again is a very unsatisfactory term, because actually there may not be any inflammation, there may not be any retinitis as such. All of the fluid may be coming from the optic disc, which we can see with ischemia and papilledema and other things. So, but I think from the immunological point of view, we can see that the optic nerve head, the prelaminar optic nerve, is very different from the rest of the optic nerve because there are no oligodendrocytes here. That's because we can't have any myelination of the optic nerves. So those where we have MS and so on, MS and NMO, these are very unlikely to produce inflammation of the prelaminar optic nerve in isolation. However, this is seen and in some situations, and we think that this needs to be regarded as a different syndrome. So the crimps, these were the name for the dastardly fellows who were involved in press ganging people to work on the ships of the British Navy, which was so unpopular in America that contributed to the fact that we lost the American colonies. And here we have CRIMP5. The protein is very much involved. CRIMP5 is particularly, of the other crimps, there are another 4 of them, is particularly found in the optic nerve and retina, and seems to be mostly involved in neural development. But this is why we can have this very specific immunological condition occurring, affecting just the prelaminar optic nerve and to a certain extent the retina. And I would looking forward to hearing any comments you may have.
Dr. Sovita?
Yes. So thank you, sir. That was quite interesting. I mean, it is misleading first that one would think it is a paraneoplastic syndrome presenting because of CLL as you read the case or as you listen to it. But quite surprisingly, it has found out another cancer, which is small cell lung carcinoma. So in all this, what I wanted to know is that in this paraneoplastic, why was the intracranial pressure raised? How do we explain that in the absence of any MRI findings? I agree, it does present as a prelaminar optic neuritis, and that's why the disc edema could be associated. But a raised ICT without any neurological, and even the CSF oligoclonal bands were raised. They were found.
Yes, well, I think this is something that is well recognized with MOG, optic neuritis.
But your MOG was also negative.
Sorry? Yes, no, I'm just making the point that it's very with MS we don't see raised cranial pressure. With NMO, it's not a feature. But there's something about MOG that is much more extensively involved in the nervous system. For example, we see epilepsy with MOG, and I have a case of Cryon, which I was treating for many years, and she also had epilepsy. And it turned out that whenever I gave her more steroids, her seizures would stop. And the epileptologist found this very hard to believe, but we tracked her over many years, and it was very consistent. So MOG can do other things in the nervous system. Exactly how it causes raised intracranial pressure, presumably through some meningeal involvement, I don't know. But it has also been reported a few times with CRIMP5. And although the protein is concentrated in the optic nerve and retina, it is found elsewhere in the CNS, so can be associated with other things, including, yes, surprisingly, raised intracranial pressure.
I have a question, Dr. Plant. You have pointed out that this particular case has prelaminar optic neuritis. Now, not every, all the time we are able to pick up even normal optic neuritis where the substance of the entire intraorbital optic nerve is involved. The MRI may not be able to, MRI comes negative, right? Many a times. In fact, there was a study presented like only 60% of cases, it's picked up. Like, what are the criteria on OCT one can look for to diagnose the prelaminar optic neuritis?
Well, there's nothing specific about the optic disc swelling, but of course the subretinal fluid is important. But that also is not specific. You can see that it would be very unusual in MS and NMO, but you could see it in MOG, and you can see it with ischemia, of course, with NION. But here, of course, there's also vitritis, and that we would not see with well, we can see it with MS. They were back, but there it's more of the uveitis that's associated with MS, I think, is more like another condition that coexists and overlaps with MS, because intermediate uveitis is seen on its own in isolation in a very similar population to MS, and it's also seen the two together. So I don't think, I think there is a susceptibility there. But here we have just an anatomical fact that the optic nerve, the retrobulbar optic nerve, is not affected on MRI. And this is what we find with neuroretinitis, so-called, which we're suggesting is just a more aggressive form of prelaminar optic neuritis. So we have papillitis with and then just the disc swelling, and then it's the amount of retinal fluid that we get depends whether it comes into the neuroretinitis category.
But do you believe that every case of retrobulbar optic neuritis is should be picked up on MRI?
Yes, I think, but you may be dealing with papillitis. The point is that.
Yeah. So no, I mean, like,
yeah, I mean, certainly
theoretically, one should, if the MRI is negative, one should call it pre-laminar. We've not been doing that, but probably it's again a new insight for me.
Yes, well, the John Chen has a very interesting study coming out. He's looked at cases of papillitis and neuroretinitis using these criteria of no abnormality of the retrobulbar optic nerve on imaging is one of the criteria. They're quite often bilateral, and so on. And he's shown that they have exactly the same demographic. Exactly the same demographic, which interested me a lot, because I'm trying to say that neuroretinitis, which is a misnomer to begin with, is just is the same thing as papillitis, except that there is more obvious retinal involvement. So I've when his paper comes out, I've got a letter attached to it, which puts this point.
So one last bit. This is an autoimmune neuropathy, right? We can.
Yes, well, it's a cancer-associated.
It's like LHON, this autoimmune neuropathy and retinopathy. Right?
It's a cancer-associated. So yes, it's an autoantibody.
Yeah. Cancer associated.
But it's cancer associated, and as soon as that result came through, she went immediately for bronchoscopy and biopsy, and that's the most common diagnosis. But it's of the for ophthalmologists of the paraneoplastic conditions. This is really one to look out for.
Thank you. Great case. Thank you. Thank you. Any other question, Dr. Rath? Do you have any other comment? There are a couple of questions in the chat. Maybe Dr. Plant can answer in the chat as we're running late. With that, we'll move to the last case of the session. Am I sharing the screen?
Yes. You can see the screen.
Yeah. I'm not able to move this. Yeah. So now to discuss the next case, I invite the next panelist, Professor Dr. Meenakshi Dhar. Professor Dhar leads the ophthalmology department at Amrita Hospital and Amrita School of Medicine, Faridabad, NCR, Delhi. And she specializes in neuro-ophthalmology, glaucoma, pediatric ophthalmology, and she is also a prolific cataract surgeon. And she's been teaching for 20 years, and she's been honored by AIOS, WOS, that is the Women in Ophthalmology Society, YOSI is Young Ophthalmology Society, and she has done her clinical observership at UCLA's Jules Steen Eye Center and Addenbrooke's Hospital, Cambridge, and she's given talks in more than 200 she's given more than 200 presentations, has 300 more than 30 publications, and she has also received AIOS Travel Fellowship winner, a life member. She's also a life member of INOS, AIOS, and GSI, and WOS. So welcome, Professor Dhar. Hello. And now I invite Dr. Reed Bebani to present his case. Dr. Bebani serves as consultant ophthalmologist and neuro-ophthalmologist at Ibn Sina Hospital in Kuwait City, Kuwait. His expertise spans comprehensive ophthalmological care with specialized focus on neuro-ophthalmological conditions, contributing to advanced diagnostic and therapeutic approaches in the region. So welcome Dr. Babani, and over to you to present your case.
Thank you so much. And I'd like to thank the organizers for having me. I think this is my second time. And I have to say, I learned a lot today watching the very excellent presentation. So in keeping with the theme of the current session, this case may be actually, you find it very similar. So this is a 47-year-old lady who's a pharmacist. She presented with headache and visual disturbances over the last month, and she was seen by another ophthalmologist who noted bilateral disc edema and had referred her for evaluation. By that time, she already had an MRI and MRV of the brain, which was normal. Her past medical history was positive for hypertension, hypercholesterolemia, and diabetes. And she was on several medications for diabetes, hypercholesterolemia, and she was also using Rybelsus, which is an oral semaglutide, basically an oral form of Ozempic, to treat diabetes, and she has been on it for the last 4 to 5 years. Now, her weight was 63, and her BMI was 28, and just looking at her, she did not seem to be, or she did not look to be like an obese or overweight lady, but she did report having gained about 3 kg over the last year. So this is her visual acuity, and the exam visual acuity was normal. Rest of the exam really unremarkable, including ocular motility and anterior segment exam. And this is her visual field, which was pretty unremarkable, although she does have some kind of a bit of high fixation losses in both eyes. And this is her fundus exam with the OCT. So as you can see, she has bilateral disc swelling, and this is also shown in the OCT nerve fiber layer thickness. And at that point, you know, she's a female, middle age, and she having experienced a little bit of a weight gain. So your differential diagnosis would be number one would most probably be idiopathic intracranial hypertension. Now having been one of the advantages of being the last presenter is giving the opportunity to adjust the differential diagnosis. So we already touched upon the sort of the IIH NION crossroads, and other possibilities in the diagnosis would include things like bilateral ischemic optic neuropathy, although it's a bit unusual. Now I have to remind her she's on oral form of Ozempic. Things like anemia, diabetes, but for some reason she did not seem like a typical IIH patient. She wasn't very overweight, and she has been on Ozempic. And right now I'm at the stage where I prescribe Ozempic to treat IIH. And if you've been following the literature, there've been recent paper and studies that actually showed that GLP-1 agonists can actually reduce the intracranial pressure by reducing the CSF production. And GLP-1 agonists will probably be the future drug to treat IIH. So the fact that she wasn't very overweight and she's been using Ozempic made me think a bit, is there something else that I'm missing? So I asked the patient, are you using any other medications? Are you using supplements? And she said, yeah, actually, I've been using this retinol cream for the last year, and I've been applying it over the eyelid for twice a day now. And she had stopped it by herself a week ago before she came to see me. So maybe I should just ask the panel right now, any thoughts, or should I just continue?
I think continue for the sake of...
Okay. Well, I mean, it did cross the mind, like most of us are familiar with vitamin A toxicity causing pseudotumor cerebri. And this is usually in the oral form of vitamin A. And, this is not a new knowledge. And in fact, the Eskimos, as they were wandering around the North Pole hunting bear for fur and meat, they would consume the animal except the liver, because the liver has very high concentration of vitamin A. So just to put it in perspective, 1 gram of polar bear liver would contain almost 10 times the daily requirements of vitamin A. So this, they actually did find that if you do that, then you would get a severe illness characterized by severe headache and blurred vision. And it wasn't until like the middle 20th century where this was proven scientifically. So most of us are familiar with other formulations that contain vitamin A, and the most common would be Recalcitrant for treatment of acne. And this, based on this paper, has been shown to be associated with IIH, including 6 cases with positive rechallenges. So the median time from drug exposure to the onset of symptoms is around 2.3 months. Intracranial hypertension secondary to all-trans retinoic acid, which is used for the treatment of childhood leukemia, acute leukemia, has also been shown to cause IIH, and this also has been reported now. In this setting, you probably need to differentiate it from infiltrative optic neuropathy as well. But topical retinoids are used really commonly right now, and this is a big industry, and it's the indication for use seem to be very broad. So these include things like cosmetic, basically dark circles, remove wrinkles, anti-aging, but also to treat other medical conditions such as acne, facial wart, even psoriasis. It's a huge industry, and there's a push, and these drugs are being used ubiquitously right now. And the fact of the matter is that many patients would not volunteer mentioning them when you're taking the medical history, because they're not considered as drugs. So unless you ask specifically about any supplements or any topical creams, vitamin A, the patient would not volunteer that information willingly. And these are some of the most common topical retinoids available in the market. Now, just to remind you, these are all off the counter, so the patient can get them without prescription. And they are being used to things like acne or just as cosmetic anti-aging. Now, topical retinoids have been associated with IIH, and I've looked up the literature. There have been several case reports. This one in particular, the patient had taken over-the-counter topical retinol and developed fulminant IIH 6 weeks after he used the medication, the topical cream. The patient was treated with acetazolamide but developed optic atrophy and visual deficit. There's another case, which is kind of similar to the case that I just presented. Patient was mildly overweight, perhaps recent weight gain, but she did start using topical retinol, and then the papilledema resolved 6 weeks after stopping the topical cream. There's another case. In this case, patient used all 3 different formulations, and the papilledema resolved 2 months after discontinuation. This is another case from Headache Journal. It's a 50-year-old with a BMI of 29 who developed papilledema and headache, but she's been using the topical retinol for almost 30 years. Now, what's interesting in this case is that this patient actually had elevated serum vitamin A levels, which kind of suggests that even with topical application, you would get systemic absorption of vitamin A, leading to very high levels. And when she discontinued the topical cream, the symptom resolved and the serum vitamin A levels normalized without any dietary changes. So vitamin A does have a very long half-life. Once you have it in your body, it's really hard to get rid of. Now, this may not apply to retinol, which has a shorter half-life. It is stored in liver and fat tissue. And as humans can go up to 3 months malnourished without running out of vitamin A storage. Now, the recommended daily dose or daily allowance is between 2,000 to 3,000 international units, and the level that you're required to cause toxicity range from 25,000 to 200,000 international units of vitamin A per day. So how does vitamin A causes high ICP? It's been different hypotheses. One is activation of retinoic acid receptors within the choroid plexus, leading to increased CSF production. Another is decreased CSF absorption by decreasing the permeability of the neurovascular endothelial cells through the induction of cadherin expression and the arachnoid granulation. And the risk seems to be higher if the patient is taking tetracycline, and this is another medication that you need to inquire upon when you're assessing the patient that is linked or associated with secondary pseudotumor cerebri syndrome. So with this patient, she's a pharmacist, so she's like almost borderline treating a borderline physician here. She refused LP and she wants to follow up after a period of discontinuation of the cream, and no acetazolamide was used. And I've seen her 6 weeks later. She was still experiencing occasional TVOs, transient visual obscuration in both eyes, especially when she's bending forward. Her visual acuity remains normal, so is her color vision and her pupillary, there's no RIPD. And this is her visual field. Now, you might notice that she may be developing kind of an early sort of nasal defect here in the right eye. And this is her fundus exam right now. So she still has, some significant papilledema in both eyes. And this is just the macula. I didn't show the macula at the beginning. I didn't have the photos, but her macula was normal. And this is her latest OCT. So compared to the one that she did 6 weeks ago, the neurofibrillary thickness has improved a bit, but she still has significant papilledema. So she was advised to do an LP. She refused, and she wants to use acetazolamide right now and to be followed in the clinic. And I haven't seen her again, but I just called her 2 days ago, and she said that she noticed improvement in her vision and lessening of the frequency of the TVOs, but I have yet to see her again in the clinic again. So in summary, topical retinoids are being very commonly used right now in the treatment of many skin conditions, and they are just purchased over the counter, and they are used widely now for cosmetic purposes. You can get systemic absorption of vitamin A even with topical application, and this can cause a secondary pseudotumor cerebri syndrome. So ophthalmologists, you need to be vigilant and aware and take a detailed medical history because of this association, because history is the most important thing here in sort of eliciting this diagnosis. And I'm sorry, this is my last slide. So I welcome any questions from the panel.
So that was an interesting case, and that just highlights that we really need to take a good history, and which may not be very forthcoming, as you said. And luckily, this patient didn't have a very advanced visual field loss to present with. And it's only that as you followed her up, she did present. So maybe it's something in evolution. And since she has already stopped the applicant cream, and she continues to have the papilledema, how long do you think would the papilledema take to get resolved? And at what point would you think of, now that the field effects have started coming, at what point do you think you would start the acetazolamide or to begin with? And would you think that doing an LP would be necessary? And what are the comments of the of Dr. Gordon on this?
Well, I mean, of course, you would want to get an LP because there are so many unknowns in this case. So you haven't yet satisfied the diagnostic criteria of IIH. Having said that, sometimes we don't do LP in typical IIH cases if there is no significant visual deficit. So maybe this is a point of discussion, whether you should really obtain an LP in every single IIH patient. And the other thing is about how long should I wait? I think most of the case reports, the papilledema result between 2 to 3 months. So I would probably follow this patient 2 to 3 months, and if her papilledema doesn't improve and the vision does not improve, then I would probably try to get an LP at that point, and maybe I'll even consider other diagnoses as well.
For instance, being on semaglutide, there are cases reported in which initial presentation was like a disc edema, and it later progressed to an NAION. So would not you like to keep that in mind and request her to stop her semaglutide as well?
Well, I mean, she's using it for diabetes, so it's not as easy. It's not like she's using it to lose weight. And the point about this being a sort of an evolving incipient subclinical NIN, that I think that's a possibility too. Most of the I think the NIN cases have been associated with the injectable form, but I haven't yet seen a report of an oral form of a GLP-1 agonist. But it's the same drug, so that remains a possibility. And this emphasizes the need to follow up this patient and see where she's at after a couple of weeks, maybe a month. So it'd be interesting to see the next visit, what's going to happen. And you would probably treat her as you treat a regular IIH patient. So you'd keep her on Diamox until her vision stabilizes, and then you sort of taper it off gradually.
You're still continuing the semaglutide and GLP-1 inhibitor? She's still continuing? Okay.
Yes, she's still continuing. Yes.
Yeah. We haven't done the LP, so we are kind of we're not nailing the cause, and I mean
it could land her.
Can't really be sure if we don't have the LP. You said that it could be incipient NAION bilateral.
Yes.
And there are case reports. There is a case report of bilateral NAION with semaglutide as well. Dr. Gordon, would you kindly give some comments?
Yes. Well, first of all, I want to congratulate you on an excellent presentation, and also for using the term pseudotumor cerebri syndrome, which I have been promoting for many years, because there's so many ways, so many pathological routes to ending up in this situation. And as soon as you start calling everything IIH, it becomes meaningless. So no, it's very important. The cases I saw who were in most trouble with this were the young leukemia treatments for leukemia in young patients, because no one was looking at their fundi until they were complaining of visual loss and being referred to ophthalmology. And one case that we wrote up, we actually put in a lumbar drain, which is the if you've got to treat raised pressure acutely without a shunt, then we recommend a lumbar drain, and that really did save her vision. And I'm also mystified by why these two different ways of treating acne both cause raised intracranial pressure, whether it's vitamin A or tetracycline. I haven't quite managed to figure out what the link is there. But there again, they're usually young people, and nobody's looking at their fundi despite they're on these treatments. But I've seen some with permanent visual loss, sadly, but the most severe were the patients being treated for leukemia.
And in fact, there were when I was reading, there were some reports in which they said that they thought that instead of doing anything else, they'll continue the drug and keep on doing repeated LPs so as to decrease the pressure on the optic nerve head.
Well,
Yes,
if there's no other way of treating the leukemia, then that's an approach where you don't have to do repeat LPs if you put in a drain.
I had one question to ask, which I find intriguing, because when the radiologist gives us this report and the neurologist, they seem to overemphasize on this empty cella and link it to IIH. So what are your thoughts on this empty cella?
I think that the term empty cella syndrome should be written out of our lexicon. It's meaningless. It's not empty. The cella has everything in it that it normally has. It has a pituitary gland and a pituitary stalk. The only difference is that the correct term is intracellular arachnoid herniation. That is the pathology. The dura has little defects in it here and there, and it has a defect here for the pituitary stalk and the vessels. So it's possible for the arachnoid to herniate through that defect into the sella turcica, and indeed then enlarge it. And that can be a perfectly normal phenomenon, benign phenomenon that we see. I was sent so many patients who'd had this diagnosis of empty cella syndrome, and goodness me, what was I supposed to do about it? It's only, but of course, if you have raised intracranial pressure, then this is going to happen more often because of the CSF pressure promoting this herniation. So the correct term is intracellular arachnoid herniation, and it can be an entirely benign phenomenon, but it is also one of the very useful signs of raised intracranial pressure in pseudotumor cerebri syndrome. I can still remember when one of the case definition of benign intracranial hypertension, as it was called, was that the imaging is normal. But now you can list. There's a list as long as your arm of all of the imaging findings in pseudotumor cerebri syndrome from any cause, whether it's drugs or overweight or whatever it is. We have compression of the venous sinuses. We have intracellular arachnoid herniation. We have dilatation of the optic nerve sheaths. There are more imaging signs than you can shake a stick at.
Thank you, Dr. Plant, and thanks, Dr. Reed, for sharing this interesting case. With that, we conclude the second session. I thank all the presenters and the panelists. Over to you, Dr. Mahesh.
So let me introduce Dr. Mahesh Kumar, who is the head of Department of Neuro-Ophthalmology at Arvind Eye Hospital, Madurai, India. He has edited a neuro-ophthalmology textbook for postgraduate students and is the co-author of an Atlas of Imaging in Neuro-Ophthalmology. He has several publications in national and international journals and is a reputed speaker in state, national, and international meetings. Over to you, Mahesh, for the last session.
Thank you, Satya. And thank you for taking me as a moderator for this last session. And it's a great privilege to be a moderator of this great event. So without wasting time, since Dr. Prem has to catch an international flight, I'll be calling out Dr. Prem Subramaniam first as a speaker. And before that, I will have a brief introduction about Dr. Prem. I'll just open my slides. Yeah. So Prem Subramaniam needs no introduction, and he's a well-known neuro-ophthalmologist, and he's a Clifford R. and Janice Merrill Endowed Chair in Ophthalmology, and is a professor of ophthalmology, neurology, and neurosurgery at the University of Colorado School of Medicine. And he's an active orbitocranial surgeon with a special interest in tumors of the skull base and small incisional approaches, with a special interest in progressive thyroid ophthalmopathy. He is also the chair of the board of directors of the North American Neuro-Ophthalmology Society and serves on the board of directors of the North American Society of Academic Orbital Surgeons. He has published over 260 research articles, book chapters, and web-based educational materials. So with that, we are happy to welcome Dr. Prem Subramaniam. Over to you, Prem.
All right, hello everyone, thank you. And it's a real pleasure to be with you today. And as we get the slides up, I'll be talking today about a case of an interesting patient who presented to me, and in fact, whom I just last saw in follow-up this week. So this was a 39-year-old woman who has had vision loss in her left eye since 3 days prior. And when she presented, she said she had gotten water in her eye. Maybe that was the reason she had vision loss. She was seen by a comprehensive ophthalmologist who really didn't find anything. And as occurs, I think, in many parts of the world, for that reason, she was sent to the retina specialist. And the retina, she had no past medical or surgical history that she reported at that time. She said that she was a never smoker and she had perhaps 5 alcoholic drinks a week, 1 a day or so. And the vision at that time was recorded as 6.6 in her right eye and 6.30, improving slightly with pinhole. It was noted that she said the letters were wide. Unfortunately, as happens in EMR sometimes, and we are not attentive, the examination itself was not recorded by the treating doctor, but he did at this point say that he thought there was a diagnosis of retrobulbar optic neuritis in the left eye and associated that with the subacute vision decline that the patient was reporting. And this was in November 2023, as you can see there. She had no other symptoms. He did a OCT that did not find anything abnormal at that time, so suggested that an MRI be done and the patient be sent to neuro-ophthalmology. Well, again, as happens in the world, there was confusion and the patient was sent to our institution but saw one of our retina specialists instead. And so 2 weeks later, and this is now probably 3 weeks after onset of vision loss, she says the vision loss started temporally, spread centrally. She had some flashes, but no floaters. She said that she was vaping something. It was unclear what, whether it was tobacco, marijuana, or something else. And at this time, it was recorded as having 1 or 2 alcoholic beverages a week. Her vision, as you can see here, has improved significantly in her left eye, almost to normal. The right eye is better than 6.6, and she had an unrevealing fundus examination at that time. So then finally, 5 weeks after vision loss, she came to see me. So this is December now, 2023, and she states that her vision loss may have started after receiving a tetanus booster. And at the nadir, she says she could only see shapes and light. And it started to improve about 2 weeks after onset. She had a bit of a delayed course of presentation. So in the interim, she had been seen by her primary care doctor, who had given her some oral prednisone because it was thought she had some swelling around her neck and face, and the patient didn't feel like this was of any benefit. She now reports a remote history of smoking, no recording of any vaping, said she stopped 14 years prior, and it's noted that she was having several drinks several times a week, which is what my fellow put down. So again, her vision at this time now continues to improve in her left eye. She now can pinhole to 6.6. She misses 1 color plate in the left eye, but really many patients do that. She had no RAPD, even with the use of a filter, and she had a normal fundus appearance. So as we know, that's not the full exam. So we got Humphrey visual field testing. Her right eye, she did do better than her left eye. I think you can appreciate that there are some scattered abnormalities here on the pattern deviation in the left eye that could be of significance in the setting of her visual symptoms. She had had a fluorescein angiogram that was done by my retina colleague, and I looked at this, and I think you can see this is obviously a mid to late phase image, but it does not show any abnormal leakage. It shows some RPE dropout in the far periphery, which we often see with these Optos fluorescein angiograms. She did get now an OCT of her macular ganglion cell complex on the left and her RNFL on the right. And her GCC, although the number, it may be hard for you to see, is symmetric between the 2 eyes, I think qualitatively you can appreciate that there is some dimming of the reflectance there, indicating a smaller population of ganglion cells in the left eye that had been affected by the vision loss. And the RNFL does not show anything, in fact, maybe a subtle thickening of the RNFL nasally. So at this point, certainly I agreed that there could be a working diagnosis of optic neuritis given this clinical picture, this clinical course, and she finally obtained her MRI of brain and orbits. And so you can appreciate, I think, and Mahesh, I don't know if you want to make any comments at this point, but I think that there is some T2 or STIR hyperintensity within the left optic nerve. There is perhaps even a little bit of thickening. I don't know that I would call this gadolinium enhancement, but there is some thickening of the optic nerve on the left side that certainly raised suspicion for optic neuritis. Okay, I'll continue. And of course, when we look at MRIs in patients with optic neuritis, we want to look not only at the optic nerves, but the brain. And the brain, you can see here, this is scrolling through axial T1 images, axial flare images, and you can see that there is no flare abnormality here. And if we look on the coronals as well, the coronal sequences here did not show any abnormalities. I'm not going to take the time to show you the entire MRI, but it was interpreted as being unremarkable aside from these subtle abnormalities in the left optic disc. So at this point, we're facing a patient who probably had typical optic neuritis, a short segment intraorbitally of abnormality within the left optic nerve, no other neurological symptoms, normal MRI. And so, while there are other things like dry eye or even subtle macular edema, although there was no evidence for that on the previous scans, we really felt like this represented optic neuritis. She was counseled that because her MRI was normal, her risk of going on to develop some other problem was unlikely. Because she had good visual recovery at this point, we did not do any additional serologic testing for MOG or NMO, and she was released from my care, actually, at this point. So if that was the end of the story, I'd have nothing to say. But of course, that's not it. 9 months later, September of last year, she felt like she had been doing well up until about 1 month prior, August, when she'd had an upper respiratory infection. She recovered fully, but then felt that she had progressive vision loss in both eyes now. It was painless. It was symmetric. She felt it was somewhat variable, and she told me, sometimes I feel like I'm blind. And she did get some blue blocking glasses that she would wear, especially when using the computer, and she felt like these were of some benefit. So now her exam is very different than what it was when I last saw her in December 2023. Her vision is reduced in both eyes, more so in the left eye than the right. There was a trace RAPD in the left eye, and both pupils were a little poorly reactive to light. Now she sees none of the Hardy-Rand-Wittler color plates, and in fact, in the left eye, can't even identify any of the control plates. She has normal anterior segments, and now when I looked at her fundus, remember she's had vision loss now that she has noticed for about 1 month. I felt that she had some subtle temporal pallor in the right eye and moderate temporal pallor in the left eye. And there's a running joke amongst my fellows and former fellows that I never believe that patients have temporal pallor. I think it's overcalled all the time, and I think that's true. And so for me to think that someone has temporal pallor, I think is a sign that it was probably there. And although I am of a vintage to remember days before OCT, and I don't need OCT to tell me that there is temporal thinning of the RNFL when patients have temporal pallor, you can see here on this RNFL OCT that although it doesn't dip into the yellow or red, you can see the temporal RNFL, even in the right eye, is dipping down toward the red and significantly thinner than the RNFL anywhere else. And in the left eye, the more affected eye, it clearly, the temporal RNFL has dropped down into the red zone, but with relative preservation of the rest of the RNFL in this case. And so, not surprisingly, on visual field testing, this patient had a subtle central or secocentral scotoma in the right eye, seen really only on the pattern deviation. The left eye is more obvious on the grayscale, as well as on the pattern deviation, that there is a secocentral scotoma that is consistent with the vision loss that she is experiencing in that eye. We have an OCT of the RNFL, of the ganglion cell complex now at this point. So this is on a return visit to me. She had not had any further workup yet, but she is found to have marked thinning here in the GCL, in addition to, and the left eye just didn't calculate. So some additional details now. She underwent bariatric surgery in March of 2024. Remember, I had last seen her in December 2023. She had lost weight as desired, and she was on vitamin supplementation. And in fact, as part of routine screening for her post-bariatric surgery status, she had had some serologic testing of various vitamin levels in September, and she'd had you can see here, normal CBC as well as most vitamin levels except a low normal zinc. She, at this point, it was unclear what her alcohol intake was. She was a little vague on that in discussing it with us. So, she would say, oh yeah, I'm drinking less, but wouldn't really quantify. And she had, she reported no family history of vision loss. So at this point, we have a patient now with cecocentral scotoma, right eye less than the left eye, a subacute painless symmetric vision loss, clear temporal pallor on fundus exam, temporal thinning of the RNFL, and a clinical picture that clearly is different than what she presented with when I'd seen her 10 months prior. So we retested everything. And at this point, we did get NMO, MOG. She got a repeat MRI, as I'll show you. And she was tested for infectious potential causes like treponemal antibodies. Because, of course, of the cecocentral nature of the scotoma, the temporal pallor, the bilaterality, we ordered mitochondrial sequencing, homocysteine, heavy metal screen, methylmalonic acid, as you can see here. And by retested everything, I mean all of her nutritional labs were tested again, in addition to CBC and a comprehensive metabolic panel. None of that was revealing. The mitochondrial sequencing was negative, and all the other tests showed that her laboratory values were in normal range, or as happens often with people taking supplements, her B12 and her thiamine were actually quite elevated. So she came in for 6-week follow-up. Now, she had not yet obtained the MRI, and she notes that her vision was fluctuating still. She wasn't sure if it was stable or worsening, but her peripheral vision was quite preserved. She was very clear on that. Now you can see her vision in her left eye has somewhat slightly worsened. Her right eye is stable, and she now sees no color plates in either eye, and her fundus exam is unchanged. So at this point, I don't know if there are any questions from the panel or any discussion, Mahesh, that you would like to do, or if we should go ahead and show the OCT and MRI and see where we go from there.
We can proceed to the OCT findings, Prem.
Okay, wonderful. So we got a repeat OCT. Remember, the MRI has not been done yet. And she now has, you can see very similar findings. It hasn't changed much, I don't think, in the 6 weeks, although the RNFL in the right eye, I think, is thinning a little bit more temporally. But again, the periphery, the rest of the RNFL seems to be relatively preserved. And now you can see that there is just a generalized loss of the ganglion cell complex in both eyes, maybe a little worse in the left eye than in the right, but not in any particular pattern, I think, that is going to guide us to a particular cause. Although there was a subtle suggestion here that there was a vertical meridian that was being obeyed here, and this raised concern like, oh my gosh, could this patient have a chiasmal lesion that is causing compression that is going to be found on the MRI? Well, I hate to disappoint you, but there's no chiasmal lesion. You can see on the left there that that's perfectly normal. In the center, I'm scrolling through her coronal T1 MRI, and you can see that there is absolutely no lesion there. Maybe a little thickening at the chiasm, in fact. And on these T2 images, there's a little bit of more of a fluid signal around the left optic nerve, which I think represents a little bit of that atrophy in the left relative to the right optic nerve. But overall, nothing really revealing on this MRI. So this MRI of the orbits did not help us very much other than excluding a compressive process. And if we see now an MRI brain that we have, again, not much. There is, as scrolling through here, maybe some subtle flare abnormalities, but really nothing dramatic leaping out at us at this point in time. And if we look at an additional MR sequence here, we do not find anything enhancing or otherwise showing us abnormalities within the brain parenchyma that would suggest a cause. So this patient comes back to see me now. She says, I have numbness and tingling. So she was referred to neurology. It was attributed to a higher excess vitamin B6 intake. She had an abnormal EMG with possible small fiber neuropathy. And so now she has urinary retention, generalized fatigue, and so she gets a lumbar puncture very appropriately. And you can see here now that on her lumbar puncture, she has an increased IgG index, and she has 5 oligoclonal bands. And in addition now to having 5 oligoclonal bands, she gets a repeat MRI scan. And this is now May of 2025, May of this year. And now I think you can appreciate, and I'll pause this here briefly if I can. It's not pausing for me, but nonetheless, we can see that there are now definite white matter abnormalities on the MRI. I will play that again and just point them out for you. And so as we scroll through here, if we stop right here, we can see that there are some white matter abnormalities observed. And definitely right here, we have U fiber abnormalities within the cortex. So very now, this MRI has gone from having essentially nothing to very characteristic pericallosal and subcortical white matter lesions. Her visual fields at her last follow-up with me showed these patterns, again, secocentral in both eyes. Nothing has really spread to the periphery. And her OCT now shows temporal thinning in both eyes, well out of proportion to thinning anywhere else. Her visual acuity remains poor, and she has no color vision in both eyes. She has persistent temporal pallor, and her ganglion cell complex is quite thinned. So before we go to the questions, I just want to run through a couple of thoughts that we had in this patient. She clearly meets the diagnosis for multiple sclerosis. She has been started on disease-modifying therapy, and she has had no new neurological events. But if we look at vision loss patterns in patients that with bilateral optic neuritis that have been previously published, we see here that patients either had disc edema or not, and they often had pain, as you might expect. There could be an REPD. But if we look at the visual field mean deviation, by and large, these patients pretty much had generalized depression of their visual field, not a focal secocentral scotoma like we see in this patient. And at recovery, like many patients with optic neuritis, the recovery showed a marked improvement in the visual field mean deviation. In an analysis of over 3,600 visual fields that were collected in the ONTT, 45 patients had secocentral scotoma, 45 fields. That's just over 1.5%. And only 4 out of nearly 2,000 fellow eye visual fields in the fellow eye had secocentral scotoma. So a very uncommon finding with typical demyelinating optic neuritis. But again, remember, ONTT was unilateral optic neuritis only, not bilateral. So what would I like to summarize for this? This patient likely had typical optic neuritis in the left eye in late 2023. She had good recovery and no other radiographic findings. When she presented with this new bilateral subacute vision loss in 2024, she had an unremarkable MRI. She had these various risk factors, having had bariatric surgery, putting her at risk for nutritional problems. She had possibly alcohol abuse. None of those things panned out, and eventually she really developed classic MS by 8 months later. Does this represent what has been referred to as Harding disease, the overlap of LHON and MS? In this patient, again, the mitochondrial testing was negative. She has been sent for whole exome sequencing. We will see if that shows any recessive or dominant autosomal contributors to mitochondrial health that might lead to further understanding of this patient's clinical picture. And so I thank you for your attention and look forward to the discussion.
Thank you, Prem. It's a great case, and a lot of questions for this case which are popping up. So was the first episode a true optic neuritis or not? We didn't have an RAPD, and we hardly had a color vision defect, or could it be something else? And whether these two events could be related these are the things which we think of. What do you think?
I think in retrospect, Mahesh, it was a mild case of typical demyelinating optic neuritis. I really do. Because of the MRI abnormality in the optic nerve, I think by the time she came, because of the recovery that she was already having, that's why an RAPD was not detected. Unfortunately, I think in some of my colleagues' practices, the RAPD is only checked by technician and not necessarily by the doctor. So I don't put too much weight on that. And so I think it was a true mild optic neuritis, as can happen with typical demyelinating disease.
Any other investigation, like for example, electrophysiology, would it have helped in this case?
Absolutely. So we don't get VEPs very frequently. VEP certainly may have shown delayed latency, which would go along with demyelinating disease, which I think could help to confirm that contribution. But I really think the idea that I'm coming away with here is that this could very well be an overlap syndrome. We know that exists. And so I would expect the VEP to be delayed now in this patient with known demyelinating disease, but I'm not sure it helps us to know if there's anything else in addition to the optic neuritis as the cause of her vision loss.
So any other questions from any other panelists?
Yeah, and I saw Dr. Shika put a comment that the chiasm looked thickened even in the first MRI, and it may have. I mean, again, that could be, again, a precursor to LHON, absolutely.
So will additional tests would have helped in this case? Like you have done the NMO MOG as well as any other tests might have helped, right? Yes.
Right, and so we look for other inflammatory markers, absolutely, and none of them were positive.
Okay. So that's a great case, Prem, and if there are no other questions, we'll go to the next case. And thank you, Prem, for that interesting discussion. And thank
you all.
Thank you all. Thank you. So I would like to introduce the other panelists for this session. First, we have Dr. Digvijay Singh. He's a director of the Noble Eye Care, Gurugram, Delhi. And he's also the HOD of ophthalmology at Narayana Super Speciality Hospital as well as Rainbow Children Hospital at New Delhi. So he has got a special interest in neuro-ophthalmology, pediatric ophthalmology, strabismus, and glaucoma. And he holds to his credit plenty of awards, publications, and book chapters. And he's also a research guide and a co-guide to a dozen students of different universities across the country. And he's a treasurer of Indian Neuro-Ophthalmology Society, secretary of Gurugram Ophthalmology Society, and past president of Young Ophthalmology Society of India. The next panelist will be Dr. Jyoti Matalia. She's the head of pediatric ophthalmology, strabismology, and neuro-ophthalmology at Narayana Nethralaya, Bangalore, India. And she has presented over 350 lectures and conferences in India and abroad, and 70 publications and 15 book chapters and 16 awards to her credit. She is also in charge of the postgraduate training at her center and runs a fellowship program in her specialty, having trained 40 fellows till date. Her areas of interest include pediatric cataract, neuro-ophthalmology, myopia management, and teaching is her passion. Next, we have Dr. Neena, who is a senior consultant and head of the Department of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology at Giridhar Eye Institute, Kochi. And she has over 21 years of teaching and clinical experience with a special interest in neuro-ophthalmology, pediatric cortical visual impairment, myopia control, complex strabismus. She is a reviewer of many indexed journals, including Ophthalmology, Strabismus, American Journal of Ophthalmology, and Indian Journal of Ophthalmology, Kerala Journal of Ophthalmology, and an associate editor of the Kerala Journal of Ophthalmology, and a scientific committee chairperson of Cochin Ophthalmic Club. Then we have Dr. Durga Priyadarshini, who is the Deputy Director of the Department of Neuro-Ophthalmology at Shankar Nethralaya, Chennai. And she had pursued her post-graduation in Diploma in Ophthalmology at Shankar Nethralaya, Chennai. And she's a recipient of the gold medal during her residency and has cleared the exams conducted by the International Council of Ophthalmology. And she has been a consultant at the Shankar Nethralaya for the last 10 years and presented numerous scientific papers, posters, and conducted instruction courses. She is an active member of the organizing team of the Neuro-Ophthalmology and Cataract Services conducted by her parent institution, and she constantly pursues to widen her knowledge in her subspecialty. She loves art and is an avid amateur artist. So with that, I introduce the first speaker of this session, and I welcome Dr. Shika Basi, who is a director of Neuro-Ophthalmology Department at Shankara Nethralaya, Chennai. She is also on the editorial board of the Indian Journal of Neuro-Ophthalmology. Her topics of interest are optical coherence tomography, neuro-ophthalmology, optic neuritis, and idiopathic intraretinal hypertension. Dr. Shika.
Thank you, Dr. Mahesh, for the kind introduction, and Dr. Satya for the opportunity. Yeah, so my screen is visible?
Yes, yes, it is.
Yeah, it's full screen, right?
Yes.
Dr. Mahesh?
Yes, yes, yes.
Yes, visible.
Yeah. So I'll be presenting a case of MOG optic neuritis and latent syphilis, where we can probably discuss whether these are related or passing acquaintances. So we saw a 25-year-old male medical graduate who presented to us for a second neuro-ophthalmology opinion at our institute. He gave a history of gradual onset, painful bilateral vision loss that had developed approximately 1.5 months prior to coming to us. The vision loss was accompanied by significant headache, pain with eye movement, and subtle color desaturation bilaterally. He was a medical graduate, so he could give a very relevant history. He also gave a history of seeing persistent bilateral floaters, 10 to 20 in each eye, which appeared more prominent in dim lighting conditions. There was no history of photopsias or seeing flashes of light. He also complained of worsening of vision with exercise, what we call Uthoff's phenomenon. And he also complained of 1 or 2 possible episodes of oscillopsia, transient visual obscurations. He was a little anxious. So he had taken treatment locally before coming to us. And he was, the papers showed, his old reports showed that he was diagnosed to have bilateral optic disc edema, showing central scotomas on visual field testing, and NMO and MOG antibodies. He was diagnosed to have optic neuritis, bilateral optic neuritis. NMO and MOG antibodies as tested by fixed CBA were negative. And the CSF also had been done, which was positive for oligoclonal bands. So he was treated with intravenous methylprednisolone, 1 gram daily for 5 days, which was followed by oral prednisolone, 40 milligrams per day for 10 days. And then he was tapered to 30 milligrams. And as he reached 30 milligrams first day, he relapsed again. He complained of pain, more pain on the left side, and the vision deteriorated to 636 in both the eyes. And the treatment was re-escalated. And he was treated again for 3 days with intravenous methylprednisolone, followed by oral prednisolone 40 milligrams for 3 days. And while he was on 30, he withstood 30 milligrams this time. He came to us. So when we examined him at our institute, his best corrected visual acuity was good, 6.9 and 6 in both the eyes. He was a high myope, you can see, minus 8.25 and minus 9.5 in right and left eye, the refractive error. And his extraocular motility was full, free, and painless in both the eyes. Pupils were briskly reacting to light. His color vision was good, 21 by 21 in both the eyes. His anterior chamber was, on slit lamp examination, anterior chamber was quiet. It was within normal limits. So this is the on fundus examination. You can see it's a tessellated fundus with mild blurring of the nasal margin. And I have noted vitritis in my fundus drawing. It's not seen very clearly here. And I felt, since he was also complaining of floaters, I felt that there was vitritis in both the eyes. This is what I've documented. He was a high myope also. And this is the visual field. The visual field showed it's more of a generalized reduction of sensitivity with central depression on the right side. And I felt there was a component of uveitis. I sent for a uveitis specialist opinion. And looking at the old reports, he was also found to be positive for RA factor, and ANA antibody was, anti-nuclear antibody was also positive. Other than that, there was no significant history suggestive of past uveitis. So the uveitis specialist ordered for the FFA and also for the ultrasound. And these are the findings. The right eye, it showed the early phase, it showed a few window defects. And in the late phase, in the periphery, you can see there was, my cursor is not seen moving, no? You can't see the cursor moving here. So you can see, other than the window defects, there was some staining of the vessels in the periphery. The same thing in the left eye. There were a lot of window defects, and then the peripheral vessels you can see in the superior images showed staining. On the OCT, the RNFL thickness was increased in the all 4 quadrants in the right eye, in the left eye in 2 quadrants. And at the this is the OCT through the macula. What is standing out is, if you can see here, in the right eye, there are some hyperreflective dots seen in the vitreous. And on the ultrasound also, a few moderate reflective echoes were noted, suggestive of vitritis. Other than that, ultrasound was normal. I am sorry, I don't have the MRI images, but it was reported to be normal. There was mild widening of the perioptic spaces. Other than that, MRI brain was normal. Spine screening was also normal. So the blood investigations were ordered. Patient at our institute, and patient was already on steroids. The WBC, the RBC was a little on the lower side, and there was a neutrophilic response, probably because of the steroids. ESR was 20, and Mantu was negative. So at this time, the working diagnosis is probably atypical optic neuritis with uveitis. Hence, atypical optic neuritis workup has been ordered. The previous reports are of complete hemogram, and this is the Mantu. And VDRL, test for syphilis, is part of atypical optic neuritis, and also for uveitis, and it was found to be the RPR was reactive, and so was TPHA. So a reactive RPR at 1:16 dilution suggests significant antibody presence, and a positive TPHA confirms syphilis. So he was also advised to, we repeated the CSF analysis to rule out CNS involvement, and he was found to have, the CSF showed elevated protein, elevated chloride. The gram stain was negative for any bacteria. KOH was negative for fungus. RPR turned out to be negative, and TPHA was also negative in CSF, and MTB was also negative. So at our institute, we ordered for MOG and NMO again, but it's a fixed cell-based assay. At the same time, sample was also sent for live cell-based assay. So the fixed turned out to be negative again, but the live cell-based assay turned out to be a clear positive for MOG optic neuritis. the phenotype of optic neuritis was also such that it was a very steroid dependent optic neuritis. So in serology, there is a clear positive syphilis serology. MOG antibodies are clear positive by live cell-based assay. Along with that, he was also RA factor positive and positive anti-nuclear antibodies. So other infections like HIV were ruled out. X-ray test was also clear. Patient was referred to infectious disease specialist who elicited the history of palm and sole skin lesions 1 year prior to presentation to us, which was initially misdiagnosed and treated as scabies. And he was diagnosed to have late latent syphilis with CNS involvement. And he was treated with CNS involvement. Actually is the CSF was negative. He was treated with injectable penicillin G injections, 2.4 million units, 1.2 million unit in each gluteal region, once a week for 3 weeks. This was the treatment prescribed by the infectious disease specialist. Now coming to the treatment of optic neuritis, it became a little complicated. We know that the patient has a steroid-dependent optic neuritis, which is MOG optic neuritis, requires, if it was not a case of syphilis, ideally patients should be treated with some form of immunosuppression like mycophenolate, mofetil with injection rituximab, 2 injections. This would have been the protocol given if the patient was did not have this associated infection. So he was advised to take the infectious disease specialist clearance to start immunosuppression. And he was also initially noted to have oligoclonal band positivity in CSF. So he was advised to repeat that 3 months later to look for the response. And he was advised to take locally the injection rituximab after completing the course of penicillin as advised by the infectious disease specialist. He was advised to taper steroids 10 days, 30, 20, and 10. And he has done well. He's done well with this treatment. So the question here is that this is probably the 6th case reported of MOG optic neuritis with positive syphilis serology. So in all the reported cases, the authors have questioned whether these are 2 different things, or maybe syphilis, latent syphilis, has a role in the pathophysiology of MOG optic neuritis. So these are the previously reported cases of MOG optic neuritis with syphilis infection. Around 5 cases have been reported, and out of which 3 cases are of latent syphilis with MOG optic neuritis, and only 1 case is of MOG optic neuritis with latent syphilis has been reported before this. So with that, I conclude.
So I think it was a fantastic case, Dr. Shikha. And
to stop the sharing.
Yeah. I think it is gone now. Yeah, so that was a fantastic case. And as you said, I was also looking at the literature. There are cases that have been reported, but I think mostly it seems to be 2 in bit, which is why maybe one may be getting more active than the other. But ultimately, it does come down to the dilemma of, you're treating the infection part of it, or you're doing the immunosuppression, or how much to do what. So did you find that was a challenge that was looked at during the treatment?
Yeah, that was the main, because this was the first time that had seen a case of MOG optic neuritis with an active infection. And so that bit was challenging, how to start the immunosuppression. So we took infectious disease specialist opinion, and it's like, learning on the go, kind of that, keep the patient on steroids until we get the clearance for immunosuppression after the treatment of syphilis. I mean, like we just did it this way, that treat the infection with penicillin and then start the immunosuppression, that is injection rituximab and mycophenolate. So this, I don't know if Dr. Plant is there. This was very similar to, this was like, because the MRI was normal and the swelling of the disc was there. So this was also papillitis. He had presented a very similar case where OCB was positive and there was only papillitis, nothing on the MRI. I think he's left.
He is left, I think. But papillitis and vitritis, which is probably significant as well at that some stage.
Yes.
So I think that's also very, very important. This case also highlights the need to, look at, to be able to identify the atypical optic neuritis and then, further look into the investigations there, because otherwise it was just gone into steroid. As it came back, once the steroids were tapered, the same would have happened if somebody else, gave it even at a higher dose of a longer period. So till you actually take care of the cause, it wouldn't have settled.
I didn't get your question.
No. Yeah. Am I audible now?
Yeah, you're
Yes.
audible,
Yeah.
but
So
you're talking too fast. I could not.
Okay. My throat's also a bit jammed up today, so that's why I'm in a jacket with a viral. But so
Yeah,
I was saying the ability to be able to catch an atypical optic neuritis and identify that is also very important, because if you're going to blindly treat with steroids, then you're going to get you're going to have recurrences rather, or breakthroughs as soon as the steroid is tapered. And if there's an infection, then you're only making things worse as it goes.
Yeah, MOG optic neuritis is also a type of atypical optic neuritis, which tends to, every time you taper steroids, it tends to recur. So, but the thing is that when we see MOG optic neuritis, I don't know how many of us order the complete atypical workup. So before these NMO and MOG antibodies came in the clinics, we used to do for, if it is not MS optic neuritis, we used to do the entire atypical workup, which included infections like tuberculosis, syphilis, etc. We used to do that. Since MOG and NMO have come, I don't know how many of us are still doing, once you get optic neuritis, you order NMO, MOG, but the other infections also need to be ruled out. So that bit is important. It's
yeah, that's
very
very
rare
right.
association. We don't see it often. Here we had, as you mentioned, vitritis also. So it was atypical. I was thinking in terms of MS optic neuritis with uveitis. So my initial, since OCB oligoclonal bands were positive, so the initial working diagnosis was that. But syphilis was a total, surprise.
I think fantastic. Any other panelists want to add anything?
So there's this concern of false MOG positivity, but I think you have cleared it, Dr. Shika. You have done the live.
Yes, it was. So we got the live cell-based assay, which is, it was a clear positive.
Positive. Okay. Yeah.
But I still don't have the answer to the ANA positive and RA factor positivity.
Yeah.
There is some cross reactivity occurring there.
There's definitely a lot of cross reactions. Yeah.
Yeah, two very prominent immune system things happening there. So,
So thank you, Dr. Shika, and thank you, Digvijay, for the excellent discussion, and thank you, Shika, for the great case. So with that, I invite the next speaker and just share the presentation. Dr. Zina Almer, who is a Director of Neuro-Ophthalmology Service at Shamir Medical Center, Zarif in Israel. And her previous work experiences include being a pediatric ophthalmologist and neuro-ophthalmologist at Shamir Medical Center, Israel, and faculty of ophthalmology department at Tel Aviv University, as well as in in the Israeli Defense Forces. She has got a lot of professional organizational memberships in the Israeli Ophthalmological Society, NANOS, as well as American Association of Pediatric Ophthalmology and Strabismus. Welcome, Dr. Zina, for your presentation.
Hello, thank you very much. And thank you, Dr. Sakai, for this invitation. I really am honored to be here. Let me share my slide. Okay. For some reason, my presentation isn't. I don't know why I can't open my presentation.
Maybe you can
share and then share again.
Stop sharing and then share again. That will be better. Can stop sharing first.
I'm trying. It's just nothing works. Okay.
Yes.
Doctor, can you do me a favor? Can you just start the presentation and then share? I will just stop here as of now. Or can you just try opening?
Okay
Yeah,
now.
it is there.
Can you see it now?
Yes, all good.
Yes.
Okay,
Yes.
so thank you very much again. And my case is somewhat similar with Dr. Chan's case in the first session. So I first like to mention this case was initially managed in our medical center and later transferred to the Sourasky Medical Center in Tel Aviv under the care of Dr. Einat Klein, who kindly agreed to share the patient's follow-up for this presentation. And I call this case a timing matter. And this is a 19-year-old healthy man who presented in April this year with 10 days left eye progressive vision loss and periorbital pain. His review of systems and exposures history were non-contributory. He presented with 20/20 vision in the right eye and 21/50 in the left. He had reduced color vision in the left eye and the left RAPD. His extraocular movements and neurological examination were normal. These are his fundus photos and his OCT, and you can see the right eye is completely normal, and there is some left optic disc swelling. The visual field was normal in the right eye, and he had a left inferior altitudinal visual field defect. His MRI showed the left optic nerve was swollen and enhancing, especially posteriorly up to the prechiasmatic part, and you can see here the images. The brain MRI was otherwise completely normal. At this point, with a presumed diagnosis of optic neuritis, he was treated with intravenous steroids. Visual acuity and color vision improved, but there was no change in his visual field. He was discharged after 5 days with steroid taper while waiting for the anti-MOG and anti-aquaporin 4 results. But 2 days later, he returned to emergency room with worsening vision, now down to 2200, and periorbital pain. He was admitted to neurology and underwent extensive serologic, autoimmune, infectious, and paraneoplastic workup, all normal and unrevealing. He had a spinal cord MRI that was normal, a lumbar puncture normal as well with negative oligoclonal bands, and a PET CT that only revealed the left optic nerve thickening with pathologic hypermetabolic uptake, but was otherwise normal. He was treated with 5 courses of plasmapheresis and repeat intravenous prednisolone, but continued to worsen. And the anti-MOG and anti-aquaporin 4 results came back negative. So here you can see his progression over 2 weeks, starting at the initial presentation. At first, there was some vision improvement under steroids, but then rapid visual functions deterioration, while the optic nerve head swelling was progressively worsening. Here you can see some images comparing his MRI presentation on the left to a follow-up MRI 2 weeks later on the right. And these are some axial T1s, coronal T1s, and axial T2s, and you can clearly see the lesion progression. So now we're worried this may be a neoplastic process, specifically a glioma. And I want to emphasize this patient had no NF1 features. Other possible diagnoses remained in the differential, but they were less reasonable. So here you were, 28 days after his symptoms started. His vision in the left eye was 2200. He had a diffuse visual field defect with sparing of the upper nasal quadrant and the prominent left RAPD. The optic disc was markedly swollen, but the GCL remained normal. And at this point, we really felt tissue diagnosis was needed. But we are hesitant to biopsy since this was still a seeing eye with a normal GCL. That said, biopsy was discussed with the patient and his family, though I'm not sure we were very persuasive. But upon hearing this, they opted to transfer to the Sourasky Medical Center in Tel Aviv, which is a bigger tertiary referral center in Israel. And at Sourasky, after multidisciplinary consult, they felt no additional workup or treatment could be offered besides biopsy, which both the team and the patient were reluctant to go ahead with. So he was discharged on steroid taper, only to return 3 weeks later with clinical and radiologic worsening. As his vision was now hand movements, optic nerve biopsy was endoscopically done by ENT. And Dr. Abergil, who performed the surgery, kindly agreed to join us in this conference while he's in Vienna at another meeting to give a brief explanation on his technique at the end of the presentation. This is an OLIC2 stain from the specimen, and this is a marker for gliomas. And the pathology report read low-grade pilocytic astrocytoma, BRAF V600E positive with low cellularity and no mitotic activity. So the WHO classifies gliomas into low and high grade. In 2021, molecular features as detected at biopsy were added to gliomas classification. As opposed to children, low-grade optic pathway gliomas in adults are rare, sporadic, and usually isolated to the optic nerve. Adult presentation can be at any age, but mostly in the first decade of life. Unlike NF1-related gliomas, in adult sporadic gliomas, biopsy is important for specific treatment choice and prognosis. Although 5-year survival rate is high, in adults there is a 30% chance of malignant transformation. So close surveillance is needed and repeat biopsy may be required. The treatment goal in optic pathway glioma is vision preservation. The main treatment indication is progressive clinically significant vision loss, and of course, contralateral eye involvement hazard. The mainstream of treatment in optic pathway glioma is chemotherapy. Radiation is best avoided in young children and is contraindicated in neurofibromatosis. Surgical treatment is rare and reserved to severe disfiguring cases. BRAF and MEK inhibitors were lately approved by FDA for gliomas harboring BRAF mutations, and I'll elaborate on this. The mitogen-activated protein kinase signaling pathway influences cell growth, differentiation, and apoptosis. Its activation, as occurs with BRAF gene mutation, results in increased cell division and survival. MAPK pathway inhibitors are used in cancer treatment. The V600E mutation is the most common BRAF mutation and was described in up to 20% of low-grade gliomas. The V600 mutation is associated with poorer response to chemotherapy and shorter progression-free survival. So in March 2023, the FDA approved a selective BRAF V600 inhibitor and a MEK inhibitor combination, namely dabrafenib and trametinib, as first-line treatment for children with low-grade glioma BRAF V600E positive, as this treatment was shown to result in significantly better responses, longer progression-free survival, and had better safety profile than standard chemotherapy. So back to our patient, I remind you that pathology showed low-grade glioma BRAF V600E positive. He was started on dabrafenib and trametinib on June 20, 2 months after his initial presentation. And here you can see his visual acuity and visual field improvement under this treatment. This is his OCT showing the reduction in optic disc swelling, while the GCL has finally declined as expected. And as for his MRI, I'm sorry I didn't have the exact same imaging sequences to compare, as these were done at two different institutions. But still, you can see on your left the tumor before, and on your right the tumor after treatment. You can see the tumor regression. So to conclude, the most difficult decision for us in this case was when to go ahead with biopsy. Or is it at all acceptable to biopsy a seeing optic nerve? And actually, just recently, but after our case concluded, this beautiful paper came out of the Mayo Clinic, where they looked at indications and outcomes of optic nerve and optic nerve sheath biopsy over 24 years. And in this paper, they had 32 optic nerve biopsies with an 81% diagnostic yield, leading to an overall change in clinical management in 89% of patients. And what was most interesting for me is that while the preoperative median visual acuity was no light perception, the range was 20/20 to NLP. So they concluded that overall biopsy is a high-yield diagnostic step with a low complication rate, even when vision is relatively preserved preoperatively. So I would be very interested to know your opinion regarding biopsy timing and maybe your experience with the BRAF/MEK inhibitor combination treatment. Thank you very much for your attention. And maybe Dr. Abergil can first explain a few words on the biopsy procedure that was done, if he's connected.
Hi,
Yes.
thank you. Can you hear me?
We can hear you.
Okay.
Yes.
So thank you for inviting me to explain my way of thinking and my approach. So actually, after we done a multidisciplinary meeting on this case, we decided that that's the time to go for a biopsy. The main problem when you do a biopsy in this setting is that you enter with a patient that sees, and then you don't know if your biopsy is going to really affect the optic nerve, because you never know where is the tumor or where is the viable fiber, I'll call that way. So after consenting this case with the family, we decided to approach it as we do optic decompression approach endonasally. So it is actually an endonasal procedure when you do a complete, what we call an ethmoidectomy. You expose all the lamina up to the optic nerve in the sphenoid tunnel. And then I decided to go from the orbital apex, where I saw the nerve was a bit widened, and go take it back to the sphenoid, where it's going towards the chiasm. And after exposing the dura, we took a few biopsies from the nerve, and luckily we didn't really distract the nerve. That's the way we do it. Thank you.
So actually, we thought at some point that maybe at least part of the vision improvement was due to the decompression, and not only because of the treatment itself. Can anyone comment on this?
Jyoti?
Yeah, I think very interesting case actually, where you got a remarkable improvement in vision after treatment. But what I had a feeling is that initially when we saw the MRI itself, there was this fusiform dilatation, enlargement of the optic nerve, not a classical. So if you would have detected this in the initial thing, then would we have avoided a biopsy? So this is also my opinion with all. Would we directly go? Luckily, in your case, the vision had come to a level where we needed some answers, and therefore going in for a biopsy was actually needed, and it really did well. But sometimes suspecting this in the first go because of the fusiform enlargement, it looked different than what you would expect in a patient who has a classical optic neuritis. So probably look at it and go into finer ways of picking out in this young patient about what possibly will be the optic nerve issues that could have helped us, look into a direction rather than treating this like an optic neuritis.
Yes, you're right. This was in the back of our mind, but it was difficult anyway to go, to biopsy a seeing optic nerve. It was really a very difficult decision. And also, I wanted to ask on the ganglion cell layer that kept, it didn't change for a month. It was 28 days into his symptoms, and it was completely normal. And this also, I don't know.
Yeah, so that's actually unusual. Usually, even before if defects start showing on the visual field, we sometimes pick up a lot of effects on the macular ganglion cell layers. Unless this happens so rapid that we could pick, and the treatment happened in time, that before this really causes, structural damage, you were able to get the effect already put in. That's why we could have the ganglion cell layer intact. And though the visual field showed changes, we could reverse those changes. Because the ganglion cell never showed any major defects, the visual field also tend to recover back to normal. So probably things happened in a very short time, and the treatment was given in a good course of time, during which the damage actually was prevented.
Yeah, we thought there's something to do with the compressive effect also. It happened fast. It was also a compression issue, a fast compression issue, and then the biopsy, the decompression also contributed to the vision improvement. This is how I explained it to myself, but I don't know if it's.
Yeah, I think there could be some compression issue, but before it could have, with the treatment, you could relieve the compression fast enough to cause the actual damage coming in structurally onto the ganglion cell. So any other opinion regarding doing biopsy in these cases?
Yeah.
Hi, Dr. Jyoti, I'm here. Vivek here.
Yes, Vivek.
Yeah, so I think most of the time, very similar lesions, although this is like very fusiform if you see the appearance. Otherwise, you would see even more flat and, like a long length of the involvement, which might get sometime very much confused with, the MOG perineuritis or, the MOG optic neuritis. So I think even if it is there underlying gliomas, there is no harm in the first go to treat it like, the optic neuritis being in a confusion. So what happens, these tumors, they respond to the initial doses and then again they come back with. So what happens in the initial phase when we give the steroids, some sort of inflammation or some volumetric loss that happens with the steroid, and then again because being a tumor, we are not treating the pathology itself, so they come back with a vision loss. But I think like doing biopsy in this particular case, there was a yield, and then we were like pretty blank on this is the reason. Otherwise, even if they are like a silent low grade or a moderate grade gliomas, the treatment is completely different, and I have never seen patients improving so dramatically. And then again, this is something like new knowledge that we are getting out of this case, that this combination of drug that really helps to reduce the tumor.
Yeah.
So it's an excellent case, and congratulations, Dr. Zina, for recovering the vision of the patient, and thanks, Jyoti, for that discussion. So with that,
Thank you very much, and thank you, Dr. Abergil.
thank you, Dr. Abraham. Thank you, Dr. Abraham. Yeah. So with that, I invite our next speaker, Dr. Amanda Henderson. Dr. Henderson is a Frank B. Walsh Associate Professor of Neuro-Ophthalmology at the Wilmer Eye Institute, where she is the chief of the Wilmer Neuro-Ophthalmology Division. Her research interests include optic neuropathies, specifically optic neuritis and non-arthritic anti-ischemic optic neuropathies, high-value care, and the use of big data to answer neuro-ophthalmic questions. She also has a particular interest in medical education and serves as the Neuro-Ophthalmology Fellowship Director and Medical Student Educator at the Johns Hopkins. Dr. Amanda.
All right, thank you so much for that introduction, and thanks to the whole planning team here for having me at this conference. I'm going to try to share my screen here. Are you guys seeing my screen in full screen?
Yes. Yes.
Perfect. All right, so I will be starting with a case here. Credit for the title goes to my former fellow, Dr. Rita Busaid, who's much more creative than I am. All right, there we go. All right, so here's our case, a 63-year-old man with bilateral vision loss. He actually presented initially to one of our optometrists at the Wilmer Eye Institute. And so this is the history from that initial presentation. 4 months before presentation, he noted blurred vision in the right eye, and that then declined over a month after onset. And then 3 weeks prior to presentation, he experienced similar visual symptoms affecting the left eye this time. He had not had any recovery in either eye at the time of presentation. He denied any other symptoms that were specifically associated with the vision loss, at least from his perspective: no pain, no headache, no double vision. But he did unfortunately have a lot going on medically. He had pancreatic cancer, which was stage 4 with known metastases to his liver and his lung. He had had a splenic infarct for which he was on Eliquis afterward. He also had a long history of type 2 diabetes and obstructive sleep apnea and had previously been a smoker but quit 7 years prior to presentation. In terms of pertinent medications, he had been on a chemotherapy regimen, which you can see here, for his pancreatic cancer for about the 9 months prior to his presentation with the vision loss. So at that initial exam, his visual acuity was 2150, pinholing to 2050 in the right eye and 2020 in the left. He was noted to have a right relative afferent pupillary defect, and color vision was down in the right eye. The anterior segment looked normal, and the posterior exam showed a pale nerve on the right, and the nerve on the left was described as having raised borders with sharp vessels and a hemorrhage superiorly. His fields at that point, you can see here, and you can see in the right eye, he had some constriction, almost an altitudinal appearance with some constriction superiorly as well. And then the left eye, less specific, but certainly nasal and superior changes. You can see his retinal nerve fiber layer OCT, which shows thinning in the right eye and a little bit on the robust side in the left eye, measuring 118 on that side on average. So at this point, our optometrist actually ordered an MRI and additional laboratory testing, but unfortunately, due to his overall health situation and his treatment requirements at this point, the patient actually did not complete that testing until he then presented to our emergency department 2 months later due to continued decline in the vision. And so when he was seen by our team in the emergency department, his vision had unfortunately declined to counting fingers in the right eye and 20/80 pinholing to 20/60 in the left. He still had a right RAPD, colors were now down in both eyes, and both optic nerves were now noted to be pale. He did have OCTs done at this presentation, and you can see that there has been a change in terms of the retinal nerve fiber layer. Now both retinal nerve fiber layers are thin. There's no longer that robust appearance on the left. And this was his baseline ganglion cell measurement, a little bit artifactual, but probably some thinning on both sides. So at this point, thinking about a differential diagnosis, this patient has many risk factors for many different causes of optic neuropathy. And so given the history, there was an initial question of whether this could have been a bilateral sequential NAION. He did have multiple vascular risk factors in terms of the diabetes and the obstructive sleep apnea. It did look like there was some disc elevation around the time of vision loss in the left eye, although the continued decline of the vision in that right eye going back several months is a little bit less typical for NAION, though perhaps not impossible. Because of his other medical history, in terms of the stage 4 cancer, there were several issues we thought about in terms of optic neuropathies that might be in some way related to his cancer, whether it would be a direct metastatic effect from optic nerve infiltration, whether this could have been a paraneoplastic optic neuropathy, which was actually something of pretty high concern at this second presentation, or whether this could be an adverse event related to some of the treatment he was receiving for his cancer. And of course, I'll leave something else on this list as well. So at this point, the patient was admitted after he presented to the emergency department, and he underwent a significant workup for all of these conditions, as well as for some other potential conditions as per our neurology group. You can see here that his inflammatory markers were normal. He got some infectious and nutritional labs that were also normal. He had a paraneoplastic panel, which was unremarkable except for a very low titer anti-titin. It was actually just at the level of being detected and was really thought to be pretty non-specific in this case. In terms of his CSF, he did undergo a lumbar puncture, and the CSF was fairly benign, except he did have a slightly elevated protein, normal at our institution being 45, so slightly elevated. He got an MRI scan, and I'll show you a few pictures from the MRI scan here. On the left, you can see this T1-weighted post-contrast fat-saturated sequence, and so you can see that his optic nerves here do not have any enhancement. And you can see on the T2-weighted sequences, again, the orbits look relatively normal. These are just some representative images, but you'll have to believe me that through the whole MRI, there's no evidence of metastatic disease in terms of no enhancing lesions or new masses. So because of concern that this was in fact a paraneoplastic event, the patient was admitted and got 5 days of IV methylprednisolone, 1 gram per day. He had no improvement with that 5 days of treatment, and so then he received a course of IVIG, and unfortunately still did not have any improvement. At that point, he was discharged with outpatient follow-up, and that's actually when I met him in my clinic about a month after his discharge. His vision had continued to decline over this period of time, and he was counting fingers in both eyes at this point. Still did have a slight RAPD, and both discs were pale. Due to the poor vision, we got a Goldmann visual field in clinic, and you can see he has these inferior windows sort of remaining, but has both superior and central field defects as well as constriction inferiorly. His OCTs show continued thinning of the retinal nerve fiber layers and the ganglion cell layers in both eyes. And at this point, we talked a little bit more to him about his overall history. And it turned out, in terms of his family history, that he had a nephew who was the son of his sister, who had lost vision in a bilateral sequential nature when he was a teenager. And he also had a great niece who was the daughter of his sister's daughter, who had also lost vision in one of her eyes, though he didn't have as much information about exactly what the time course or evaluation of that workup had been. And the question was raised, and the patient actually was aware that there was some question about this having been a genetic sort of event. And so at this point, we sent off an optic atrophy panel to through GeneDx, one of the genetic testing companies here, and he was found to be positive for the mitochondrial mutation in 11778 affecting ND4, which is, as everyone here knows, one of actually the most common mutation causing Leber's hereditary optic neuropathy. So our next question was this just a somewhat atypical presentation of Leber's hereditary optic neuropathy, which we certainly can see outside the typical demographic of young men? Or was there some sort of tipping point in this case, perhaps related to his underlying treatment with chemotherapy, that could have caused his LHON vision loss to occur at this point in time? And I actually don't have an answer to that question. I'm not sure that we ever will for a single case like this. But in terms of thinking about potential mechanisms, how his treatment could have led to vision loss through a mitochondrial mechanism in a patient who was predisposed to that with this mutation, we can see here the chemotherapeutic agents he had been on, including 5-FU, irinotecan, oxaliplatin, and capecitabine. All of these drugs have some effect, on DNA, and particularly the platinum drugs, oxaliplatin being one of these, have been shown to increase free radicals and potentially, I think mechanistically, could have been a tipping point for someone predisposed to mitochondrial dysfunction, although that'll be a bit difficult to prove, I think. So in terms of take-home points, before we kind of open it up for discussion, I think this was a case of patients having more than one disease, and what initially looked like it might be a cancer-related issue did appear, in fact, to be an atypical presentation of Leber's hereditary optic neuropathy. And the thorough history was really a key to getting to that diagnosis. We certainly know that LHON can present outside the typical demographics of young males, and I think we actually see this pretty commonly when we remember to look, that LHON can present in older men. It certainly can present in older women, so it is something we have to keep on our differential when we see a case coming in with a clinical history of bilateral sequential vision loss, perhaps with this sort of robust nerve fiber layer at the onset. We know that environmental and toxic factors can appear as triggers in some cases of LHON. There are studies that have demonstrated that tobacco, as well as to a lesser degree alcohol, can certainly act as triggers for LHON. There are a few case reports of patients who have developed ethambutol toxicity that in the setting of an LHON mutation, and that appears to be a trigger in some of those cases. And it's unclear whether in this case the chemotherapeutic agent may have played a role, but I think it is something we're exploring more and more in terms of what may be the tipping point for individual patients with LHON. All right, so thank you all for listening to my case, and this is a picture of Baltimore where I am today, so I guess we can open it up for discussion.
Thank you, Dr. Amanda, for that wonderful case. I don't think we could have done better to that. You did a very methodical workup and explained all the possibilities, all permutations and combinations. And as you rightly said, we would have done the same way. We would have thought about as NAION, cancer-associated, optic neuropathy, and then, rule out everything and finally, think about the least common things. But it does tell us that we should always, revisit a diagnosis when we are not able to find the correct answer.
Great case, Dr. Amanda.
I just wanted to, Dr. Manish.
Yeah, please go on. Please go on, Nina.
Yeah, so you showed us serial OCT pictures, but unfortunately I missed out on that GCL picture from the first visit. I think if you had a GCL picture on that first visit, perhaps, because when the patient had presented to you, he was asymptomatic. I mean, he was probably in the evolving phase of LHON in the left eye. Probably a GCL thinning at that stage would have pointed out that this is probably a hereditary optic neuropathy, LHON, though it's a wild guess, but I'm just, retrospectively speculating it.
No, I agree that I agree. Unfortunately, he had seen one of our optometrists and no GCL had been obtained at that point in time. I completely agree that usually when patients with LHON come in, and in fact, sometimes we'll have patients with a family history of LHON come in and they haven't lost vision yet, it's a very typical pattern for the RNFL to look normal or a little thick and the GCL to already be very thin. So I completely agree with you. It's really a typical presentation that would clue us in, I think.
Yeah, also your visual fields were atypical too. You didn't get central scotomas, you got altitudinal defects. But on the Goldman, though, I noticed a spiraling of the visual field. That's quite typical of LHON. Wasn't there a centri, fugal pattern? The defects were going away from the center. Was it so?
So let me bring the Goldman back up here. See where it went. Sorry, guys. Here we go.
No, this one, the previous one, was it Goldman or it was not this
so
one?
This is the only Goldman we had. This was done in my clinic where we're able to do a Goldman. Before that, the patient had a Humphrey, which is this one up here. I agree that this Humphrey is really atypical, and actually, I would have said this probably can't be this probably can't be LHON because there's no central scotoma. I think what's a little confusing though is his vision, his acuity was certainly down. So I think he may have had he may have been trying really hard in this field and did a bit better than one might anticipate. Because you can see the fovea in the right eye was 35, which really doesn't agree with the fact that his acuity was down to 2150. So I think sometimes in patients who are trying to adapt to their vision loss, they work really hard on the visual field, and it's not always super reliable. This is a limitation. And I think the other issue here is this was, again, done before I met this patient, but this was a CETA faster protocol, so we don't have good reliability indices to really gauge how reliable this particular field was. But I agree, these fields do not look typical for LHON. When we go back to the Goldmans, so this is a 5-4E target. The only target he could see at this point, given that he was counting fingers, was the 5-4E. So he really just has these small inferior windows remaining. The central field is completely knocked out in these fields. So I think this is a bit more typical.
Yeah. So I think I agree with you. I think he always had the mutation, and that his history of smoking, and he was using I mean, he was on multiple chemotherapeutic drugs which could have added up the mutation level, and probably he manifested the disease. So I think and the history was very, because all the maternal relatives were having the disease, right?
Yes, all maternal
Yeah,
relatives.
yeah, so that's interestingly, we are just warming up to genetic evaluation in our patients. And I had recently had a 65-year-old lady who, after having done extensive workup for all optic neuropathies, turned out to have an NT-ND1 mutation, which was like a total surprise to me. But she was relieved when we told her that, yes, this is the reason for your optic atrophy and, your problem. So I think it's a very good case, and I really enjoyed reading about it.
Excellent. Thank you so
Thank
much.
you. Thank you, Dr. Amanda. And that's an excellent case and a lot of learning for all of us here. Thanks very much. And thanks, Nina, for that excellent.
Just a last comment. I mean, because I think in
Yeah.
India we still, thinking that LHON is a disease of young males, 20 to that age. But I guess if you read the latest updates on LHON, it says all demographic populations can be affected with LHON, especially women less than 5 years and above 45 are as risky to get LHON as males. So that is something we need to keep it in mind.
Yes, absolutely.
Absolutely.
Absolutely, Dr. Nina. Okay, thanks, Dr. Amanda.
Thank
and
you.
Thanks a lot.
Thank
and
you.
Thank you. So with that, we go to the last presentation of this today's session. I invite Dr. Zoe Williams, who is a professor of ophthalmology, neurology, and neurosurgery, and fellowship director and chief of Neuro-Ophthalmology service at Flama Institute, University of Rochester School of Medicine at New York. She is a chair of the Basic and Clinical Science course BCSE Section 5 of the Neuro-Ophthalmology Committee. She serves on the American Board of Ophthalmology Neuro-Ophthalmology Exam Development Committee for written and oral board certification. She is a section editor for the Neuro-Ophthalmology Virtual Education Library novel, and she's an associate editor for the Frontiers of Neurology. She has authored over 700 peer-reviewed publications and several book chapters. Dr. Zoe Williams, your case, please.
Okay, thank you so much for the kind invitation from Satya and the panel. Are you guys able to see my presentation in slideshow mode?
Yes, we are.
Okay, perfect. So my case is entitled Seronegative Everything. We're going to start off. This is a 28-year-old who presented to our emergency department with progressive bilateral vision loss over 4 days and mild pain with extraocular movement. He had been hospitalized at an outside hospital 2 weeks prior for blurred vision and imbalance. And it was a Saturday when he came in. We weren't able to actually get his imaging, but we could view the report. And he had a reportedly normal contrast MRI, brain orbit, cervical, and thoracic spine. He had cell-based MOGAD IgG and aquaportin 4 at the outside hospital, which were both negative. And he had a lumbar puncture, which showed a lymphocytosis with 58 nucleated cells, predominantly lymphocytes, and elevated CSF protein at 175. Oligoclonal bands were negative, but his myelin basic protein was elevated. Additional workup that he had previously, he had a negative paraneoplastic panel. He had a normal serum interleukin 2R, and he had negative HLA-B27, ANA, ANCA, Lyme, syphilis, and HIV screen. He reported he had improved with a 3-day course of IV Solu-Medrol in terms of both his imbalance and his vision, and he was discharged from the outside hospital without an oral prednisone taper at that time. He states his vision remained stable for about a week after improvement, and then he developed recurrent pain with eye movement and a decline in his vision bilaterally. He had no medical history, was not taking any medication, was a non-smoker who drank occasional alcohol. Family history showed no autoimmune disease, no multiple sclerosis. On review of systems, he reported some imbalance, urinary hesitancy, and his review of systems was negative for diplopia, weakness, numbness, tingling, nausea, vomiting, hiccups, fevers, unintentional weight loss, headache, or cognitive change. So on our exam, he was count fingers in both eyes with decreased color vision, 11 out of 12 solid color pages. His pupils were 3+ reactive with no APD, and the rest of his exam was completely normal. So optic disc showed no optic disc edema and no pallor. This is his Humphrey visual field with size 5 testing, which shows bilateral central scotomas. And so he was assessed as having a bilateral retrobulbar optic neuritis, atypical as it appears to be steroid dependent, and CSF pleocytosis. So we ordered a repeat MRI brain and orbits with contrast, MRI cervical, thoracic, and lumbar spine with contrast, repeated the lumbar puncture, and the plan was to start him on Solu-Medrol 1 gram for 5 days with consideration of Plex depending on his MRI results. So our MRI ended up being actually very similar to the outside MRI once we got those images. So he did have bilateral T2 hyperintensity of his optic nerves. And then he also had some longitudinally extensive enhancement, which extended through the intercanalicular portion intracranially and stopped short of the chiasm for both nerves. He also had bilateral enhancement of his 3rd nerve in the cisternal segment and of his 5th nerves, and this was also seen on the outside MRI. So he was treated with Solu-Medrol. He got 1 gram per 5 days, followed by prednisone 60 milligrams daily and plasma exchange. And by the end of the first week, his vision had improved to 2100 in the right eye and 20/30 in the left eye. He had repeat visual field testing, this time with the size 3 target, and had central cecocentral scotomas. So additional workup, we did a repeat cell-based assay for the MOGAD IgG and aquaportin 4, both of which were negative. He had a negative TB and sarcoid screen. He also had negative MRI of the cervical, thoracic, and lumbar spine. We did CT chest, abdomen, and pelvis, which showed no malignancy, no evidence of sarcoidosis or TB. He had a full PET MRI, which showed no hypermetabolic lymphadenopathy. Testicular ultrasound was negative, and his repeat lumbar puncture showed, again, a pleocytosis, although improved, now 24 nucleated cells, still predominantly lymphs. His total protein had decreased, but was still elevated at 77. He now had positive oligoclonal bands, and on cytology, he had lymphocytosis. His flow cytometry showed no malignant cells, and a paraneoplastic panel was negative. So at this point, we can stop and ask if anyone would order any additional testing.
Hi, Dr. Zoe. So I would think of LHON in this young male with a bilateral loss of vision with a normal looking disc with a secocentral field effects,
Yep,
serum
and I think
lactate and pyruvate and testing.
we've definitely seen a few cases this morning that definitely bring that up, that you should be thinking about this in that setting. I think his CSF pleocytosis goes against it for this case, but it's definitely good to consider it. And I agree with his presentation of his nerves and with that visual field, it would be on the differential. So I'll keep going if that's okay.
Yeah,
So he
please.
had a final diagnostic test, and this was a CSF MOG testing, which was tested via the live cell-based assay. and that did come back as highly positive with an immunoglobulin binding index of 39. Normal is less than 2.5, and his titer was 1 to 512, with the normal being less than 1 to 2. So he has seronegative CSF positive MOGAD. So after his plex, he underwent a slow prednisone taper. By a month out, he was at 2050 plus for his right eye, 2025. His peripapillary RNFL still looked good. He did have decrease of the GCC bilaterally. And then by 2 to 3 months, he'd improve to 2040 in the right eye, 2025 in the left. And you can see his visual field looks near normal now. So MOGAD, as everyone knows, is CNS demyelinating disease that's usually associated with a core clinical demyelinating event, and it occurs due to serum autoantibodies directed against myelin oligodendrocyte glycoprotein. It is a rare disease. It has no female predilection, and it can be monophasic or relapsing course. So the new diagnostic criteria that were proposed in 2023 do require fulfillment of A, B, and C. So a core clinical demyelinating event is A. And then for B, you do need a positive MOG IgG test. So that should be a cell-based assay for serum. And if it's a clear positive, then you're all set. You don't need any additional supporting features. But if it's a low positive, or it's a positive without a titer, or it's negative but CSF positive, then you do need supporting features. So that includes a negative testing for NMO and then at least one supporting clinical or MRI feature. So our patient did have bilateral simultaneous clinical involvement of optic neuritis, and he did have longitudinal optic nerve involvement on both sides. And then you need exclusion of a better diagnosis, including multiple sclerosis. So this study also reviewed the 3 studies that were included that evaluated both MOG IgG titers in paired serum and CSF samples. And it was found that about 40 to 60% of MOG IgG seropositive patients also had CSF positivity. So in general, there's a lower sensitivity of the MOG IgG testing in CSF versus serum. So they looked a little bit more closely at the 3 studies, and they found that of these 3 studies, in the first study, there were 3 of 80 patients. In the second study, 13 of 262 patients. And in the third study, 4 of 118 patients that were positive for MOG IgG in the CSF alone. And then they looked at the clinical presentation of these patients, and 100% of those 3, 69% of those 13, and 66% of the 3 of the 4 patients that had clinical information available showed clinical features that were consistent with MOGAD. So they concluded that CSF testing for MOG IgG can be used in select circumstances to support the diagnosis of MOGAD in MOG IgG seronegative patients if they have supporting clinical and MRI features. So this is basically the proposed approach to MOG antibody testing in clinical practice. So both the diagnostic criteria proposed in 2023 and this paper really emphasize you want to restrict testing to patients that have compatible presentations with MOGAD. Okay, so you really want to make sure that they do have a core clinical demyelinating event that could be from MOGAD before you test for this. And you want to make sure that they're atypical for MS. So if you have a patient that fulfills those criteria, then you want to start first with the serum testing for MOG antibody, and that should be a cell-based assay, and it will be live or fixed based on what the center's ability to perform is. I think most of the papers agree that live is slightly preferred over fixed because it may pick up about 10% more patients with a clearly positive result. So if that is negative, you sort of need to reassess do you still have a high index of suspicion for MOGAD? And then if you do, you want to kind of look at the timing of when the testing was done, whether this was at the time of an acute attack, which would be more likely to have a higher titer, and was it prior to immunotherapy, because that is known that will decrease titers. And you also want to, at that point, consider should we do CSF testing for a MOG antibody? And of note, in the CSF, it needs to be a live cell-based assay. So the fixed cell-based assay was found not to be sensitive. So then at that point, you can do the testing and then obviously see what the result is. But if it is again negative, then you really want to reconsider your diagnosis. So what to test? So again, serum is the preferred fluid to test. isolated CSF positivity really requires cautious interpretation. We know that overall the sensitivity of the serum MOG-IgG is higher than in the CSF. And isolated CSF MOG-IgG positivity in patients with presentations that are consistent with MOGAD range from 0 to 30%, again, limiting to testing only the live cell-based assay. And then isolated CSF MOG-IgG false positivity ranges have also been reported from 0 to 50%. So there are some cases in the literature of pneumococcal meningitis that had positive MOG titers in the CSF. So really should be limited to patients that are seronegative in whom you have a high index of suspicion for MOGAD. So my questions for the panel were, do you currently send CSF MOG-IgG in your seronegative cases if you have a high suspicion for MOGAD? And then why are some patients who are seronegative but CSF positive for MOGAD? Why does that happen if the MOG-IgG is actually peripherally generated? So there is in the literature some suggestion that maybe there's intrathecal synthesis of MOG-IgG as well. So maybe this is a different entity. Or maybe this could be treatment effects. So presumably if you had started treatment before your serum was drawn, you may potentially get a negative serum test, and perhaps from breakdown of the blood barrier, you might end up having a positive CSF test because now you haven't cleared that as quickly. It's totally hypothetical, but I'd be interested in other people's opinions on that. Is there a difference in visual or neurologic prognosis or relapse rate in seronegative CSF positive MOGAD? I think this one is really hard to answer. I mean, the literature says no, but if you look at how we're defining when you should test for MOG-IgG in the CSF, we're really emphasizing that it should be in a case that is clinically characteristic of MOGAD. So it's a bit circular in the reasoning in terms of would we end up finding out that this was a completely different phenotype if we're really limiting our testing only to patients that really look like MOGAD? And then finally, should the lumbar puncture be repeated in cases where you had just CSF positivity? Does persistent positivity in the CSF signify a higher rate of relapse akin to the persistent seropositivity? So I'd be interested for any thoughts from the panel or anyone else on the call.
Fantastic case, Dr. Zoe. Actually, we know that serum MOG antibody is more sensitive than CSF, but it's really an eye-opener as to when to evaluate, especially when you have everything negative, and how CSF MOG antibody can be a powerful tool in challenging cases like you've shown today. And I would also be keen to the other panelists to comment on your questions that you've kept here. And I would like to take your comment on other CSF analysis, especially the biomarker, CSF biomarkers like GFAP and NFL, the neurofilament light chain, in such cases where all the seromarkers are negative.
So to answer Dr. Zoe's first question, do we currently send CSF MOG-IgG? I would say no. From my center, no. So we simply call it as double seronegative, and we still treat it as optic neuritis. And if it recurs, probably a seronegative recurrent optic neuritis, something like that. So probably we should be sending more of CSF MOG after, as per this case. So other panelists also can add to this from our Indian perspective. What do we do? Anyone else?
Yes, sir. We also at SN also we are right now not doing CSF MOG in seronegative cases, but it will be good to look into this aspect as well.
Yes.
And one more question for the speaker and the other panelists. Like here in India, we have more access to fixed cell-based assay, and so is it a must that we look into the titers for MOG antibodies in such cases?
Yeah, so I think Mayo Clinic has published on that. So if you have a low positive titer, so if it's 1 to 20 or 1 to 40 for the titer, it's only got a 51% positive predictive value for MOGAD. Whereas if it is, 1 to 1,000, that's pretty much 100% positive predictive value. So I think it is really important if you do the fixed cell-based assay that a titer is sent so that we know the likelihood. I think we've all probably seen the low positive where something in the clinical presentation really didn't fit well with MOGAD, but then that came back and it kind of threw it a little bit into confusion as to whether to treat someone as MS or as MOGAD. So the titer is very important.
Dr. Zoe, would you like to answer Dr. Durga's questions on other CS of markers? What do you think about that?
Yeah. So I'm less well versed in all of these markers, but I can tell you in our patient, his free kappa light chain was actually markedly positive, which my understanding is that is much more common in MS. Obviously, this presentation in America is very uncommon to have a bilateral optic neuritis simultaneous from MS. It would be very uncommon. And also the appearance on the MRI, obviously uncommon. His bilateral cranial nerve enhancement also, that was completely asymptomatic. That has been reported in MOGAD. It's not that common, but it's believed to be that there is actually, because this occurs in the cisternal segment, this is actually, there's still central myelin there. So this is basically a targeting immune attack of the myelin there, causing the enhancement of the of the cranial nerves. And 3, 5 have been reported. Cranial nerve 7 and 8 have also been reported as showing enhancement. It can be completely clinically asymptomatic. So it's another thing that if you see, just to kind of think about MOGAD as well. Interestingly, his oligoclonal bands turned positive on our repeat lumbar puncture. They were not positive on the initial, but I know in MOGAD it's about 20% of patients will have positive oligoclonal bands. So I don't think that's completely differentiating. Did I answer all of the question I might not
What is
have?
your take on patient presenting post immunotherapy? Like maybe the patient might be seronegative. In that case, do you recommend CS of MOG antibodies to be done?
Yeah, so I think the recommendation is to either wait. So if they're already treated, especially with either Plex or IVIG, is to wait 3 months before you repeat. Unless they have a recurrent attack, then you could again repeat at that time. But if you just repeat, so if we had the negative and then you just repeat it again, it's less than 2% chance that you're gonna have had a false negative initially and just get a conversion. So you generally have to let the treatment clear before you retest, is my understanding.
So probably we should be, what will be the effect of, I know we have had papers on this that it doesn't really affect, but what do you think is the effect of steroid treated patients falsely testing negative for MOG? Does it really matter if we don't do it initially and do it later after the steroids?
I actually don't know how long you have to treat before you're going to get a false negative. In our case, this was obviously first treated in an outside hospital. The best I could tell from the records, he was checked for MOGAD and MO on his second day of hospital admission. I could not tell exactly when the IV steroid was started, but it was either that same day or possibly the day before, because it was a very short admission. So he only received 3 days and then was discharged. So it was definitely very close. So whether that would have been enough to make it seronegative, I'm not sure. I don't know if anyone has experience with actually studying this for timing of it, but I think it is important to realize if somebody was treated first that you might get a false negative. But then unfortunately, I believe the guideline is to wait 3 months to retest. And unless they have a repeat attack. So in this case, of course, it wasn't really a repeat attack. I think he just relapsed from a very short course of treatment with steroids.
But how could we explain the imbalance and absence of brain lesion or spine lesion in your patient, Dr. Zoe?
Yeah, so I can't explain that. I actually looked back at his outside hospital MRI, our MRI, reviewed it with neuroradiology, absolutely nothing. The only thing I can say is that on the neurologic exam, it was sort of a soft call. So he said he had imbalance, but he had sort of this wide base gait is all that they found. So they didn't find any true ataxia, at least at our hospital. It was documented that he had ataxia by the outside hospital, but there's no detail on it. So I'm not sure. I mean, everything looked completely fine in his brainstem and cerebellum on both scans. So hard to know.
Okay. So any other final questions?
Fantastic.
Any other panelists? Okay, if there are none, thanks very much, Dr. Zoe Williams, for the excellent case.
Thank you so much.
Thanks, Durga, for the discussion. So with that, we come to the end of the last session. Back to Satya. Back to Satya.
Yes, thank you, Mahesh and Shikha, for co-hosting the session wonderfully, and for all the speakers for their exciting cases. And we call it the end of day today, and let's hope to see everyone tomorrow for more challenging cases in the eFriend session tomorrow evening, IST 4:30 p.m. Thank you. Bye-bye.